Hello, guys. Are we on break? Hello? Hey.
Okay. Yes, we're on break.
When do we come back? When are we coming back, please? Do you know?
We don't know. I was just waiting for a teacher to show up. Probably 8:15.
Okay, thank you.
No problem.
Yes, sir. Yeah, the right spot. Yeah, yeah. Well, this is the- Let them know I'm saying. Follow the knees. Party's over. All right, good morning. Oh, I need to put this on once. All right, so welcome. Since you've had a very interesting first week, exciting first week with biochemistry, want to change it up, change the pace and do something a little more boring, right? So oncology, so there's cancers, right? So we're going to talk about all the different cancers, head to toe, and connected with some concepts, but a lot of facts, right? So most of your questions in oncology are going to be more fact-based. So, you know, what do you see, where do you see, who do you see, what do you do? A little bit of treatment too. Okay, so what is cancer, right? It is cells that are out of control, right? Normally, in our body, as cells go through the cell cycle, growth, right? There are certain things, or let's say so-called policemen, that make sure that they stay on track. They don't go out of control, right? So what would be an example for that? One checkpoint that we always, refer to default to. P53, right? It makes sure that it doesn't go out of control. Similarly, RB, right? So that's another one. So all these, there are some checkpoints that make sure they all are organized. Cell division is organized. They don't go out of control and they stay within that organ and everything is good. Sometimes these checkpoint inhibitors don't work, or there are also genes that are called proto-oncogenes, right? These are necessary for normal growth, but when they get mutated, they become oncogenes, right? Your KRAS, for example, right? An oncogene. So cancer can result either because of an inactive tumor suppressor gene. So P53 is a tumor suppressor gene, right? If that doesn't work, cell division keeps going. Or an oncogene or proto-oncogene becoming an oncogene, now that also increases cell division, right? So two ways a cancer can develop, okay? So now the initial signal or stimulus for this to happen is what? Stress, right? When cells are stressed, initially they undergo a few changes, right? So you're starting for your assembly and you get stressed. What do? I mean, hopefully nobody does the first part, they give up, right? So I don't want to do this anymore, right? Anyone thought that? Yeah, I have to, right? So that's the first thought that comes to mind. No, you know what? I can do that. I don't want to do this anymore. So that's what the cells do too. They undergo atrophy. So that's decrease protein synthesis, it decreases cell size, and then they just kind of shrink. Okay. What's another thing that you're going to do when you're studying? You're going to say, okay, I'm going to find some friends who are studying too, right? And I'm trying to study with them, right? So hyperplasia. So what happens when the cells are stressed? They undergo hyperplasia, hyperplastic changes, they increase in cell number, right? And this usually happens in a gland. So adrenal gland, if it's stimulated, what's going to happen? The adrenal hyperplasia. So more number of cells. Third thing, what you're going to have to do. When it comes to PASS program, you're going to pick up those big heavy books and, get your brain all full with all this material, right? So cells undergo hypertrophy, right? That's a third thing that happens. So atrophy, hyperplasia, and hypertrophy. Hypertrophy usually happens mostly due to resistance, right? Or another type of stress. For example, what's the most common example for a cell or a tissue undergoing hypertrophy in stress? A common example. Oh, no, not then. That's atrophy, actually. When you remove the cast, what does the muscle look like? It shrinks, so it's atrophy. That's atrophy. Heart, exactly. What's the cause? What's the threat there? Hypertension, exactly. Right? Somebody who has chronic hypertension, what happens to the work of the heart? Increases. Eventually, what's going to happen to the heart muscle? People hypertrophy. So that's why it's important to control blood pressure, because eventually hypertrophy, if you don't control it, what's the next stage after that? It becomes dilated. When it becomes dilated, it's irreversible at that stage. Hypertrophy is still reversible. So that's why we want to kind of control the blood pressure so we don't get to that stage. Okay, so that's hypertrophy. Similarly, breast, prostate, uterus. These tissues, they undergo both. They can undergo some hyperplasia and they undergo some hypertrophy, right? So both can happen in the breast, in the uterus, and even in the prostate. When you say BPH, right? So it used to be called hypertrophy, then it became hyperplasia. Why? Because there's a little of both happening in the prostate. Okay, so that's the first stage, or first thing that happens when a cell is stressed. Now, if it continues to be stressed, then what happens? Now it undergoes a few other changes. It can either become anaplastic, it can undergo metaplasia, or dysplasia. So these are now different kinds of changes that happen if you continue to stress that cell. Okay, so for example, when you smoke, first step will be it undergoes some metaplasia, right? Then it becomes dysplasia, then it becomes anaplasia. So that's the kind of how it goes through. The first stage will be metaplasia. Why? What is metaplasia? That's switching of the cell type. What's dysplasia? It's uncontrolled growth now. And then anaplasia, it's late stage, right? So let's look at each of these. Anaplasia. Anaplasia is the worst form, right? Why? Because there's lots of cells being produced. Now, all these cells are immature, right? Initially, it goes back to its immature state or back to the mesenchymal origin, and they become rapidly dividing. So all these cells, the new cells being made, they become rapidly dividing, and then what happens? That's why they don't need any maturation time, and this is the most aggressive, which also means these cells will metastasize often, right? That's why it's the worst form of cancer. So anytime you have an anaplastic, the cancer reaches the anaplastic stage, prognosis is very bad, right? The only way to treat anaplastic is, I shouldn't say the only way, but they are sensitive to radiation and chemotherapy, right? Chemotherapy, all these drugs. What are we trying to do with all these chemo drugs? Stop cell division, right? But at different stages of cell division, we can kind of intervene and stop that from happening. Okay, that's what all these chemo drugs do. What does radiation do? Similarly, radiation kills cells two ways, right? What's one way radiation can kill the cell? Breaks the membrane, and then what happens?
DNA.
Free radical. And yes, correct. So two things. One is it causes breaks, so DNA breaks, right? And it also induces free radicals. So this radiation generates free radicals. And we know that free radicals are actually bad to the cells. So these free radicals can stop the cell division, and it can also cause DNA breaks during replication, and therefore inhibit it from replicating further. Okay, so that's anaplastic changes. The metaplasia, we said, is switching, replacement of one cell type to another cell type. But why does this happen? Because when the body or cell is stressed, they want to undergo some changes to resist that stress, right? We talked earlier about smoking, right? That's one thing that happens in the bronchi. So what's the change that happens? What's the normal epithelium there? In the airway. Well, it starts out as columnar, and as you grow lower into the alveoli, it becomes squamous in the alveoli, but starts out as columnar, right? So smoking, what happens? What does this columnar become? Squamous, right? So that's the metaplastic change that happens in the lung. Then similarly in the cervix, right? Cervical cancer, HPV. So it can also happen due to irritation, right? So even in the cervix, the early part of the cervix, the endocervix, the epithelium is still columnar. Here too, HPV. What kind of cancer does HPV cause? It will be squamous because they undergo squamous changes. Okay. Third place that we commonly talk about metaplasia more often, where is that? In the esophagus, right? From chronic GERD. What's the epithelium there? What's the metaplasia? It's the opposite. It goes from squamous to columnar. Because now all that acid, columnar cells line the stomach too, right? So therefore they can resist acid better. Squamous becomes columnar. So anytime you have this metaplastic change happening, now we have to keep an eye, right? Because what's the next thing that can happen? Dysplasia. So we want to kind of make sure that we are monitoring this person to catch them before it becomes complete neoplasia. So that's why we have, when you have Barrett's esophagus, that's your metaplastic change, that's what it's called, right? What do we have to do then at that point? How do we screen them? How do you keep track of them? How do you monitor them? Screening with endoscopy, right? So once you have developed Barrett's, now it means that it can undergo dysplasia. So we have to monitor them with endoscopy, not every year, but at least every few years to make sure that it's not changing. Similarly, why do we do pap smear? Same reason, right? We want to make sure that if there is any change that's happening, we catch it early enough so that we can do something about it. Because dysplasia, early dysplasia, metaplasia, these are reversible. Okay, late dysplasia, when it comes into like carcinoma in situ, in that stage and later, it becomes irreversible. So the earlier you catch it, the better prognosis. Okay, so that's metaplasia. Now there is another change that can happen when you have something growing, when you have a tumor growing in your tissue, right? The body, when you have an infection or when you have some insult, an injury, what does the body do? You have the immune system that's activated, right? And they try to heal that or wall off that area. So initially, these when there is a growth, desmoplasia is a response the body does, like it treats that mass as a wound in a way, right? And it lays collagen and fibrous tissue around it, kind of like encasing it. That change is desmoplasia. Okay, so that's sometimes you see that also with these cells. Now, we said if it's metaplasia, you stress that cell continuously, now it becomes dysplastic, right? So what's dysplasia? Loss of cell-to-cell contact inhibition. So how does a tissue or a gland or whatever a structure we're talking about know when to stop dividing, the cells to stop dividing? When they touch each other. So because you have an architecture, right? You have a basement membrane. So within that, they're going to divide. And when they start to touch each other, a nicely packed is going to stop. Dysplasia means even when they touch each other, it doesn't stop. So what's going to happen? They're going to start climbing on top of each other. So it loses that organized pattern within the cell. Loss of inhibition cells begin to crawl on top of each other. And this is the first stage of cancer. But this stage is still reversible. This is still early on. Carcinoma in situ or CIS, from that point on, now it's kind of like into a late stage and it becomes irreversible. No, carcinoma in situ is still localized. What does it mean by in situ? It means it hasn't broken through the basement membrane. So it's still contained to where it actually began. No metastasized, whether it's local or distant. No mets yet. It's still within that organ itself, the primary gland itself. It hasn't broken through the basement membrane. However, there's still lots of cells. So when you talk about cancer, we talk about increased nuclear cytoplasmic ratio, right? Because now there are more cells. So all that is seen, but it's still confined to that organ. Okay, and that's also why prognosis is good if you catch them at this stage. Exactly why we do all this screening, whether it's colonoscopy, whether it's pap smear, whether it's mammogram, whether it's endoscopy. We do all the screening to make sure that we at least catch that tumor at that stage. Okay, good so far? Now I continue to stress the cell again. This plastic, but I'm going to give, they're going to get stressed further. It becomes a neoplasm, right? Neoplasm by itself are not all malignant. They could be benign or malignant, right? What's the difference between a benign and a malignant neoplasm? Benign, they're usually well circumscribed. They have a capsule. They kind of stay localized. They are mobile. It will not break through the basement membrane, break through the capsule. It will not outgrow its blood supply, and they do not metastasize. And they follow some normal physiology. So, well, it's a common example of a benign mass that follows physiology, and that usually helps us identify what the mass is. What kind of mass are we talking about here? A benign, freely mobile. That's a clue. Lipoma, sure, okay. Yeah, fibroadenoma, right? Fibroadenoma, what if a female presents with a mass that's mobile in the breast, what's one of the questions that we're going to ask them? Does it hurt? Yes. What else? How does it change with menses? Why? So that's your main physio point, right? Because if it's a fibroadenoma, is it estrogen or progesterone dependent? Estrogen dependent, right? So when you ask them about the menstrual cycle, which part is estrogen in the menstrual cycle? The first part or the second part? The first part, right? The first 10 days is estrogen, and the last 14 days is progesterone. So when you ask the question, you always ask, do you see any association with the menstrual cycle? And if it does it get larger during the first part of the first few days of menstrual cycle? Because if it gets larger during the last part, which is progesterone dependent, that could be a fibrocystic disease, right? So you have fibroadenoma and you have fibrocystic disease. Fibroadenoma is estrogen dependent, can enlarge during the first part of the menstrual cycle. Fibrocystic disease is progesterone dependent, that enlarges during the second part of the cycle. So that could also be a clue in a question when you're talking about the mass, and they say it changes, varies with the menstrual cycle, whether it's early or late. You can point to a diagnosis. Okay, so that's a fibroadenoma. Malignant, now all bets are off, right? None of this matters. They're not going to follow any physiology. They're going to be on their own. They can aggressively grow. They can grow locally. They can go to different further out as mats. They need more blood. They're going to pull blood from all your other tissue. So that's why you get emaciated. That's a malignant neoplasm at that stage, right? So benign follows physio, malignant just does whatever it wants to do. Okay, so when a malignant neoplasm, now we know malignant means they are rapidly divided, right? So what do rapidly divided cells need? Blood supply, right? Because what comes in blood? Nutrients, ATP. They need a lot of blood. So first, what do? They pull this blood from all your other organs and kind of takes it to itself to grow. It also makes angiogenesis. right? What's the function of angiogenin? Angiogenesis. So these tumor cells also make their own angiogenin to make these blood vessels, right? But these new vessels are not like our regular vessels. So these are thin and they are fragile. So that's why anytime you see blood, especially in an older person, blood, either through the lung, so spitting blood, vomiting blood, pooping blood, peeing blood, what do we always rule out? We also always have to rule out cancer because these vessels frequently bleed. And because of that, when you have an older person presenting with anemia, that's also a reason why you want to check for cancer, any cancer, right? So anemia or bleeding, always rule out cancer because these vessels that are made by angiogenin, they break down easy. Okay. Now that's one part. I need blood. I'm going to make angiogenin. I'm going to make blood vessels. They're also selfish, right? What are these malignant neoplasms? We also know that they metastasize. But these mets, generally, when compared to the primary cancer, they are smaller, right? Why are they small? Why don't they also grow as aggressively as your primary cancer? That's because of endostatin. Endostatin is the opposite of angiogenin. Endostatin means it prevents blood from going to these other cells. So even if you have mets somewhere else, they remain kind of small, right? As long as the primary tumor is making endostatin, the secondary tumor is not going to get much blood, so it'll stay put. But let's say that you leave the mets there and you remove the primary tumor now. What's going to happen to that secondary tumor? It's going to start growing. So that's why most of the time, if you have a really aggressive cancer, really malignant cancer, it's already metastasized, generally we don't remove it, right? If it's really aggressive, really malignant, late stage, we don't, and metastasized, we don't generally remove it. Why? Because if you do remove it, the other secondary masses can begin to grow now. Now, obviously, there's exceptions to this, depending upon symptomatic relief. If there's something that's causing obstructive symptoms, something like that, then obviously remove it. But most of the time, we don't for that reason, right? When it's really aggressive and it's late stage. Okay, so those two things that are made by cancer cells. And endostatin actually is being studied now as cancer therapy treatment, because if it stops blood flow or inhibits blood, then obviously we can use it as for a therapeutic drug, right? So those are two things that are made by these cancer cells, angiogenin and endostatin. Right. So when can we see that mass? So most of the time, we don't really know when the cancer started, right? We catch it when the patient presents with symptoms, usually. But when did it start? We don't know. But when can we actually see that mass? When there are 1 billion cells. That's when we can actually palpate it. So which means that when we're treating this mass of cancer, how many cells do we have to kill to induce remission? At least 1 billion cells. Now, let's say we kill those 1 billion cells. How long does it usually take for this 1 billion cells to reassemble, come back together? It takes about 5 years, right? So that's when we talk about cancer mortality prognosis. They always talk about 5-year mortality, right? Why 5-year mortality? Because that's how long it takes for these cells to reassemble. So for 1 billion cells to reassemble. Okay, so that's some basic things about cancers. Now, we talk about mets, right? When the mass, the primary mass, outgrows its blood supply, it needs more blood. So where would it go? Looking for blood. The most vascular areas. What part of the body is most vascular? There's always, there's well vascularized. Brain, right? Because you're always thinking, maybe not early in the morning, but for the most part, or when you're in class, but otherwise, brain, right? Lots of blood there. So that's where it goes first. Then, where do you have a lot of blood? Lungs. Lungs, because why? You need oxygen. So where does all the blood go? Pick up that oxygen. The lungs. So then it goes to lungs. So generally, also you think about What are other areas where there is always a lot of blood? Any area that is rapidly dividing. So what's on place where the cells are always dividing? Bone, right? That's where it goes next. Then it goes to the liver, then it goes to the adrenal, and then finally to the pericardium. So there too, in that sac, there is some blood. So in that order, actually, that's the order that meds are actually going to most of the time. Brain, lungs, bone, liver, adrenal, and then pericardium. Okay, so that's where they go. So now, naming. To name a tumor, but especially it's a benign one, first name is the cell type, the first part of the name. And when you add an oma to the end, that's a benign, right? So let's say if you have a mass on the skin, how do you name it? Skinoma. Fibroma of a bone. Osteoma, right? So you add the primary part is a cell type. The second part of the name is an oma. So when you see an oma with that cell type, that's a benign mass. Fibroadenoma, right? If it's gland, it's adenoma. Any gland, adenoma, right? Adenoma, fibroma, osteoma, those are all benign masses. Now, there are some exceptions, but those are the common ones. So it's a cancer. It's the same thing. The first part is still the same, cell type. The second part, depending upon where it originates from, if it's epithelium, if it's carcinoma, and if it's connective tissue, sarcoma, right? Osteosarcoma. Osteoma is benign, osteosarcoma is malignant, right? Then carcinoma is also malignant if it's only epithelium. So now we're going to actually, oh, before that, there are some omas that don't follow this, exception to that rule, right? Two of them here, hamartoma and choristoma. Hamartomas are the most common benign masses anywhere, right? What's a hamartoma? Abnormal growth of normal tissue, normal location. So it's where it's supposed to be, but it's just overgrowing. What's an example for that? Lipoma. Okay, I mean, not in the slip, because that could be anywhere in the sense. Polyps, yes, polyps, keloids, right? Those are normal tissue, normal location, but too much. Whereas hamartoma is a normal tissue, but an abnormal location. So you have, a growth that's somewhere in your body, that cell type is there, but it's where it's not supposed to be. The most common example for a choristoma is something that's not supposed to be there, but it's there. Meckles, somebody said Meckles, right? What kind of tissue in Meckles? Yeah, so what's the most common abnormal cell type you see in Meckles? From what gland, what tissue? Pancreatic or gastric, right? So pancreatic or gastric tissue is seen commonly in the Meckel's diverticulum, right? So that's normal cells, normal tissue, but an abnormal location. What's another common one, especially in females? Endometriosis, right? Endometrial cells can be present in the ovary, could be on your tubes, could be in the even in the peritoneum, right? So again, abnormal location of normal cells in a place it shouldn't be. So those are two exceptions. You have a question? Was there a question? Yes, Bryce?
Yes, I'm gonna go back a little bit. When you talked about dysplasia, you said that it's reversible. So
yes.
So it means like so normally we should not. So if the stress stops, the cell will go back to the normal state.
Correct. So you have to stop the stress. It can go back. Early dysplasia, not late, early dysplasia.
Okay.
So that's why in early dysplasia, we don't do any treatment per se. We just monitor them mainly to kind of, stop the stress and then monitor them to make sure that they don't go any further.
Okay.
Anything else?
No.
All right.
Thank you.
Sure. Now, these are exceptions to the rule too. These omas could be benign or could be malignant. So that's why they are grouped together. Seminoma, lymphoma, teratoma, especially the immature one, those are malignant. Mesothelioma, retinoblastoma, neuroblastoma, and melanoma. So these are, although they follow the benign naming rule, these are exceptions because these could be malignant. Okay. Now let's talk about one organ at a time. Okay. So we're going to have anything benign, adenoma, malignant, carcinoma, right? So by the end of the day, you're going to be so fed up of hearing adenoma and carcinoma because unfortunately, I have to say that for every organ, right? So when it's adenoma, and then it's carcinoma. So let's start with the brain. Most common intracranial tumor, right? Intracranial means it could be from the brain itself or it could also be from the meninges, right? Most common intracranial tumor is meningioma. So these arise from your meninges that cover the brain. And because it's outside, it's got a pretty decent prognosis because you can go in and take it out. If needed, you can actually resect it without going into the brain, right? But symptomatically, because it is a growth that's within a confined space, what can it do to the brain? It can push on the brain. It can displace the brain because there's not too much room within the skull for it to move around. So you can push on it and cause symptoms based on where it is and what part of the brain is affected. Okay. Now, a clue for a meningioma in a biopsy is the cells that we see in it, right? So what do we see in a meningioma when you do a biopsy and look under the microscope? Some bodies, right? What are some bodies? So when cells die, what happens to them? No, they calcify. So these are basically those cells that are dying and they're calcifying, but they calcify in a specific pattern, and those are called Samoma bodies. And generally, they look kind of like, you might have seen these pictures. They kind of look like this, right? Samoma bodies. Okay. Now, Samoma body doesn't always mean a meningioma. Samoma bodies can also be seen in a couple of other tumors. What are they? Papillary carcinoma of the thyroid, serous cyst adenocarcinoma of the ovaries, a meningioma, and a mesothelioma, right? So if you see Samoma bodies, it could be any of these. Okay. Meningiomas are also seen in a neurocutaneous syndrome, neurofibromatosis type 2. We're going to talk about it a little later, but in neurofibromatosis type 2, we can also see meningiomas. Okay, so meningiomas, most common intracranial tumor. Now, overall, what's the most common tumor in any organ? Most common in any, so it has to be one answer for all of them, right? Mets, right? So most common tumor in any organ is always going to be Mets. So what's the most common tumor in the brain? It's Mets. But what most common primary tumor of the brain? Now that'll be different because primary means it's originating from that organ itself. So whether it's liver, whether it's kidneys, pancreas, brain, doesn't matter. When it's a primary, then it's of that particular tissue. But overall, just most common tumor is always going to be Mets. Okay, so primary versus just most common. Most common primary, just like we're saying, most common primary brain tumor. Now it's coming from the brain itself. What would that be? Astrocytoma. That's most common primary brain tumor. Astrocytoma, what do they arise from? Astrocytes, right? These are your cells, glial cells in the brain. So these are cells that cover your nerves. They're glial cells, and then they arise from that. And there are different types, and there's different stages of astrocytoma. What are some examples? A glioma. Glioma is usually seen on like nerves. So we have something called an optic glioma, right? Also seen in neurofibromatosis. So that'd be an example for a glioma, an optic glioma. So that's on the optic nerve. So they usually present with symptoms related to vision. Okay. oligodendroglioma. Oligodendrocytes, what do? Myelinate the central nervous system, right? Oligodendrocytes myelinate central nervous system. What does the peripheral? Schwann cells does the peripheral nervous system. Okay, so oligodendroglioma are oligodendrocytes. So these are tumors arising from oligodendrocytes. Okay, so they usually affect the cerebral cortex commonly. So which means they're going to present with, if it's a cerebral cortex that's affected, what will be a symptom of that? Personality changes, right? Along with some focal neurological deficit. So depending upon what part is affected, they can have some focal neurological deficits or definitely personality changes. Okay, oligodendroglioma. Now, in a biopsy, how do you know it's oligodendroglioma? What do you see in a biopsy specimen? They give you the characteristic fried egg appearance. So basically, you have a nucleus with a clearing around it. Okay, and what's the other thing you see? The vessels become thin. So these are clues for oligodendroglioma. Fried egg appearing cell. So a nucleus, a small cells with a nucleus in the middle and a clear cytoplasm around it. So that's a fried egg appearance. And the vessels become very thin and fragile, and that's why your chicken wire capillaries. And obviously, you're going to see some calcifications also. So if you see all these together with some symptoms like neurological symptoms or even personality changes, oligodendroglioma. Okay. The third is ependymoma. Ependymal cells. Where do we see the ependymal cells? They line the ventricles, right? Ventricles are through where CSF flows. So you have two lateral ventricles. From there, it goes to the third ventricle, fourth ventricle, and then you do this subarachnoid space. That's how CSF flows. But there are foramens between each of these. From the two lateral to the third, it's foramen of Monroe. Okay, so that's what the CSF flows through. Between the third to fourth, it's aqueduct of Sylvius or cerebral aqueduct. And then from the fourth ventricle, you have two Luschka on both sides, and then a Magendie. Okay, so those are the different foramens. From the lateral ventricle to the third ventricle, foramen of Monroe. From the third to the fourth, aqueduct of Sylvius. From the fourth, you have three foramens, two laterally Luschka, and then one magenta to the subarachnoid space, and that's normal for CSF. Which means if you have a mass anywhere, if any of these foramens are occluded, what's going to happen? Just back up, right? What's it called the condition? Hydrocephalus, right? So you're going to head's going to enlarge, hydrocephalus. Now, hydrocephalus, there are two types of hydrocephalus. What are two types? Communicating and non-communicating. So if you have a mass that's occluding, for example, ependymoma, it lines the fourth ventricle. If you have a mass that's actually growing into the ventricle, it's going to obstruct the flow of CSF. It's an obstructive lesion. It can lead to non-communicating hydrocephalus. So if you have hydrocephalus, what happens to intracranial pressure? Increases. On physical exam, what do you see? Papilledema. So these patients on exam will have papilledema, right? Because your ICP is high. Reason? There's backflow to CSF. So any mass in or around this that can cause obstruction to the flow of CSF can lead to non-communicating hydrocephalus. Communicating hydrocephalus is when there is increased production, increase in vessels of CSF. So we have making more, then that's more communicating. Yes, question? Shri?
Yes, can you explain the difference between communicating and non-communicating hydrocephalus?
Sure. Communicating basically means the CSF continues to flow normally. There is no blockage to the flow of CSF. It's just that there is too much CSF. So in conditions where, what could be a reason why there's too much CSF? Give me a diagnosis. Excessive vitamin A, hypervitaminosis A, right? They get pseudotumor. That'd be a condition where you have too much CSF. So that would be a communicating hydrocephalus because it's normal flow, but it's just that there is too much. But in an ependymoma, or we're going to talk about another condition, a craniopharyngioma, right? So anything that's around it, pinealoma sometimes. So these are structures that are near these foramen. As they enlarge, they can occlude one of these foramen and then lead to what you call backup of CSF, and that's non-communicating because the foramens or the different ventricles are not communicating to each other. So basically that's what it means. It doesn't go from the lateral ventricle to the third ventricle, or it doesn't go from the third to the fourth ventricle, depending upon which foramen is blocked. That's non-communicating. Is that clear?
Thank you so much.
Sure. All right, so ependymoma. Now in ependymoma, what else would you see on a biopsy? Here, the histological finding is perivascular pseudo rosette. So basically you have a blood vessel and you have these cells that are arranged around it like a flower, right? So perivascular pseudo rosette. So you will see a blood vessel with these cells arranged around it like a flower, basically. So that's ependymoma. So the clues, what are the clues for ependymoma? Perivascular pseudo rosette, okay. Yes, so cells lined up the mass in the fourth ventricle. Another one, hydrocephalus, papilledema, right? All of these will point towards an ependymoma as a cause or as a mass. So these are astrocytomas. Okay. We'll come back to that. Now, this astrocytoma itself, some of that are dangerous, right? Yes, question? Where does meningioma come from? The meninges. That's not part of the brain. Right? So it's a primary brain tumor. It has to come from the brain itself. Most common intracranial is meningioma because it comes from the meninges. Okay. Right. So an astrocytoma, that's a grade 4. Cancer, we stage and we grade, right? A grade and 4 is the most aggressive, most severe form of these cancers. So a grade 4 astrocytoma is called glioblastoma multiforme. Okay, so that again has a poor prognosis. Now the clue for this is it's bilateral, right? So when we do a CT scan here, when you do an image on a CT, what you're going to see? A butterfly appearance. Why? Because it's bilateral, you're going to see on both sides. The wings of the butterfly, you see on both sides. So that's a glioblastoma. Along with that, on histology, there's another clue for this. Histology, what you're going to see. Pseudo-palisading, pleomorphic cells arranged or around a central area of necrosis. So you'll have a necrotic center, and then you have these cells that are arranged around it, pseudopalisading, so maybe in a kind of like a line. Or the other way they describe this is as a garland. Okay. So again, two clues. So both of these masses, the questions most of on these tumors would either be diagnostic, meaning it said what are they, what is it made of, what's the cell type, or what are you going to see, or they give you what they see and ask you what it is. So that's why these findings are important to identify in a question. So pseudopalisading pleomorphic cells arranged around a central area of necrosis or a garland-like arrangement. That points to glioblastoma. And then, on a CT, you can also see that butterfly appearance. Now, astrocytoma can also be seen in kids, but they've got a different name. Okay? In kids, it's called a pilocytic astrocytoma. How else is different from adults? It's a location. Okay. A pilocytic astrocytoma is seen in the posterior fossa. So what are the structures in the posterior fossa? The brain, cerebellum, and basically brain stem. So pons, medulla, cerebellum, they're all in the posterior fossa, right? Pilocytic astrocytoma is a posterior fossa tumor. So if you have a location in a kid, it's posterior fossa tumor, it's pilocytic astrocytoma. Now, however, what's the most common malignant tumor in a kid? In children? Which one? Not neuroblastoma, medulloblastoma. Okay, the most common malignant tumor in a kid is a medulloblastoma. Now, medulloblastoma, where does it originate from? Cerebellum, actually, cerebellum, right? So that's also a posterior fossa tumor. So when you have a posterior fossa tumor in a kid, there's only two diagnoses, right? It could be a medulloblastoma or it could be a pilocytic astrocytoma. Okay. So now we'll talk about medulloblastoma as to how do you differentiate between the two. So both of them are present in the same location. Now we talked about some neurocutaneous syndromes like meningioma and glioma, right? Meningioma and glioma are seen in neurofibromatosis. Okay. So what are these neurocutaneous syndromes? All of these have some intellectual issues, seizures, and calcifications, along with obviously skin lesions, cutaneous findings, and tumors. So seizures are due to brain involvement, right? What most common manifestation of increased ICP is what? Could be a seizure, right? Any brain issue, one of the first things that you can see is a seizure, right? So all of them have some cutaneous findings. All of them have some brain tumors. All of them have present with seizures, calcification, and some intellectual difficulties. Okay, so those are neurocutaneous syndrome. So what are the most common neurocutaneous syndrome that can be tested? Neurofibromatosis. Now, what do you see in neurofibromatosis? Hyperpigmented macules, because it could be hyper or hypo. So differential for hyperpigmented macules is neurofibromatosis and McKeown-Albright syndrome. So these are the two for hyperpigmented. If it's hypopigmented, then it is tuberous sclerosis, right? So those the rashes or those lesions also help identify neurofibromatosis versus tuberous sclerosis. Yes, Marbell, question.
So the hyperpigmentation is seen in neurofibromatosis and which one again?
This one, the next slide. McKeown-Albright.
Okay, okay, Mark, okay.
Right? Yeah, we're going to talk about that.
Okay.
We'll talk about that too coming up. All right, so now cafe au lait spots seen in neurofibromatosis. Type 1 and type 2. There are two types. More of these are seen in type 1. In type 2, there might be a few, very few these macules. There are macules, but very few, but type 1 has a lot more. Now in type 1, you're going to see a few other things. It's type 1 versus type 2. Now, type 2, we said, what's a brain tumor we see in type 2? I said it twice. What's a brain tumor we see in type 2? No, schwannoma. Meningioma. In type 2, you'll see some cafe au lait spots with meningiomas. And yeah, somebody said schwannomas, which is also correct, but bilateral. So schwannomas can occur unilateral too, could be on just one side. But here, neurofibromatosis, you have bilateral schwannomas. Marbel, you have a question?
I'm sorry.
Plus a few rashes, few spots, cafe au lait spots, right? If the schwannoma, right? Where do we see the schwannoma? What nerve is affected? 8th cranial nerve. What does it do? Hearing, right? So if you have a bilateral schwannoma, what will be their presentation like? Vertigo, tinnitus, and deafness. So that triad of vertigo, ringing in the ears, tinnitus, and deafness. So that indicates a schwannoma. Now this will be bilateral. If it's unilateral, it's a tumor it could be a schwannoma by itself, right? Not associated with neurofibromatosis. So if it is associated with neurofibromatosis, it has to be bilateral. Neurofibromatosis type 2, you can see bilateral schwannomas on both sides. Okay. All right. How about in type 1? You see a lot of cafe au lait spots. What else? Oops. Axillary freckling. Leash nodules. Gliomas. And pheochromocytoma. Those are your type 1 associations. So depending upon which ones do you see, it could be a type 1 or type 2. Yes.
Sorry, type 1.
More. Yeah, type 1 has predominant cafe au lait. Literally, I mean, 10 to 15 to hundreds. The whole body can be full of these vacuoles too. Okay, cafe au lait spots. So many. Type 2, few. So axillary freckling, leash nodules. So those are pigment deposits in the eye, melanin deposits in the eye. So you'll see that brown spot in your eye. That's your leash nodules. Gliomas, we talked about gliomas earlier, hypovasculocytoma, right? Optic glioma, so it's seen on the optic nerve. And the pheochromocytoma is a tumor of the adrenal medulla. We'll talk more about it later, but it's a tumor of the adrenal medulla. So those are your type 1 associations, and meningiomas and bilateral schwannomas are type 2. Along with that, there's also chromosomal, 17, 22. So 17 is for type 1, 22 is for type 2. Now, we talked about tumor suppressor genes earlier in the beginning, right? Inactivation of tumor suppressor genes can lead to overgrowth. So in type 2, there is a tumor suppressor gene involved, and that one is Merlin, right? So Merlin is a tumor suppressor gene that is inactivated, which leads to the development of all these tumors. Okay. That's NF type 1 and type 2. Now, neuromas, so neurofibromatosis, I didn't mention that. It's called neurofibromatosis. Why is it called neurofibromatosis? Because it's called a lot of neuromas and fibromas. So nerve tumors and soft tissue tumors like skin. So along with this, you're going to see a lot of neuromas and fibromas. Okay, so all that, NF type 1, NF type 2. All right. So the second one with cafe au lait spots, it's yes, question. Yes. McCune-Albright syndrome. Here too, you're going to see cafe au lait spots, so hyper, right? Hyperpigmented macules. But what else do you see? They have endocrine issues. Multiple endocrine issues, and that's why you also see precocious puberty, because you have too much LH, too much testosterone, too much estrogen, so they can lead to precocious puberty. And Also see fibrous bone tumors. So the entire bone is replaced with, or bone marrow is replaced with fibrous tissue. So fibrotic bone tumors, less precociousness, less capillary spots, McKean-Albright syndrome. So differential for hyperpigmented macules, therefore, to be McKean-Albright or neurofibromatosis. And obviously look for the other associated manifestations, which will help to diagnose which one it is. Okay. Now another neurocutaneous syndrome, but this is more, yes, question. Yes, because if the bone marrow is replaced, obviously there will be what you call osteoblastic actin will also be reduced. These are vascular tumors, Sturge-Weber, usually seen as a big bright red patch on the forehead, port wine stain. Okay, that's an enlarged blood vessel. It can also be manifesting as an angioma of the retina or the brain. Angioma is again a vascular tumor. Now, if you have a blood vessel in your eye that's enlarging, what happens in intraocular pressure? It goes up, right? Intraocular pressure going up, what's the condition then? Glaucoma, right? So with glaucoma, if you have an angioma in the retina. Yes.
The port wine stain is only on the forehead, not any other part of the face.
Most commonly. Yeah, it could be other places too, but that's usually the most common presentation. Okay. Any wet blood vessel, basically. Right. Now, if the blood vessel that's enlarged is in the brain, remember we said, if you have increased ICP in the brain because of whatever reason, what's one common manifestation of that symptomatically? Seizures, headaches, and seizures. So these patients usually present, if it's in the brain, seizures, and if it's the retina, glaucoma. Okay, so this is also neurocutaneous syndrome because you have a cutaneous manifestation, which is that red patch, and there's a brain tumor, or not tumor, but could be a malformation in the brain leading to CNS symptoms. In who? Not necessarily. I mean, the port wine stain usually you see it, early on, but this can also develop later on. Yes. The other one, which is hypopigmented. Hypopigmented is tuberous sclerosis. Now, tuberous sclerosis is pretty bad. Why? Because what are the three most important organs in that order? Brain, heart, kidney, right? And thus has all three affected: your brain, your heart, and your kidney affected. So which means this is pretty bad, right? Now, there are two types, but symptomatically they are exactly the same. But the difference is they are due to different genes. Again, tumor suppressor. These are also tumor suppressor genes, but TS is tuberous sclerosis 1 and tuberous sclerosis 2. 1 is on chromosome 9, 2 is on chromosome 16. 1, the other name for it is Palmerton, and 2 is tuberin. Okay, so TS1 and TS2 on 9, chromosome 9 and chromosome 16, Palmerton and tuberin. Again, tumor suppressor genes, so inactivation of these genes can lead to all those different tumors that are developing. So how do you know it's tuberous sclerosis? Hypopigmented spots or ashen leaf spots, shagreen lesions of the skin. So these are like fleshy growths on the skin, okay, shagreen patches. And other than that, you're going to see on the face, they have sebaceous adenomas or adenoma sebaceum. Is usually seen on the face around the nose. So you have the little macules that pop up there. Those are sebaceous adenomas, ashen leaf spots, shagreen lesions, and then now they have brain tumors. Brain tumors are called tubers, or they can also have astrocytomas. In the heart, rhabdomyoma or rhabdomyosarcoma. And in the kidney, renal cell carcinoma. And there's one more tumor that can happen in the kidney, renal angiopathy. angiomyolipoma. So based on naming, angiomyolipoma has what all? Blood vessel, muscle, fat. Angiomyolipoma. So all three are affected. So which means if you're suspecting tuberous sclerosis and they present with, let's say, a seizure, right? You have to also screen them for the other masses, other tumors. So all these patients will get a CT scan to begin with to look for brain tumors. How do we detect a rhabdo in a heart? What's the best way to do that? Echo. And then how about kidneys? Ultrasound, right? So all these patients will have to go. So this is a next step kind of question. What else would you do? When you know tuberous sclerosis, what else are you looking for? Let's say you know that they have one of these tumors. It could be heart, it could be kidney, or it could be brain. So what's your next step? Or what else would you do? Is you got to do an ultrasound, or you can do CT, or you can do an echo to find out if there are any of the other tumors. Okay, so that's tuberous sclerosis. Again, not really much you can do, and this is a pretty bad situation. So those are your neurocutaneous syndromes: tuberous sclerosis, Sturge-Weber, neurofibromatosis, McCune-Albright. Okay. Now we said earlier, most common cancer anywhere is always what? Mets. And where do we see these mets? Specifically in the brain. It's at the gray-white junction. So if you have a question where a patient is presenting with seizures, you're thinking there's something going on in the brain, you do a CT scan, you see these lesions at the gray-white junction. 99% of the time, what are they? Mets, right? Why is it the gray-white junction? Because that's where blood supply enters the brain tissue, right? What you call from the aorta or your subclavian, your vertebrals, all that come up into the circle of Willis, right? Go into the brain, and the gray-white junction is the most vascular part. So what do cancer cells want? Blood. So where do they go? Wherever they can get the most blood. And that junction is where you have the most blood. So any lesions at the gray-white junction, mets. Okay. And the most common location, primary location, if you have mets in the brain, is the lung. Okay. Lung is what most commonly goes to the brain. Others also do, but most common, you got to know most commons too, right? The most common is going to be the lung. So we said earlier about mets, right? What was the number one place mets go looking for blood? Get the blood moving, come on. Brain, right? Followed by lung, followed by bone, followed by liver, followed by adrenal, and finally pericardium. Yes, excellent. All right. So that's the brain part. Now, let's go into some of these other nearby structures. Any questions so far? No? Okay. A lot of memorization here. Unfortunately. All right, now let's talk about the pituitary. Most common tumor in the pituitary is an adenoma. Remember we said about glands, it's going to be an adenoma, any gland, right? Adenoma. So adenoma. In the pituitary, there are different cell types. There are chromophobes, acidophils, basophils, lactotrophs. Those are acidophils. Now, depending upon what cell type is the primary, it could be different symptoms or it could be different names. The most common overall primary tumor is a non-functional tumor. 95% of the time, it's non-functional. So what does it mean, non-functional? It's just a mass, but it doesn't really produce anything. Because what's the other tumor in the pituitary that can produce something? Prolactinoma, right? Prolactinoma is a functional tumor. Why? What's its function? What does it release? Prolactin. Not a trick question, right? Prolactin, right? If it's a non-functional adenoma, it doesn't make anything. But then how does it give you symptoms? Mass effect, right? In the pituitary, so we have prolactin. What activates prolactin is TRH, thyrotropin releasing hormone. This comes from the hypothalamus, right? So TRH, TSH, T4, T3 in that axis, hypothalamus, pituitary, and the gland itself. So TRH is from the hypothalamus that can activate prolactin. Okay. What inhibits prolactin? Dopamine. And then what does prolactin do? Inhibits GnRH. Okay, so that's the axis there, how it works. If you have TRH, too much of TRH, you're going to have too much of prolactin. Where would you have too much of TRH? What condition? Not goiter, not primary. A hyper or hypo? It's going to be hypo, right? Because TRH is the feedback, positive feedback. So which means that if you have TRH up here in the hypothalamus, you have TSH, and you have T4, T3, what's going to happen? It's always going to feed back. It could be positive or negative feedback, but only if T4, T3 is decreased, would the feedback be positive, right? So if it's hyper, T4 is going to be low. So in hypothyroidism, do they have menstrual irregularities? Yes, they do. That's why, because it's the axis is affected. Okay, so TRH, you have too much TRH, there's too much prolactin. Too much prolactin will inhibit GnRH. Downstream, GnRH is still hypothalamus. What comes from the pituitary? LH and FSH. That's also going to be affected. If GnRH is inhibited, LH and FSH is also going to be inhibited, which means downstream estrogen is also going to be inhibited. TRH, yes. Maribel, question?
Yeah, so my question is, please, can you throw more light on, I am lost, how you from a TRH to TSH to T4 to T3? Please, can you explain for me, please?
Sure. So we'll do all that more in detail when you do endocrine, but let's quickly talk about TRH. So every hormone, right, has a stimulating hormone which needs to be activated by a releasing hormone, right? So all your releasing hormones are going to be in your hypothalamus. CRH, TRH, growth hormone releasing hormone, GnRH, gonadotropin releasing hormone. They're all going to be in the hypothalamus. So TRH is in the hypothalamus. Then your stimulating hormones are going to be in your pituitary. TSH, FSH, growth hormone. What else? Right? All those are going to be a pituitary. And then finally, whichever gland you need to activate, that's where you get the actual hormone from. So that's your thyroid. In this situation, it's thyroid. So now in this axis, right, T4 release is controlled by TRH and TSH. TRH needs to stimulate TSH, which then makes the gland make more T4. Okay, so when you say hyperthyroidism, it could be at any level, or hypothyroidism could be at any level. There's primary, secondary, and tertiary problems, right? Anytime we talk about a primary issue, it's always going to be the gland. So primary hyperthyroidism, primary hyperparathyroidism, primary adrenal insufficiency. This all means that the problem is in the gland itself. If it's in the pituitary, that's secondary. And if it's in the hypothalamus, that's tertiary. Okay. Now, to maintain adequate levels, if you have a lot of T4, the gland's hyperfunctional, in Graves' disease, for example, the gland's making a lot of T4. What's that going to tell the pituitary to do? Stop making it. I have a lot, I don't need any more, right? It's going to be a negative feedback. Similarly, what's it going to tell TRH? Still going to be negative, right? If it's too much. On the other hand, if it is too little, what's it going to tell TSH? It's positive feedback, make more. What's it going to tell TRH? Positive feedback, make more. Okay, so that's how axis functions. And this is applicable to any endocrine hormone. Doesn't matter what, it always follows those axes, right? Negative or positive feedback. Okay, is that clear? Marbell?
Yeah, so yeah, it's clear, but I didn't get it from the T4 is going back to TSH. From T4 is going back to TRH. Can you explain that, please?
Yeah, it's just a feedback.
Okay.
Because they're all dependent on each other, your body is kind of trying to regulate the levels by either turning off the synthesis or trying to increase the synthesis, right? So if you have too
Okay.
little, it's basically telling the pituitary, hey, I have too little. I need to feedback positively to increase its production. So that's what it is.
Okay.
Positive and negative feedback. All right. So now if you have too much TRH, prolactin is increased. Now here, in a non-functional adenoma, we said it's due to pressure because of the size. As it enlarges, it compresses the axis and inhibits dopamine. Just because of the size, it pushes on the pituitary stalk and then inhibits dopamine from acting on prolactin, and then prolactin goes up, and that's why you get the symptoms. So whether it's a functional prolactinoma or a non-functional adenoma, you get the same symptoms. In a non-functional adenoma, it's because of the size. In a functional adenoma or a prolactinoma, it's because the tumor is making prolactin. So it will follow the same principle. If you have too much prolactin, it inhibits GnRH, inhibits LH and FSH. And that's why in prolactinoma, what do they present with? Females, they present with amenorrhea, right? Along with that, pituitary, where does the pituitary sit in the brain? Something called a cella, right? And where is that cella? It's right above the optic chiasm, right? Optic chiasm, you know, the optic nerve, and the optic chiasm and the optic tract. So if the mass is compressing the optic chiasm, what kind of visual field defect do you see or not see? Bitemporal hemianopsia. So this side, the temporal side, you have vision field loss, temporal field loss, because in the optic chiasm, you know, the tracks for vision, they actually cross, right? The inner tracks cross, the outer tracks don't cross. So that's why they see opposite. So in an optic chiasm lesion or a pituitary adenoma, whether it's non-functional, whether it could be functional, it could be prolactinoma, it doesn't matter what it is. If it's sitting on the chiasm, it's going to lead to a visual field defect or bitemporal hemianopsia. Okay? Yes. Non-functional. Non-functional means it's just because of the size. It compresses the stalk. If it's a functional prolactinoma, it's making more prolactin, so it gives you the same symptoms, but it's just that it's due to different causes. Okay. Now, if you have a prolactinoma, what's our goal of treatment? Or pituitary adenoma causing symptoms. If it's not causing any symptoms, they don't really do anything, right? Once they present with visual field defects or amenorrhea, now we have to do something, right? So our primary goal is what? Definitive treatment is always going to be removal. You have to take it off. But what if it's a large mass? You want to make sure it shrinks a little bit. And sometimes when you shrink the mass with medications, symptoms disappear and you're good. You don't really have to do anything. But even with medications, if the symptoms persist, then you got to take it out. What kind of medication do you use to kind of shrink the mass? Or what type of medication do we need? You want dopamine agonist. What's an example for a dopamine agonist for prolactinoma treatment? Bromocriptine. Or another one, which is cabergoline, right? So those are the two dopamine agonists that can be used to reduce the size of the tumor. So either if the symptoms disappear, or if it still persists, now it's easier to remove it. And if you want to remove it, how do you go to remove it? Through your sphenoid. So transsphenoidal resection of the pituitary of that mass. Okay. So always start with medication, and then before you treat, surgery, with surgery. So these are pituitary adenomas. Now, if it's cancer, it's adenocarcinoma. So fortunately, in all these glandular tumors, adenocarcinomas are rare. All of them are adenocarcinomas, and they are usually pretty rare. So most common is still a benign tumor, an adenoma. Okay. Another nearby structure is a pineal gland, right? What's the function of the pineal gland? What does it make? Melatonin, right? So it controls your circadian rhythm. That's why when you have pinealoma or pineal gland adenoma, these can be affected. Your circadian rhythms can be affected. Your menstrual cycle can be affected, right? Now, again, because of the location of a pineal gland tumor, it can cause cranial nerve issues. You can compress cranial nerve 3 or cranial nerve 6. Okay. Now, which if it's cranial nerve 6, what would that look like? We're looking inward, right? Because cranial nerve 6 supplies what extraocular muscle? Lateral rectus. That means you lose your lateral rectus, eye will be pulled medially. That's esotropia. So you can see that in a pineal gland tumor. Similarly, some of these masses of pinealoma can also release HCG. And HCG is similar to LH. And because of that, if there's a lot of HCG, it can actually activate the LH receptors and lead to precociousness. Okay, so that's how you get precocious puberty in a pineal gland tumor. So visual issues and precociousness with a pineal gland tumor. Another syndrome that's also associated with the pineal gland tumor is Thyroid syndrome. Here, what is the problem? These patients are unable to look up. Vertical gaze palsy. What's the other condition where they can't look up? Can't look up. Homocystinuria. Yep, exactly. Right. Vertical gaze palsy means their eyes are stuck downward. They're not able to look up. Vertical gaze, and this is because of something called the superior colliculus in the midbrain. It's compressed. So which is where your vertical gaze center is. So if you're pushing on that, because of a pineal gland enlargement, it can result in vertical gaze palsy. And that syndrome is called the Parathyroid syndrome. Okay. So that's another association with a pineal gland tumor. And most common cancer of the pineal gland is, everybody said, adenocarcinoma, right? Adenocarcinoma. Remember we said posterior fossa tumors in children, right? What were the two posterior fossa tumors in children? Pilocytic astrocytoma and medulloblastoma. Now we talk about medulloblastoma here. Now, how do you know it's a medulloblastoma? What do they present with? Because what's nearby? Early morning emesis, vomiting. Because the vomiting center or chemoreceptor trigger zone, CTZ, is also at the base of the fourth ventricle around the cerebellum. So which means when they are lying down, they're okay. In the morning, they wake up and they change the position when they sit, this mass pushes on it. And then they induce vomiting. So early morning vomiting, seizures in a child, think medulloblastoma, right? So this is also a posterior fossa tumor. But how do you know it's a medulloblastoma? It's cerebellar in origin And like I said, it has the early morning vomiting and
Wait, you said the vomiting center is on the floor?
fourth ventricle.
Floor.
Another tumor. Now, this is actually a pituitary. It actually developed from remnants of the Rathke's pouch, which is where the pituitary develops from, right? So this can also give you bitemporal hemianopsia because it's a pituitary. It can affect the anterior pituitary or the posterior pituitary, but it can also give you bitemporal hemianopsia because it is a pituitary, and it can also compress the optic chiasm. But how do you know it's a craniopharyngioma? They are cystic. So cystic masses. And what is contained within the cyst? Fluid, thick, dark fluid. It resembles more oil. So that's why it's thick and dark, and that's why it's referred to as a more oil appearance of the fluid, and has some calcifications in it. Okay, so a cystic mass in the pituitary with thick fluid and some crystals, think craniopharyngioma. Can also give you bitemporal hemianopsia. Okay. So that's a craniopharyngioma. Okay. Yes, question?
Hi, sir, what was
Abdul-
the,
Yeah, go ahead.
Yeah, that's maybe. Please, did you say that the paranoid syndrome is associated with pineal tumor?
Yes.
Okay. Thank you.
Abdullah, had a question?
what was the other thing that you could see Parathyroid syndrome in?
It's just a pineal gland tumor, pinealoma.
No, I'm saying, you could also see it in something else too, right? Other than, the
Yes.
pineal,
Right. So vertical gaze palsy. So they're not able to look upwards. Their eyes are fixed downwards.
and what is it also seen in?
That's seen in Parathyroid syndrome. So pinealoma plus vertical gaze palsy is Parathyroid syndrome. Okay. Pinealoma by itself may or may not cause Parathyroid syndrome. So you can have a pinealoma without the Parathyroid syndrome, or you can have a pinealoma plus vertical gaze palsy, which is Parathyroid syndrome. Okay. All right, that's the brain. Any questions? Yes.
Paralysis of upward gaze, their eyes stuck up or stuck down?
Stuck down. So they can look up. Vertical gaze palsy, meaning the vertical gaze, they can do vertical gaze, looking up. All right, so now moving down into the mediastinum, right? The next one, mediastinum, the middle, anterior, and posterior mediastinum, right? So we'll look at each of them. What are the structures here, and what are the tumors that you see in each of these? Starting with posterior. In the posterior mediastinum, it's mostly ganglia, right? So if it's a ganglia, what's the most common tumor? Neuroma. And if it's cancer, most common cancer would be neuroblastoma. Okay, so neuroma or a neuroblastoma, because this is where most of the ganglia are. Now, these are neural crest cancers, right? These cells are derived, or this tissue organ is derived from crest cells. Okay, neuroblastoma is exactly the same as a pheochromocytoma in an adult, right? So in a neuroblastoma, however, what do you see? It's the most common abdominal mass in children. What's the other abdominal mass in children? Films tumor, right? Nephroblastoma. So it could be a neuroblastoma or a nephroblastoma in a child with an abdominal mass. Now, on physical exam, how do you differentiate between a neuroblastoma and a nephroblastoma? You cross the midline, exactly, because these neuroblastoma is from the adrenal glands, right? And the adrenals sit on top of the kidneys, and they're more closer to the midline and kind of pointing inwards. So which means if you have a neuroblastoma, if the adrenal gland is enlarged, it will cross the midline. Okay, whereas if it's Wilms tumor or a nephroblastoma, is generally on the side, so flank masses. So that's one way on a physical exam to know if it's a neuroblastoma versus nephro. Crossing the midline, neuro doesn't cross the midline, nephro. Okay, so what do you see in neuroblastoma? What is there a lot of in neuroblastoma? Because it's a tumor of a ganglia. And what's the most common location also? Well, adrenal medulla. Okay, and what does the adrenal medulla make? Catecholamines. So what do these patients with neuroblastoma have a lot of? Catecholamines. So what are these catecholamines? Norepinephrine, epinephrine, dopamine, right? And what's dopamine used for generally? If you're too much of dopamine, what do you see? Too much activity, right? Too much activity. So that's your hypsarrhythmia. Hypsarrhythmia is basically too much brain activity, so they can develop seizures. Okay. Dancing eyes and dancing feet. Sure. Yeah, neuroblastoma is an adrenal gland tumor, and the adrenals are on top of the kidney, and they kind of are pointing towards the midline. So when they enlarge, it crosses the midline. Whereas if it's just a kidney, it stays on the side, on the flank. So hypsarrhythmia has increased activity due to increased dopamine, and usually manifests as seizures. So that's why they call dancing feet. Opsoclonus is same thing, increased movement of the eye. So that's dancing eyes. So the eyes will be darting back and forth. It'll just be going back and forth, right? That's opsoclonus, dancing eyes, dancing feet. The good thing is these usually regress spontaneously. So pretty good about that. You know, we don't really do anything. Sometimes it can regress by itself. The pheochromocytoma is the adult version of a neuroblastoma. Adrenal medulla, sometimes it's in children, sometimes it's bilateral. It can metastasize sometimes, familial, and could also be malignant. Remember, this was one of the ones that we included in the exceptions earlier on in OMAs, right? Because 10% of them are malignant. So therefore, it's not always benign. Yes.
Quick clarification. Highest one is depression rate, 2%. Is that it regresses by 2%? Like what's the 2%?
No, 2% of cases it regresses. But 2% is pretty good when you look at cancers. So that's why it's still good.
What's like the presenting age for the neuroblastoma?
Seizures and age. So pediatric, so anything between like less than 18, you can think about in kids. But 10% of the time, they can also develop pheochromocytoma. That's the only difference. But if it's a child, then, or it could be younger, right? Under that age.
But not like at birth.
Not at birth, unless it is like maybe it's a neurocutaneous syndrome. We talk about pheochromocytoma right there too, right? So unless it's one of those syndromes, not otherwise. Now, in general, there is no absolute. So when I say it's not seen at birth, usually not seen at birth. But can you see it? Yeah, sure, you can. These neural crests, or because you have too much catecholamines, right? What do they present with? How do you know clinically to diagnose this? Hypertension, tachycardia, but not persistent, it's episodic, right? It comes and goes. So whenever there's that surge in catecholamines, you got hypertension. So that's important because if it's persistent hypertension, what would you think about? If it's persistent, if it's not episodic, if it's paroxysmal hypertension comes and goes, we think few. But what if someone has 180 or 110 and it just stays that way? It's hypertension. So what could be a cause of it? Correct. Renal artery stenosis, could be cont syndrome, hyperaldosteronism, right? So if it's persistent, think of other causes of secondary hypertension, right? So you already ruled out primary cause, other causes secondary like renal artery stenosis, hyperaldosteronism, things like that. But if it's paroxysmal, right, it goes up and down, every day you have this episodes, then you think pheochromocytoma. So because there's a chance of malignancy, and because we can't really make them out, whether it's benign or malignant, most of the time we remove them, right? Neuroblastoma, we can wait because there's spontaneous regression. But when it comes to pheochromocytoma, we have to remove it. However, right, before we remove it, what do we need to do? Somebody comes to 180 or 110 blood pressure, you take them in for surgery? You can't, right? What do we need to do first?
Or like pre-op, it's phenoxy benzene.
Yes, we have to lower the blood pressure before you start the surgery. So there we use phenoxybenzene. What is phenoxybenzene? Mechanism of action.
Non-competitive inhibitor, basically the catecholamines of northern.
Alpha 1, right? Alpha 1 antagonist. Because norepinephrine, what's its primary receptor? Alpha 1. And what is the primary location of alpha 1? On your blood vessels, right? So that's how you get this hypertension, because alpha 1, norepinephrine, alpha 1 agonist. So it causes vasoconstriction, which gives to high blood pressure. So what do? We got to block that receptor to bring the blood pressure down. Because even if you have a lot of norepinephrine, if you can block the receptor, then it's not going to work. So we block the receptor with phenoxybenzene, which is an alpha 1 blocker, long-acting, irreversible alpha 1 block, irreversible alpha 1 blocker. We use that prior to surgery, and then you do surgery. Phentolamine is a short-acting blocker. So we usually do that for testing, not for treatment. Right? Phentolamine for testing and phenoxybenzene for treatment. Another way to diagnose this is to look for its breakdown products in the urine, right? So norepinephrine catecholamines, when they break down, it gives up. You break metanephrines and VMA and HPA, homomelanic acid, vanillyl mentolic acid, and metanephrines. So these will end up in the urine. So another way to look at a diagnosis is look for these products in the urine, do a urinalysis to check for these breakdown products, and if you see these, that helps with diagnosis also, right? That's pheochromocytoma. Now, in general, when we talk about neural crest-derived structures, there's a mnemonic. Motel Pass. So these are all derived from neural crest cells. So what does it stand for? M, melanocytes. So if you have a malignant melanoma, right? Where does it come from? The melanocytes. That's also a neural crest-derived tumor. O, odontoblasts. So your teeth. T, tracheal cartilage. E, enterochromaffin cells. These cells are usually seen in your GI tract and they make serotonin. L, laryngeal cartilage. Okay. Has, P, pseudo unipolar cells. So these are cells of the neurons. A, all ganglia. So we just talked about neuroblastoma. And the adrenal medulla is also a ganglia. S, Schwann cells. We talked about Schwann cells, myelinate the peripheral nervous system. And then finally, spiral membrane. Spiral membrane is in the heart. So it's what develops into the aortopulmonary septum. That's the spiral membrane between the aorta and the pulmonary artery. The aortopulmonary septum. So those are your neural crest-derived structures. Okay. So the main things to remember here will be melanocytes, your enterochromaffin cells. So when you talk about serotonin syndrome, right? Enterochromaffin cells, then adrenal medulla, Schwann cells. So those are the most commonly tested in relation to neural crest-derived structures. Yes, question?
Yes, when you were talking about the pheochromocytoma, you said if it was a persistent palpitation, we should think of what again?
Yeah, persistent hypertension. Think about renal artery stenosis as a cause of that hypertension, or maybe even hyperaldosteronism as a cause of that hypertension.
Thank you.
Right. All right, now in the anterior mediastinum, what are the structures in the anterior mediastinum? Thymus, thyroid, trachea, and then, Marbel, you had a question?
Yeah, please, you said the other guy that asked you about persistent hypertension, he said hyperaldosteronism, and what is the cause of persistent hypertension?
Renal artery stenosis.
Okay, thank you, sir.
And in the anterior mediastinum, you can also have masses that are lymphomas or even teratoma. So these are the different masses in the anterior mediastinum. So if you have a thymoma, so if you have an anterior mediastinal mass, so when you do an X-ray, when you do a chest X-ray, you see a little shadow, a large shadow there, right? So that could be a thymus, thymoma. What condition is thymoma usually associated with? Myasthenia gravis, right? So you can have a thymoma. Then thyroid, we'll talk about the thyroid masses, then tracheal masses, and then lymphoma. So whenever we see mediastinal masses or mediastinal shadows, we think about lymphoma, right? Which lymphoma usually presents as a mediastinal mass? Hodgkin's lymphoma, or it could also be a teratoma. Okay, so those are, what's the other mediastinal mass? Sometimes otherwise, other than cancers. What's that other condition where you see mediastinal lymphadenopathy? 45-year-old African-American female. Sarcoidosis, right? Sarcoidosis. So that also gives you a mediastinal mass or mediastinal lymphadenopathy. All right, now let's have a leukemias. Leukemias in general are mostly B-cell leukemias. 98% of the time, they're all B-cell leukemias. Only 2% of the time, it's a T-cell leukemia. Okay. Now, I'm going to briefly talk about some of these leukemias. It comes up later in your, I think, immunology chapter will be done again by Dr. Francis, but I'm just going to give you a few clues to identify the different types of leukemias. So before that, how do we get these cells? You have your stem cells that become, there are two cell lines, right? You have your lymphoid and myeloid. Lymphoid cell lines, they become NK cells, your natural killer cells, or a B cell or a T cell. Okay, lymphoid cells. On the myeloid side, what do they become? The RBCs, platelets, mast cells, and then you have myeloblasts. Myeloblasts. What are myeloblasts? That's our favorite term, right? Get excited when we hear that, which is NBME. Neutrophils, basophils, monocytes, eosinophils. So those are your myeloblasts. Okay. Neutrophils, basophils, and eosinophils. Those are your granulocytes. And when you talk about granulocytosis, granulocytopenia, what does that mean? You either have too much of your granulocytes or too little granulocytes. And then your monocytes, which becomes macrophages, along with your B cell and T cell, those are your agranulocytes. So when you talk about drug-induced agranulocytosis, all that, that's what we talk about. These are the cells, okay? So that's how these myelocytes or lymphoblasts, lymphoid cells, and the myelocytes are formed. Now, when you talk about leukemia, they're all B-cell leukemias, mostly. And there are a couple that are T cells, okay? Now, so let's look at leukemias. What are the different types of leukemias? You broadly classify it as acute and chronic. You have acute AML, ALL, then you have CML and CLL, right? You have the acute and you have the chronics. So kind of like 2 or 3 points about each of them, just to make it easier for you to pick it up in our question. I mean, it comes up later in one of the immunology chapters, but you can just follow through since we are talking about it. So when you talk about acutes, right? Between acute and chronic, which is worse? Acute. Where is the problem in acute? It's usually the bone marrow. Okay. Whenever you say acute, the problem is the bone marrow. When it's chronic, it's generally the periphery. Okay. So in acute, lymph, and these acutes, if it's a bone marrow, you're going to have more blasts. So what are blasts? Whether it's lymphoblasts or myeloblasts, what are they? Immature cells. They are baby cells, because myelocytes, lymphocytes are your mature cells. Myeloblasts, lymphoblasts. How much lymphoblasts or myeloblasts should be there? Less than 10%, because there's always going to be a little bit, right? Because as they mature, as the bone marrow puts us out and they mature, a few myeloblasts will remain or lymphoblasts will remain. It's about 10%. So in acute, in both in ALL and in AML, there are more than 20% blasts. The only difference between the two is in ALL, it'll be lymphoblasts. In AML, it'll be myeloblasts. So immature myelocytes, immature lymphocytes. Okay, so that's across the board. In both acute, there'll be more than 20% blasts. So when you look at lab values and they, when they talk about lymphocytes, mature and immature, and they say 20% or 30% myeloblasts, there's no reason why there should be that many myeloblasts, which means the bone marrow is actually hyperproliferative. So that's how you know leukemia. Okay. Yes, Victoria.
Isn't there a type of leukemia that's like the promyeloblast or something like that?
Yes. So even the
AML?
correct. So that's also in AML. That's a subtype of AML. So myelocytes are actually when myeloblasts become myelocyte, they go through a few stages. So they become promyelocyte before they become a myelocyte. So it depends on.
Sorry, there would still be more than 20% blast then.
Exactly. There'll still be more than 20%. Yep.
Okay.
And they'll also have increased promyelocytes. So that's how you know it could be PML, along with there are some other clues that you're going to look for also. Okay. So there's also a general classification for age. Now, when you talk about age, it's just a guide to help you think most common. It's not an absolute. In ALL, it's usually seen in the younger population, 0 to 15. Okay. AML is 15 to 30. CML, 30 to 50. CLL, greater than 50. Again, just to make it clear, it's not an absolute. It's not a must that is always like this. But most commonly, in those age groups, these are the ones you're going to think about first before you look at other things. Okay. Now, if the bone marrow is making a lot of blasts, now that we're only talking about the white cells, blasts, right? What's going to happen to RBCs and platelets in ALL and AML? If your bone marrow is occupied by myeloblasts, it's going to take up more room. Will suppress the other cell lines. Both acute ALL and AML will also have decreased RBC, so anemia and thrombocytopenia. Okay, so that's the other manifestation. So a kid who's presenting with a lot of infections, who's presenting with anemia, thrombocytopenia, what should you think about? ALL or AML, right? In a child. What's that? So if you have a kid, you learn about low energy state, right? So a kid is tired all the time, growth is affected, they have all these bone pains. And when you look at peripheral smear, you see anemia and thrombocytopenia, even without looking at blasts, just anemia and thrombocytopenia with all these presentations, what should you think about? A leukemia, right? So that'll be a presentation for a leukemia commonly. So think about that when you see these symptoms of presentation. Okay. All right. So now, which means low platelets means they're also prone for bleed. So this could be also persons coming with, when they brush their teeth, they're bleeding or they have nosebleeds for no reason. But your bleeding time, clotting time, and all is fine. It's not a clotting factor issue. So that could also mean a leukemia because we know they're going to have thrombocytopenia, right? So kind of put all those together to see, oh, okay, what's the most common cause of all this happening together in a person? Right? Leukemia. All right, so ALL, what else? So lymphoblasts means they are immature lymphocytes, lymphoblasts. Now, these cells also have markers. Mature lymphocytes have CD, cluster of differentiation. They have a marker. Mature cells are CD20. So 19, 20, 21. When you talk about lymphocytes, 19, 20, 21. So you have a lot of cells that are positive for CD19, CD20, or CD21. That means they're all mature cells. If you have a lot of cells that are positive for CD9 or CD10, so 10 minus the mature, they are lymphoblasts. So that's another clue for lympho ALL. Lots of cells that are positive for CD9, CD10. Another thing that's positive is TDT. So that's an enzyme that's present in lymphoblasts. So they will be positive for that. It'll also be PAS, periodic acid shift, the stain, positive. What do they stain? PAS positive means, what does that mean? What does it actually stain? Sugars. So glycogen, right? So there's a lot of glycogen in those cells. So anytime, even in other conditions, you can have PAS positive. So PAS positive, basically, that stain stains for sugars. What else for ALL? So pediatric population, blast, thrombocytopenia, anemia. What's that? Down syndrome. You can see this in Down syndrome. And if the translocation is 1221, that indicates a good prognosis. Okay, specifically, if it's 1221, good prognosis. So those are a few things that help you identify acute lymphoblastic leukemia. Yes, Victoria?
Sorry, why did you say it's associated with Down syndrome?
It's just an association. It's seen more commonly in Down syndrome. Or Down syndrome patients can develop ALL.
Okay, there's no reason, or we
Yeah,
don't know
there's no
why?
specific. Yeah, there's no specific reason
Okay.
why. It's just association.
Okay.
Ryan, you had a question?
Yeah, so you said it's associated with CD markers 19, 20, and 21, and you say that those are the mature markers for the lymphocytes?
Correct. Those are markers for lymphocytes.
Oh, okay. So it doesn't matter even though it's still an acute blast.
No. Actually, let me rephrase that. 19, 20, 21 is seen in CLL.
CL. Okay. Sorry.
Because CLL chronics are mature cells.
Okay.
So CML and CLL are myelocytic and lymphocytic. AML and ALL are myeloblastic and lymphoblastic. So that's why I just want to make the difference. In ALL, it's going to be 9 and 10. In CLL, it'll be 19 and 20.
Okay.
Okay. All right. So just one note about treatment. So most of the time, yes, question? The markers, immature lymphoblasts are CD9, CD10 positive. Mature lymphocytes are CD19, CD20, CD21 positive. Okay.
Excuse me, doctor, it's also gonna be CD34?
CD34 is not specific because CD34 is for all stem cells. Yes,
Oh.
you're going to see CD34 also, but that doesn't tell you it's ALL. It could also be AML.
Okay, thanks.
Yes, these are B cells. So CD910 is B cells. CD1920 is B cells. If it's T cell, what are the T cell markers? T cells are the smaller numbers. CD3, CD4, CD5, those are T cells. Okay. Any other questions? Okay, so just one note about treatment because there is clinical relevance. So like we said earlier, anytime you're trying to treat any cancers, what are we trying to do? Inhibit replication, inhibit DNA synthesis or DNA replication, right? So all the drugs will work in that effect. Here we use doxorubicin. I mean, there are other drugs too, but I just wanted to mention doxorubicin because it is tested for its side effect, right? What's the side effect of doxorubicin? Cardiomyopathy, right? What kind of cardiomyopathy? Dilated cardiomyopathy. Remember we said earlier, which is worse, dilated or hypertrophic? Dilated is always worse, right? So doxorubicin has a cardiotoxic effect, dilated cardiomyopathy. However, because of that toxicity, we can pre-treat them with a rescue drug to prevent the toxicity. So that's why I brought it up, because we need to know those rescue drugs. There are about 4 rescue drugs that I'm going to talk about through the course of the day. And this is the first one. So doxorubicin, to prevent cardiotoxicity from doxorubicin, what's the rescue drug? Yeah. Dex. Rock. So you can pronounce it whichever way you want to, but that's why it's a rescue drug to prevent cardiotoxicity of doxorubicin. So usually when you treat with doxorubicin, you give this along with it. Yes, question?
Yeah, excuse sir. Please, sir, I want to take us back. I don't really get how you get this 20% blast cell. And the other stuff is explain about the blast cell, please.
Sure. So blast basically means they're immature cells, right? Normally, when the bone marrow makes blasts and they most of them mature into a regular myelocyte, it becomes your white cell. Okay. Now, if your bone marrow is putting out so much immature cells that only some of them are actually maturing. So there's an imbalance between mature cells and immature cells. There's a larger proportion of immature cells, and that's why it's called a leukemia, right? You have leukocytosis. When you check white counts in these cancers, what would your white counts be? It's very high. WBC count will be in the 50,000, 60,000, 70,000, in that range. But even in those ranges, the majority of those cells are immature cells. So that's why it doesn't help, right? That's why you get infections, because these cells are non-functional. They get frequent infections because of that, okay? That's a 20% blast. You have more immature as compared to mature. More, not more immature than mature, more percentage of immature that should be more than normal. So normally it's less than 10%. Now you're more than 20%.
Okay.
Okay. All right. So now AML. So AML is myeloblastic. So here you're going to have myeloblasts. If it's myeloblast, what do they stain for? Myeloblast. What do they have? Myeloperoxidase, right? So if these cells are positive for myeloperoxidase, that it's AML. Again, a lot of blasts, there'll be myeloblasts, myeloperoxidase. Now, these cells, something else that's kind of unique to AML, which will help you at least identify AML, they can present with DIC, disseminated intravascular coagulation. Now, have you talk about the clotting cascade? Did you talk about last week yet? No? Okay. So these cells, so in the clotting cascade, there's the intrinsic and the extrinsic pathway, right? So briefly, the extrinsic pathway, there's only one factor. Which factor is on the extrinsic side? 7. How is 7 activated? Tissue factor, right? So these cells, these cancer cells, they release tissue factor. So then this tissue factor will activate factor 7, activate the clotting cascade, and that's how they get DIC. Okay, so these patients can present with DIC, infections, just like any leukemias. They also myeloperoxidase positive. Now these cells could be CD34. Somebody asked about CD34. Now you can say CD34 here because there is no other marker for that. CD34, however, is not unique. It's just they are on all stem cells. Now here, there are 5 subtypes. M1 through M5. But for our purposes, we only need to know M3, which is your PML. Okay. So PML is due to a translocation. And what's a translocation PML? 1517. And this causes a problem with the retinoic acid receptor. What is retinoic acid? Vitamin A. Why do we need vitamin A? What's the function of vitamin A? For and cell maturation, right? So that's why these are immature cells, because if the retinoic acid receptor is mutated, not enough vitamin A, so cells stay immature. So that's also why, what do we treat them with? All trans retinoic acid, right? We're giving them vitamin A. Okay, so that's the PML that we have, promyelocytic leukemia, right? It's a subtype of AML, specifically with 15-17 translocation, and you treat it with retinoic acid. Okay, so that's AML. CML, so when you go to the chronics, CML and CLL, these are mature cells, so they are myelocytic. It's chronic myelocytic leukemia and chronic lymphocytic leukemia. You're going to have a lot of mature cells. Now CML, so any cells or rapidly dividing cells, what do they use as a second messenger? Tyrosine kinase for growth and replication, tyrosine kinase. So CML is due to a mutation where you have too much tyrosine kinase. So that's why you have too many myelocytes. And that's a BCR ABL mutation there. That's an oncogene, right? When we talk about oncogenes and tumor suppressor, that's an oncogene, tyrosine kinase. So they end up making a lot of white cells, mature cells. However, now somebody has white cells in the 25,000 to 30,000 range. Okay, what else can cause white cells to be that high other than a leukemia? Infection, right? But infection usually, yeah, it goes to 15, 16, 17. You may not go to 50,000, but yeah, 15, 16, 17. And sometimes even leukemia starts out 20 and then eventually becomes 50, right? So you have to differentiate it from a normal reaction. And that there's something called the leukemoid reaction, right? Leukemoid reaction. So normally, leukemoid reaction is when you have your body's normal response of some stress can increase your white count, right? So when you're going to take your USMLE and then you open, you hit start, and then you see the first question, and somebody comes and draws your blood and look at your white cell count, what's it going to be? So very high, right? Or even right here, or even here, and Dr. Francis, calls a name. I don't know any names, so I can't call. So calls a name and asks you a question, what's your white count going to be? It's going to shoot up, right? Why? What causes that white count to go up? Cortisol. What does cortisol do? So your bone marrow is suddenly going to start making more? No, right? But where are these white cells? Where are these cells normally just hanging out? Where in the blood? I mean, if it's in the blood, then you should measure. You should be able to measure it, right? They are marginated, right? They're actually stuck to your blood vessels. They're lining the blood vessels. So when you have cortisol, what's going to happen? They demarginate. They all fall into your blood. So that's why your white count goes up. It's not that the bone marrow suddenly starts making more. It's going to take time for all that to happen, right? So stress demargination. So a leukemia reaction could be that. Yes. So that's immature versus mature cells. So you have a lot of, like infection, right? You might have your bone marrow making a lot of cells, right? So you can increase white count. So that's when we say we have increased, myelocytes versus lymphocytes. So we have increased white count, then we call that a left shift. So a leukemia reaction, how do you know that someone's white count, let's say it's 20,000, it's not a leukemia reaction, it's a leukemia? That's a test that we can do, right? There's something called the leukocyte alkaline phosphatase, so lab score, LAP. So it's usually talked about in the context of a CML, because CML is the one that resembles a leukemia reaction. Right? So you do something called a lab score. Leukocyte alkaline phosphatase. So these are only present in normal cells, basically. So which means if it's a leukemia reaction, what would your lab score be? High, because it's normal cells. Whereas if it's a CML or if it's cancer, then your lab score is low. So a lab score is used to identify a leukemia reaction versus of leukemia. Okay, so that's CML. Now here, point about treatment. When we treat CML, we are trying to inhibit tyrosine kinase. So we use tyrosine kinase inhibitors. Imatinib. So those drugs that end in NIB, NIB, they are tyrosine kinase inhibitors. Now, finally, CLL. So out of all the four, CLL has the best prognosis because these are also mature lymphocytes. Okay, they have increased lymphocytes. And like I said, they are all CD19, CD20, CD21 positive. Now, where do all these lymphocytes hang out? B cells. In the lymph nodes. So if you have a lot of these mature lymphocytes, what's the patient going to present with? Lymphadenopathy. So most of the time, that's the most common presentation, not anything else. They just have lymph node enlargements all over, right? That's CLL. And because all these are tightly packed into your lymph nodes, if you do a biopsy, then on the slide, you see smudge cells. All that means is that these cells are so tightly packed, they're kind of cracked. They're smudged. That's CLL. And for treatment of CLL, you're using a drug that specifically inhibits CD20 cells. Rituximab. So there are some of these drugs you need to remember, not specifically due to treatment, because it's got a very specific mechanism of action. Rituximab, CD20 inhibitor. Yes. CD20, specifically CD20 inhibitors. So that's why it's rituximab, imatinib for CML, Atra for AML, and doxorubicin for ALL. All right. So those are your leukemias and the clues for leukemias. All right. Any questions? Yes. CLL. Okay. What's the most common cause of death in cancers? All right, so let's take a break. And 20 minutes. 10:40?
Question?
Yes, question?
Yes, so it didn't catch what you said about the smudge cells.
Smudge cells are just basically cells that are crushed because they're all tightly packed within the lymph node. Because they're all tightly packed, they kind of get squeezed in there and become crushed. And that's smudge cells.
When you get away from the computer, it's hard to hear what you say.
Oh, yeah. Can you hold till we come back? You can ask me when we come back in like 20 minutes.
Okay.
Yeah, we have cancer. We can get it. Not necessarily that they have it or issue. But there's always a high chance because it's a mutation. So that means that they are at a higher risk. Not that when they present you, they should have it. But yes, definitely. They have yeah, because they have astrocytomas and so because of that, you can have CNS syphilis. Oh, yeah, that's how it's a bad thing. Yeah, so that's why I said it's not accurate thing overall, but generally it follows. Yeah, there is some exception. So most of the time, I know some books in this say. Yeah, I know. That's why I'm very clearly said it earlier. So don't just say that. Okay, sorry, it's not always sure.
March. So I get a little confused because I always think cortisol and steroid inhibit the immune response.
Yes.
In this case, it's basically
It does inhibit the immune response, but cortisol, it causes the stress, right? It's called stress demyelination. So it also, it actually, what if you take cortisol overall, like steroids in general, right? they suppress immune response. But when you say immune response, what does that they're suppressing?
The action of that?
No. So I don't know if you've done it at you know what the mnemonic IPS is? Steroids mechanism of action. Have you done that yet?
I don't think we have done that.
You haven't done that yet. Okay, so I'm going to talk, then I'll talk about it right after we come back.
Okay.
Okay, so then I want to mention something else too, because
Okay.
if you have that question, just make a note. Yeah, you're right, partially, but there is something else to it too.
Excuse sir,
Yes,
please, sir, what do you mean by BCL, ABL in CML?
so BCR-ABL is oncogene.
Okay,
So the mutation of the oncogene, BCR-ABL mutation is what led to that cancer.
Oh. Like this is what I used to use for like cancer, like ALL. So for ALL, I was like, okay, roughly 10 years, CML 40, CML 50, CLL 80, and then if you get into transplant, you get DLTC.
Yeah, no, that's fine.
That timeline.
Yeah, that's fine. I mean, this is like, that's it, you know, it's not absolute. We can use it when I was, yeah, I think Dr. Franz also teaches like that, but obviously, you know, it's not an accurate science. It's just- That's okay. Stick to that. Stick to that.
I've never got a question on.
Yeah, that's fine.
Look at this and like one of the
Yeah, yeah,
characters.
absolutely. Yes.
Right, so I have a question about the LAP. So I thought that in CML, you're also interested in white blood cells. So what is unique about?
Yeah, but those are not normal cells. Though. So it's cancer cells, right? So they're non-functional. You have white cells,
Yeah.
but they're non-functional white cells. Whereas in leukemia, it's just infection, your body's response. So they are functional white cells.
So is there like a specific kind of receptor or something on the?
It's an enzyme.
functional?
It's an enzyme. LAP, leukocyte alkaline phosphate, is an enzyme, right? So an enzyme is present in normal functional cells. So when it's cancer cells, rapidly dividing cancer cells,
It's present in
the
the.
cell.
Oh, I see.
Yeah, so
So basically, the LAP is lacked in the CML cell.
correct, because it's cancer cell. So, and how do you look for it is the test is looking for the stain. So it's just a darker stain. That's all. They look at grade 1 through 4. The deeper it stains, the more the enzyme is. The lighter it is, less enzyme. So that's
Because the cancer is plastic.
Yeah, then right. Because if it's normal cells, then you're fine, right? But these are, although they are mature cells, they're still non-functional because they don't have the normal immune. They're not able to respond in a normal situation because they're non-functional. They're just there.
So in terms of the middle mediastinum, we didn't touch on that. Is that
No,
so
it's
we
coming.
did it's
Yeah, it's coming in.
Okay. I thought maybe it's not.
No, middle action, there isn't much there because middle is the heart, right?
Mhm.
So in the heart, there's really no cancer. There's myxoma. But that's it, pretty much. That's it in the heart. And lung, it's middle is heart and lung. So those will come up later.
Probably makes a clarification on the chromatoids. So because they are just mass, they will just cause a mass spec.
Correct.
And basically the pituitary stalk is where dopamine is stored.
Yes, correct. It comes to the pituitary through the stalk,
Okay.
right?
And because of that,
It can get to the
feeds back
pituitary,
the-
correct?
I get that. Is there going to be bilateral hemianopsia?
Yes. Any pituitary mass, whether it's functional or non-functional, doesn't matter. If the pituitary enlarges, it's going to compress the cas. So whether it's non-functional or functional, you still get bilateral.
Mm. And what do you say about the cella part?
Cella is just the little sac where pituitary sits. You know, you have the Rathke's pouch and you have the cella turcica, right? So there's something called the empty cella syndrome. That just means that the pituitary is not in the cella. Cella is just a little, what you call, there's a little pocket where the pituitary sits. That's it. Oh, that's what it's called. That's what it's meaning. Cella turcica, Turkish saddle. There you go.
I'm just kind of making the association with the pituitary stalk and dopamine.
Where does dopamine come from?
Isn't it anterior pituitary?
It doesn't come from there.
So the hypothalamus?
No, dopamine, they have other cells in the brain that make dopamine, catecholamines, right? Dopamine is from Which cell is dopamine? There's Maynard, there's that's not dopamine. So there are cells in the brain that make dopamine. So that has to come to the pituitary. So it comes through the stalk. It doesn't substantial nigra is dependent. Dopamine is stimulatory. I mean, in the signal, it goes through all the nuclei, but it is made in the there's a nuclear, there's a mesolimbic system, there is a substantial nigrostriatal pathways. They use dopamine, but dopamine is released from not red nuclear, chordates. And one of those nuclei. So basically, it gets to the pituitary through the stalk. So if you compress the stalk, then the dopamine doesn't reach the pituitary. That's why.
In my mind, I thought it was made in the anterior pituitary.
No, it's not.
That's why I was making that error. Because if it was made there, then why would just the
Right.
be the
It's not
problem?
made there. Yeah, these catecholamines are made in the brain, and they have different nuclei that make this catecholamine. I forgot the name. Maynard is acetylcholine.
Yeah.
I think there's what's the other one? There's like 2 or 3 nuclei. One makes serotonin, one makes catecholamines, one makes norepinephrine.
Lupus ceruleus.
Locus coeruleus, norepinephrine. So there are different nuclei, right? And then it has to
be
come.
transported. Thank you. In terms of the posterior fossa, we have to include the pilocytic
Correct.
one too.
Yeah.
Okay. Yes. And could you please clarify the morning vomiting part? So from what I sort of heard, it was because the posterior pituitary, the posterior fossa contains the vomiting center.
Yeah, the floor of the fourth ventricle, right? So, and then, so when you sit up straight, if you have a medullary mass or cerebellar mass, when you go from lying to sitting, now suddenly that pushes pressure on the CTZ.
Oh, so when you're lying down, it's not pushing
No,
pressure?
because it has to be, you have to be vertical, right? It's underneath. So when you're lying down, it's side by side. You're fine. When you get up from this position, it becomes like this. So now you push on the vomiting center, induces vomiting.
Yeah, I think there's a question.
Same thing. Yeah, CT is the same as area post treatment.
And I was wondering for the Down syndrome, or was it? I noticed one of the translocations that has departments, it said translocation
1221.
21. Would Down syndrome be associated with some 21?
Is it because, not necessarily, because there is a poor prognosis translocation too in ALL. They also see in Down syndrome. So I mean, maybe because there are a lot of chromosomes sometimes and there is an overlap, but it depends. Right? It's not necessarily, but it could be. Yeah, there's no association that I know of just because of that. But when you talk about 22, like so 922 is Philadelphia, right? And then 1722 is NF. There's still 22 there, but they are separate. I didn't talk about that in CML 922.
For the neurocutaneous and sort of the histologic features, do you have any sort of brain map kind of thing that you use to help you remember?
For which one?
The neurocutaneous syndromes and
like NF?
Yeah.
To remember which one? To remember
all the neurocutaneous syndromes like neurofibromatomas, like Macoon's,
drill. I mean, I just learned it by repetition, right? Because I say it so many times, I remember it. It's the same thing. Those kind of things, it's it's good if you can make an association somewhere, but it's hard, because there's so many of these things. It's just it's a list. So best thing to do that. The way to do that will be to kind of like drill each other. When you drill, you can remember it more. Yeah, I mean, people come up with a lot of different ideas, but I don't have it. Unfortunately.
Gotcha. All right, thank you.
All right, cool.
Hello, guys. Are we on break? When do we come back?
8 minutes. 8 more minutes.
Huh?
8 more minutes.
What?
8 minutes.
8 minutes.
Yes.
Oh, God, that's so short.
Yeah. Like 16 and. Yeah. Yeah. No. I'm sorry. I don't. Right. Okay. That was to the foundation. At this point, I'm not really trying to. No, I can do one after. We have to take individually, say, this is what works best on how many. Those parts, you know, you hit. Yeah, it's fun. He had one left, and he had one left, so they were he went, and he stopped. And then went back. But he had, yeah, you wanna. Yeah. No, 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 you know. Yes. No, it's like, yeah, I just. It's like you start, you know. You're gonna make it much like this. Yeah. No, I don't do it as in the corner, I do it before the game starts. I just pull lines, I can wait before it's over under. Yeah. That's right. But the. Yeah. I'm supposed to, you know, come on. My there's not bad. Yeah, you know one. That's my Oh. What reaction is leukocytosis, which is the body's response to some kind of virus. This increased white cell count as a normal level. Get infection, surgery, for example, right? For explain the stress in the white cell count. That's normal. That's okay. Well, you don't really, we say lymphocytosis, you don't say lymphoreaction. What means, because valves and infection, what provides the space like 12,000, 15,000. High, but doesn't go into the 20. When it goes to 20, 25 days, now you have to really think about leukemia, but then you have less. Yeah, so basically it's kind of like a umbrella term. It's a normal reaction. That's why you look at CML was with one. Normal was. So there too, the moment I grab it, to make more. Right, ready? So online, somebody had a couple of questions.
Oh, yes, I think that was me.
Yeah,
Right.
go ahead.
Yes, so I was asking a question about the nudge cells because I did not catch what you said.
About which one?
The nudge cells.
Oh, smart cells.
Right,
So basically, smart cells are your lymphocytes. When they are tightly packed within the lymph node, they get crushed. Because it's a limited room within the lymph node and they're making so many cells, what's going to happen when all the cells are kind of like arranged in a smaller space? They're going to kind of like, go on top of each other, or they're going to get crushed, right? So smart cell basically is a cell that's being like crushed because of, too many in there.
Okay. So we're gonna see that how can we see that? Like
On a slide. When you take a biopsy and look at the slide, you will see a cell like someone stepped on that cell.
okay.
All right, so we had a question when we talk about cortisol or steroids in general, right? So how does steroids work in general? When you talk about cortisol, we talk about prednisone, any glucocorticoid, right? You give steroids. Why do we give steroids? So immunosuppression. So basically, you want to suppress the immune system. So I think you're going to talk. I thought you might have already talked about this, but it'll come up later in class. So there's 5 ways it works, right? Mechanism of action of steroids in general. And the mnemonic there is KISS. Inhibits phospholipase A. Phospholipase A, that enzyme, what does it catalyze? What pathway? The arachidonic acid pathway, right? To make your leukotrienes and prostaglandins. So that's one way the steroids work. They inhibit prostaglandins and leukotrienes. So that's part of the immune system, right? That's one. How about K? K stands for kills. Kills. T cells and eosinophils. So we know that they're also part of our immune system. We need T cells, we need eosinophils. So it kills those two. The other, yes.
Doesn't actually kill them. Just like increases the numbers.
Well,
Like it doesn't, like it causes it to not be produced.
right, suppresses it, right? But to remember it in the morning. So the other I inhibits macrophage migration, right? Because macrophage is also required for infection. So that's part of the immune system too. S stabilizes endothelium. Because you need, how does, when you talk about demyelination, you have the rolling diapedicers and all those processes by which the cells get to the tissue, right? How do they get to the tissue if they are in the blood? There are gaps in the endothelium through which they're traveling to the tissue. When he says stabilizes endothelium means all those gaps will kind of close. So which means now these cells can't migrate into the tissue. So that stabilizes endothelium, and then finally stabilizes mast cells. Because what does mast cells make? Histamine. So when it's stabilizing mast cells means it's now not going to make any histamine. It's not going to be granulate and make histamine. But if you look in that, what's missing in there?
from all the cells that we talked about, T cells, B cells, mast cells, macrophages, eosinophils, what's missing there? Which one specifically? Not, I mean, and in a myelocyte, which myelocyte is missing? Neutrophils. So actually steroids increase neutrophils. So that's the difference. When we talk about margination, white cells going up, overall count going up, who was asking that? Who was asking that? But yeah, neutrophils actually go up. So when we put cortisol, so there's also a question, important concept, under the effect of cortisol or steroids, everything goes down except neutrophils. Neutrophils actually go up. So that's what we're talking about. Why the total count is up. So neutrophils levels go up, everything else goes up. Okay. So this will come up again multiple times in the next few weeks because steroids use sort of treatment for so many different things. But I just thought since the question came up, just talk about it. All right. So now we said 2% of those leukemias are T cell leukemia, right? And what is that T cell leukemia? Hairy cell leukemia. Even here, 75% of the time it's still B cell origin, but 25% of the time it's T cell. So as compared to all the other ones where it was 98% before B cell leukemias, this is the one that has more frequently. It is a T cell. Now, how do you know it's hairy cell? The cells look like a hairy cell, right? So they have either fried egg appearance or they have this projection on the cells. Another clue for that is they are also trap positive or tartrate resistant acid phosphatase. Okay, trap positive. Okay. Treatment, we use cladribine. Cladribine is a purine analog. So let's use for treatment. Again, it inhibits enzymes. Purine analog inhibits DNA polymerase, or during DNA replication, it inhibits that process. Yes. So it's a T cell. Most of the time it's T cell because we talk about AML, ALL, CML, CL, they are all B cell leukemias. Majority of the time. There's only one that's frequently T cell, which is hairy cell leukemia. Okay, so if you see more T cells, 25% T cell origin, it is hairy cell, whereas all the other leukemias only 2% T cell origin. That's the difference. And how do you know it's T cell? You look for CD markers. And remember I said the CD markers for T cells are the lower numbers, 3, 4, 5. All right, now lymphomas, the other masses in the mediastinum, lymphomas. Just like leukemias, lymphomas are also B cell. So when we talk about Hodgkin's and non-Hodgkin's lymphoma, are they B cell or T cell? Predominantly, they are also B cells. Here too, there are two that are T cell. We'll talk about that. But Hodgkin's versus non-Hodgkin's. In Hodgkin's, the cells are, it's still B cells, right? CD15 and CD30 cells. And what do you see in Hodgkin's when you do a biopsy of the lymph node? Not sorry, Sky. All eyes, right? All eyes. Or these are called Reed-Sternberg cells, all eye cells. So these fractions present with lymphadenopathy, mediastinal lymph nodes, or it could also be other lymph node groups. It could be inguinal, it could be axillary, it could be cervical, different lymph node enlargement, and along with mediastinal lymphadenopathy and even splenomegaly. Marbel, question?
RS.
Reed-Sternberg.
Oh,
Non-Hodgkin's usually seen in immunosuppressed patients. So which means an HIV patient can develop non-Hodgkin's lymphoma. Okay? Non-Hodgkin's further classified into, could be follicular or Burkitt's. Translocation for follicular, 1418. Translocation for Burkitt's, 814. oncogene, BCL2 for follicular Burkitt's scenic. Okay. And for Burkitt's, another association is it can also be caused by a virus, Epstein-Barr virus, EBV, right? And that's where we see the starry scar, right? EBV-induced non-Hodgkin's lymphoma. If you look at a biopsy, and then under the slide, you'll see a starry scar appearance for non-Hodgkin's. So just again, a few clues for identifying Hodgkin's versus non-Hodgkin's. Okay. Again, these are all B-cell lymphomas. Okay. There are two that are T-cell. And what are those two? Mycosis fungoides. So this was initially thought of as a fungal infection. So it's a rash on the skin, but it's T-cell, right? When it's on the skin, it's mycosis fungoides. When it goes into the blood and becomes more systemic, then it's called Sézary syndrome. It's the same condition. If it's only limited to the skin, it's mycosis fungoides. And when it's in the blood, it's Sézary syndrome. Here, T cells, if you look at T cells, they have a slight dip or an indentation in their membrane. So they're called indented or crenated cells. Right? So that's the only association there with mycosis and Sézary syndrome. Only two lymphomas that are T cell in origin. Okay.
Excuse me.
Yes.
Please, which one is indented or crenated?
That's a T cell in both.
Okay.
I have a quick question. I just want to know for the BCL2, is that anti-apoptotic or I
That's
forgot.
oncogene. Oncogene. No, non-Hodgkin's. The Burkitt's is a type of non-Hodgkin's, right? So it's associated with non-Hodgkin's, not Hodgkin's. Not Hodgkin's, non-Hodgkin's. All right, so now moving on.
Please, did you say that Hodgkin's is CD what? CD 19 or something?
15 and 30.
Okay. Thank you.
With toxo? Toxo. I'm not sure. All right, we talk about thymus, right? Thymus. If there's a mass, mediastinal mass, a thymoma. It's associated with all autoimmune diseases except Graves, commonly seen with myasthenia. And in fact, thymectomy is also a treatment for myasthenia, right? They usually get better with thymectomy. Now, the other thing about thymus is these are pluripotent cells. So meaning it can develop into any like stem cell and then into any organ, right? Similarly, they are also immunoprivileged. So what does that mean, immunoprivileged? When they don't make antibodies, they've never seen an antigen, so they don't make antibodies. So it's usually beneficial if you need to do a transplant because there's a lesser likelihood of rejection, right? But we don't need to do a thymic transplant, but in case, so that's where it's important when you have a transplant and if you're not going to make antibodies against that new tissue, then there is a higher chance of it being accepted and not rejected. So which means, what are the other immunoprivileged sites? The eye, right? That's why they do a corneal transplant. What else? Brain. What else? Testes, right? So if you want to transplant any of these, it'd be pretty good, but you know, only problem is you good luck finding a donor, right? For any of these. Right, so those are immunoprivileged sites. Most common cancer is adenocarcinoma. Now let's come to another very important organ or gland, thyroid. Most common mass is a cyst, thyroglossal cyst or thyroglossal duct cyst. So where does the thyroid actually begin its development? In the floor of the mouth, right, by the foramen cecum. And then it migrates down to the front of the neck and that there is a track that it goes down by, that's your thyroglossal duct. Sometimes what happens that the duct is supposed to disappear. It doesn't disappear, it kind of stays back, and then it becomes a cystic dilation. So that's a thyroglossal duct cyst or thyroglossal cyst. And if it's a cyst, what does it usually have? All cysts have fluid. Now, if you leave a cyst with fluid in it for too long, what can it become now? Can it become an abscess? So any cyst anywhere, that's why what we try to do, we drain it, right? Because if it stays there for too long, then bacteria kind of settles in, and then it can become an abscess. So we don't want that happening. So basically, we have to drain that. Thyroglossal cyst. Now, tumor most common is follicular adenoma. Most common cancer is papillary carcinoma. The papillary carcinoma, we said that. What do we see there if you do a biopsy? Samoma bodies, right? Samoma bodies. What are the other tumors with samoma bodies? Louder. Telangioma. Another one. Serous one, yes. Serous cystadenocarcinoma, and yeah, that's a serous cystadenocarcinoma of the ovary. What else? Mesothelioma, right? Mesothelioma, meningioma, papillary carcinoma of the thyroid, and then serous cystadenocarcinoma of the ovary. Marbel, you had a question?
Yeah, please. What do you say is the tumor seen in the samoma bodies?
A papillary cancer. And then we talked about it earlier, right? Meningioma, mesothelioma, and serous cystadenocarcinoma of the ovaries. Something else you also see in papillary carcinoma, along with some other bodies. What else do you see? Orphan. And he had me clear, right? Because it's pushed to the side. It's empty eyes. You have a pair of eyes staring at you, but it's empty. Yes. Which one? Oh. Right. So the difference is in orphan ani, actually, it looks like this. Like it's empty in a way. But for Reed Sternberg, it's kind of like this. All eyes. So that's a difference. The nucleus pushed to the periphery. Yes. Epstein-Barr virus and CMV. Starry sky was EBV.
I see questions that have that server cells associated with
EBV, right?
I think so.
I can check on that. I'm not sure, not to my understanding, but at least I'll look upon that. Check. So what's the number one risk factor for a papillary carcinoma of the thyroid? Number one risk factor for papillary carcinoma. Previous, it's on the slide. If previous irradiation to the neck. Right? So radiation. So that's the number one risk factor. Someone who got treated for some other cancer, right? With radiation can develop papillary cancer now of the thyroid. Now, thyroid mass is very important. Two types. It could be cystic or it could be solid. Cystic, we talk about it, it could be a thyroglossal cyst. You can do an ultrasound to verify, and if it's a cyst, what do we do? Drain it, and you can send the fluid that you drained for diagnosis. Now, if it's a solid mass, you do a scan. Okay. Now, here there is an algorithm that we need to be familiar with. If you have a solid thyroid mass, we are trying to identify it as either hyper or hypothyroidism. If it is hypothyroidism, then what would TSH be? It would be high, right? Because of negative feedback, if it's hypo, TSH is high. Now, if TSH is low, right? When we do we have thyroid mass, you start with TSH. Now let's talk about a low TSH, which means now we are thinking it is a hyperthyroid situation, right? You have increased T4. Okay, hyperthyroid. So what do you do next? Radioactive iodine uptake. Right, so you do an uptake study. So we are trying to figure out What's the cause of that hyperthyroidism? Or why is the TSH low or why is T4 high? Right? You got three findings. It could be increased, it could be decreased, or it could be no uptake. Okay, so iodine, right? When you make thyroid hormones, you need iodine, right? You need PBG, and then there's iodination, and then you make your T4, then you convert it to T3. So when you do an uptake study, if the gland takes up all that iodine, what does it mean? It's working more, right? It's actually taking up all that iodine because it's active. It's hyperactive, right? So which means if it's hyperactive thyroid gland, what's the condition? Hyperthyroidism. And hyperthyroidism could be Graves' disease, it could be multinodular goiter, or it could be a solitary thyroid nodule, right? So that depends on how it's taken up. If the gland, this is radioactive iodine uptake, if it's diffuse, so the entire gland takes it up, you think Graves. If it's patchy, that's multi-nodular. If it's solitary, that's your toxic nodule. You just have one spot that takes up more, because that's only that spot is hyperactive. Okay, so now we know that's if you're taking up more with hyperthyroid symptoms, we know it's one of those conditions, and then we treat it accordingly, right? If it's Graves and hyperthyroidism, what do we usually treat it with? What are your anti-hyperthyroid drugs? PTU and methimazole, right? PTU and methimazole for treatment, that's fine. But if you are hyperthyroid, what are they at a higher risk for now? What's the most dangerous? Arrhythmia, right? Because they also have tachycardia. They can develop atrial fibrillation. And so therefore we have to be careful there too. And how do you manage the arrhythmia? Beta blockers. So generally, if it's in that line, and if it's hyperthyroid due to one of those conditions, then we use anti-thyroid medications along with beta blockers to prevent an arrhythmia and to bring down thyroid hormone synthesis. Because both PTU and methimazole, they block thyroid peroxidase. TPO, that's the enzyme that's used by thyroid gland to make T4. Okay, so that's that part. Now, if you have decreased uptake, they're hyperthyroid, but their uptake is still decreased. What does that tell you? Bob, your diagnosis. It's inflammation, right? They still have hyperthyroid symptoms, but the gland's still not taking up enough iodine. So that means there is inflammation. So inflammation, there are two conditions. Could either be decorvains or lymphocytic thyroiditis. So this is thyroiditis if it's decreased. Decorvains usually is post-viral and tender. So that's how you know it's decorvains. Whereas lymphocytic is post-partum. So somebody who just gave birth and a few weeks later, they present with hyperthyroid symptoms. And then that's postpartum thyroiditis, and it's painless. So that's how the pain is what you separate lymphocytic from decorvains. Or they complain of, a week ago, they had an upper respiratory infection, and now the person with hyperthyroid symptoms. And the thing with this is we don't really treat it because it's transient. It goes from hyperthyroid, then it becomes hypothyroid, and then it becomes euthyroid.
Yes. This is what Dr. Francis was talking about, that after birth, autoimmune problems are more common in women.
Correct. So during pregnancy, what's happening to the immune system? To tolerate the fetus, the immune system is suppressed, right? So all autoimmune conditions get better during pregnancy. But then after giving birth, now what's going to happen to the immune system? They are resetting. So there's a sudden surge in all these cells, and that's why lymphocytic. So lymphocytes suddenly go up and they go to thyroid, they damage the thyroid gland, and then inflammation, and that's why you see it postpartum. Okay, lymphocytic. And this is also because why are they hyperthyroid? Even though there is inflammation. What happens in inflammation? What happens to cell in inflammation? What's the first sign of inflammation? Swelling. Eventually, what's going to happen to that cell? It will burst. When it bursts, what's it releasing? So that's why your hyperthyroid symptoms, because these cells, inflammatory cells, once they are, these cells, they swell and they release. So this is due to release of preformed thyroid hormone during inflammation. That's why they are hyperthyroid. Okay, so that's your inflammation. Now, cancers, we're talking about this. If you have no uptake, that's cancers. Question?
Yes, I have questions.
Do you have a question, Marble?
Yeah, so I didn't understand this whole drawing, sir.
Which one?
This whole the drawing, this is the stuff you just drew now. I didn't understand anything there.
So
Your
we're trying
drawing, yeah,
okay.
Your sketch, or is it a sketch or something?
Right. So we're trying to figure out if you have hyperthyroid symptoms, there are different causes of hyperthyroidism. We're trying to figure out what is the actual cause of hyperthyroidism. Okay. So if your gland is making a lot of thyroid hormone by itself, it's active, it's hyperactive. Which means if you provide some iodine, the gland is going to use it to make thyroid hormone. So that's why in the first part, the uptake is increased. Okay, you have an increased radioactive iodine uptake because the gland is hyperactive. And if it's an hyperactive gland, then we know it's hyperthyroidism. And it could be Graves, it could be multinodular, or a solitary nodule. So basically, this is hyperthyroidism. Okay. In the same situation, if your uptake is decreased, it means the gland is hypoactive, right? As compared to the other side. It's not taking up enough iodine, although they have hyperthyroid symptoms. But why are they hyperthyroid then? Because the gland is going through an inflammatory process, and those cells in the gland which store the thyroid hormone, when they break down, they release that hormone. And that's why they have transient hyperthyroidism. But eventually, once the inflammation is treated, they go back to normal. So usually the treatment for these is just NSAIDs. You just do anti-inflammatory treatment for these conditions. So that's a hypoactive gland in inflammation. Okay. And then they have a third situation where the gland's actually cancerous. Okay. When it's cancerous, it's not going to take up any iodine. Okay. That's called your cold nodule. Whereas this is your hot nodule. So what are the cancers? Papillary, follicular, anaplastic, medullary. So those are the four cancers of the thyroid. The one with the best prognosis is papillary. And one with the worst prognosis is always going to be anaplastic, right? So papillary is the best, anaplastic is the worst. Okay, the other two in between. So papillary, we talk about papillary, previous history of radiation, often nuclei, some loma bodies, all that for papillary. If it's follicular, right? So something unique about follicular, this is the only one that breaks the capsule. So it goes far, metastasis. So local spread versus metastatic spread. If you have a thyroid cancer that has spread, think follicular, because this is the one that breaks the capsule. Okay. Medullary is a cancer of parafollicular cells of the thyroid. What does parafollicular cells make? Calcitonin. So calcitonin would be a marker for medullary. You have increased serum calcitonin. Okay, calcitonin is for calcium regulation, right? Inhibits PTH. So medullary cancer of the thyroid, you have increased calcitonin, and that's arising from parafollicular cells, and it's also seen in men syndromes, right? So medullary cancer, that's the association with medullary. And then anaplastic is just the worst form. So very poorly organized, rapidly dividing, poor mortality, right? High mortality, okay? So if you have a thyroid mass, a solid thyroid mass, this is how you would approach, yes. Tonin, yes, calcium increases. Because parafollicular cells make calcitonin. So when you have a cancer of those cells, you have increased calcitonin. Okay, so that's how you approach if it's a solid mass. Now, next to that, behind the thyroid gland, there are 4 parathyroid glands too, right? Most common tumor here is a thyroid adenoma. Now, parathyroid gland, what's the function of the parathyroid gland? It's for? Yes, which is for calcium regulation, right? So parathyroid hormone increases calcium and trashes phosphate. So this calcium, where does it draw calcium from? The PTH. Primarily, where does it draw from? Kidneys, DCT, right? Because do you want PTH to be drawing calcium from your bone all the time? No, right? It only does that when there is a deficiency of calcium. Then it has to pull from wherever possible to increase your serum calcium. But primarily, it draws from the DCT because the PTH receptor is in the DCT. And then it also draws from the bone when needed. Okay. Similarly, it also trashes phosphate. Where is that? In the proximal convoluted tubule. So it trashes phosphate, increases calcium. Okay. So if you have a parathyroid adenoma making too much PTH, what will they have? Hypercalcemia, right? And if you have hypercalcemia, what do they present with? Moans, stones, groans, bones, slightly overtoned. So PTH, what does PTH do in the bone? How does it pull calcium from the bone? PTH. It activates osteoclast, right? But does it work directly on osteoclast? No, it goes through osteoblast. So PTH binds to rank receptor. So it binds to rank L on osteoblasts, which activates it and then binds to rank on osteoclasts. Okay, so it has to go through osteoblasts to activate osteoclast. And they cause lytic lesions in the bone, right? Osteolytic lesions pull that calcium, puts it into the blood. Okay, so that's what PTH does. So this will be considered primary or secondary hyperparathyroidism if you have a parathyroid adenoma, based on what we said earlier. It's primary, right? Primary hyperparathyroidism. If it is secondary hyperparathyroidism, what would be a cause of secondary hyperparathyroidism? Oh, yeah, that's more like tertiary, but secondary means where else do you get PTH from? Where? Lung cancer, right? So secondary hyperparathyroidism and then tertiary hyperparathyroidism if it is chronic renal failure. Because if it's renal failure, you're not reabsorbing calcium, right? So what will calcium levels be? Low. So what will PTH levels be? High. So high PTH and low calcium, renal failure. High PTH and high calcium, primary parathyroid adenoma. That make sense? Yes? Sure. So if you have primary, so this here, when you talk about a parathyroid adenoma, It's primary hyperparathyroidism. So what would serum calcium be? High. What would serum phosphate be? Low. What would PTH be? High. Right? So that's primary hyperparathyroidism. What if it is renal failure? In chronic renal failure. Here we are starting with calcium because your calcium is low. You're not able to reabsorb calcium. You're not able to secrete phosphate. So now, based on feedback, negative or positive feedback, your PTH goes up in renal failure. Okay, so high PTH in both, but the calcium and phosphates are opposite when it's talking about primary parathyroidism versus renal failure. Leslie, question?
What was the secondary hyperparathyroidism about lung disease?
Lung cancer.
Lung
We're going to
cancer.
talk about it later, but lung cancer, small cell cancer, not small cell, squamous cell cancer of the lung.
Thank you, sir.
Okay, so there too, it'll be similar to primary because I'll just write that down here too. So increase PTH, increase calcium, decrease phosphate. Oh, right, correct. Increase PT, RP, and normal to decreased PTH. Right? You're right, correct. So PTRP is parathyroid related peptide, but it works exactly like PTH. But because it's going to reabsorb calcium and some phosphate, your PTH can remain normal or it can be decreased. So that's primary, secondary, and tertiary. The most common cancer here for parathyroid is also adenocarcinoma. So adenocarcinoma for all glandular tumors. And then this is also associated with the MEN syndrome. So MEN syndromes, you have MEN1, MEN2, and MEN3, or 2A and 2B, right? So what are these MEN syndromes? Yes, question there?
Yes, please, what is a PTRP? Is it peptide something?
Yeah, parathyroid related peptide.
Okay.
Bryce, question?
Yes, it's about the receptors rank L and rank. So you said rank PTH will bind to rank L on osteoblast, and then what happens?
Then they will bind to rank osteoclast.
Okay.
And then the osteoclast will then eat up bone.
Okay.
Okay. So what are these MEN syndromes? MEN1, pit parapan, right? Pituitary, parathyroid adenoma, and pancreatic adenoma. So that's in MEN1. So it's midline. Pituitary, you have parathyroid, and then you have the pancreas. MEN2 or 2A, you still have parathyroid, but now you also have medullary cancer of the thyroid and pheochromocytoma. Okay, for MEN2A, and MEN3 or 2B is medullary and pheo plus neuromas or marfanoid habitus. So marfanoid, tall, wide arm span, lens dislocation, all that kind of stuff. So marfanoid habitus with pheo and medullary is MEN2B. So here too, what's the relevance? It's like if you have one of these, so it means that your next step would be to screen them for the other tumors. Okay, if they have one. Yes, question?
Excuse me, please, what did you say right now about screening?
So if you have in MEN syndromes, let's say you're suspecting MEN syndrome because there was a family history and someone presents with a pituitary adenoma, you want to make sure you screen them for a pancreatic or a parathyroid adenoma also, right? Just because they have a history, you want to make sure that it's a solitary mass, or is it a syndrome where the other ones are also present?
Okay.
All right, parafollicular cells, we just talked about it, calcitonin, medullary carcinoma. So that's pretty much all what this slide is saying. So C cells, parafollicular cells, a marker for a medullary cancer, therefore, is increased calcitonin. Okay. All right, now the middle mediastinum. Middle mediastinum, what does it have? Mainly the heart. It has 3 layers. Endocardium, that's a smooth muscle. It also involves or includes your valves, endocarditis. So that's why we are in valvular conditions, right? So endocardium, then your myocardium, which is your strident muscle, and then your epicardium, which is your epithelial cell. And then you have the pericardium that covers the heart. Not too many things that happen here, mainly in the endocardium, smooth muscle, right? A smooth muscle tumor in the heart. It's a myxoma. Most often, where is this found? Which chamber is it seen? Left atrial. The left atrial myxoma. Now, this is usually seen in females too. How do they present? They have these fainting spells, right? However, when they faint and they fall, then they wake back up by themselves. So why does that happen? If it's a left atrial myxoma, when the atria is contracting during diastole, right? During diastole, you're trying to fill the ventricles. When the atria contracts, it's going to push that mass into the mitral valve opening. So what happens to left ventricular filling? Goes down. Stroke volume goes down. Cerebral blood flow goes down. They faint. But when they fall flat, what happens to that mass? It moves away. It kind of falls back. So then flow filling is restored and they wake back up. So that fainting spells where they wake back up spontaneously in a female, think left atrial myxoma. Now, when this mass falls into the mitral valve opening, it'll make a sound, right? Would it be a diastolic or a systolic sound? Diastolic, systolic. Diastolic, because it happens during filling, right? So diastolic sound. And that falling into that into the opening, it's a plop. That's why if you hear a diastolic plop in that with that history, think left atrial myxoma. Okay. Yes. When we get there. Right. So when let's say that someone comes to you with a history of the like fainting spells. So when you auscultate during diastole, you can hear that plop if it's big enough every time it falls into the, and it's not necessarily that they'll faint every single time, but they will have these fainting spells. But it happens because the mass is there, and it happens during that filling. Now, even if they faint, yeah, you'll still hear it. You can still hear it, correct. But with a small mass, it's not obstructing that much as compared to a larger mass. Then it's causing a bigger reduction in filling. Yes, question?
Okay. Did you say that in myxoma that it makes systolic sound?
Diastolic.
Okay, thank you.
Diastolic sound. So if it's smooth muscle, if it's cancer, then it is a sarcoma, right? So the myocardium, it's striated muscle. If there's a tumor there, it's a rhabdomyoma. Most common cancer is rhabdomyosarcoma. Now, we didn't mention rhabdomyoma and rhabdomyosarcoma, right? What condition do you see that in? Tuberous sclerosis, right? Rhabdomyoma. Tuberous sclerosis. So that's if it's a striated muscle. In the epicardium, yes. Yeah. Extrinsic connection basically is, what does extrinsic do to smooth muscle? It relaxes. So when you talk about a smooth muscle mass, so that's why it's seen mostly in, that's the estrogen connection there. Estrogen causing smooth muscle relaxation, causing that mass to grow, mass to fall, or to relax and drop into the opening. Now pericardium, right? We said pericardium, what happens in pericardium? That's the last place tumors are going to metastasize to, right? Because there's some blood there too. If you have a tumor there, it's a fibroma. A most common cancer there is mets, okay, or fibroma. Again, these are rare. You don't see that often, okay, fibroma. So that's the middle mediastinum, okay. So in the middle mediastinum, you also have the lung. So let's talk about the lungs. Most common mass in children, hamartoma. In adults, it's a granuloma, right? Granuloma, what makes up a granuloma? Macrophages, right? Macrophages are responsible for granulomas. And what's a granulomatous condition we talk about all the time? TB or sarcoidosis. So if you have a tumor in the lung, it's an adenoma. Most common cancer, like any other organ, it's always going to be mets. Okay. Intrathoracic cancer is squamous cell carcinoma. And then primary cancer, meaning it's coming off the lung itself, is bronchogenic adenocarcinoma. Okay, so let's actually look at these cancers.
So the intrathoracic not considered the primary. Like
Not the most common, no. It's because it's coming out of the airway. Squamous, right? It's airway. Whereas it is bronchogenic, it's coming from the lung itself. So lung cancers. Question? So lung cancers could be central or peripheral. What are the central cancers? You have a question?
Yes, sir. You said most common tumor, you say is adenoma. Example is mets. Did you say mets?
Yes. Overall, most common cancer.
Also, okay, what's mets, sir?
Most common cancer is mets.
Okay.
Most common tumor is adenoma.
Okay.
Oh, metastasis. Sorry, metastasis from somewhere else. Central cancers, both associated with smoking. You have squamous and you have small cell. And these are your paraneoplastic. So that's why this is important, because they may or may not present with pulmonary symptoms, but they can present with other issues. So we talked about parathyroid, right? Squamous presents with hyperparathyroidism because they make PTRP, parathyroid hormone related peptide. So increases calcium, decreases phosphate, and normal to low PTH. Okay. So in squamous, that'll be the presentation. Okay. Where in small cell, it could be a couple. Most common is they make increased ACTH. Second most common is ADH. And about 5% of the time, PTH and TSH. So generally, questions don't come about PTH and TSH when it's with small cell. Small cell, it's ACTH and ADH. So if it's ACTH, a small cell cancer that makes a lot of ACTH, what will they present as? Cushing's, right? Because ACTH increases cortisol. So they'll present with Cushingoid features. If it's ADH, what do they present with? SIADH, right? So those are the two that's important when it's Cushing's or when it's SIADH. Now, here, if there is increased ACTH, or if there is a person who's presenting with Cushingoid features, and just like in thyroid, we have to figure out where it's coming from, right? So what do we do to figure out where that cortisol is coming from? This is where we do the dexamethasone suppression test, right? So what do we do? What are we doing here? We're giving them some synthetic corticoid, so dexamethasone, and we're going to check if it's going to suppress the axis and reduce the cortisol that they have. Okay, so generally there are two ways of doing this. So you're going to see both in questions. You can either start with DST or you can start with ACTH. So let's talk about DST first. Okay, so the very first thing that you're going to do when you do the test, you're going to start with a low dose. Okay, If you give a low dose dexamethasone and if the cortisol is suppressed, what does that mean? Because that's what we are trying to figure out. Leslie?
No, I was going to answer. Sorry.
Yeah, go ahead.
If it's suppressed, maybe it's obesity, depression, or pregnancy.
Yeah, correct. So if you give a low dose, and that's low dose is enough to suppress the levels of cortisol, that means it's more physiological, right? It's not a pathological problem. So obesity can go up a little bit, depression can go up a little bit, and in pregnancy it can go up a little bit. But we can suppress it with a low dose. So that's fine. Now, if you give a low dose that's not suppressed, now it's pathological. So what's the next step then? You do use a high dose. Okay. And when you do a high dose, same two conclusions. Either you suppress it or it's not suppressed. Okay. If you give a high dose and if you suppress the cortisol, that means where is that cortisol coming from? Or what's the cause of that increased cortisol? It's actually a pituitary problem. Pituitary, meaning the axis is okay, so you're actually feeding back. All that excess dexamethasone is feeding back to the pituitary turn of ACTH. So the problem was the pituitary was making excess ACTH. We talked about pituitary masses, right? Pituitary adenoma. Pituitary adenoma that's making more ACTH, that is making more cortisol. Okay. So if it's not suppressed, that means it's not coming from the pituitary. Because for suppression to happen, it only works with the axis. If it's coming from somewhere else, then it doesn't work on the axis. So if it's not suppressed, you have two options. It could either be an adrenal adenoma, or it could be coming from the small cell lung cancer. So these are the two options. So then what do we do next? We do ACTH levels. Measure ACTH, because what is the small cell making? ACTH or cortisol? It's ACTH. So increase ACTH means it's lung. If it's decreased ACTH, means it's adrenal. Okay. So you need to know to interpret this study, because sometimes they describe what they did and the finding, and then you got to figure out what the patient has. Okay. The ACTH in the adrenal adenoma is decreased, suppressed, because the increased cortisol that's made in the adrenal gland negatively feeds back to pituitary and suppresses the ACTH. Okay. Yes. The whole thing? Yeah. So adrenal adenoma, where is the cortisol coming from? The adrenal gland itself. Right? And remember, in endocrine axis, there's negative feedback. So if the adrenal gland is making a lot of cortisol, it will tell ACTH to shut down. So this is the traditional way of doing it. So now you can also do it another way. Instead of starting with the DST, you start with measure ACTH first. So if ACTH is high, there are two problems. It could, well, if the ACTH is high, what's your diagnosis? No, ACTH is high, either lung or not adrenal, pituitary. Because ACTH is, where is ACTH made? Pituitary. In lung cancer, again, ACTH is made in the lung. If the ACTH is low, pretty much you're done, because there's only one diagnosis. It has to be adrenal. That's it. You can stop with that, right? Now, if ACTH is high, after this, now you can go and do the suppression test. Okay, so you can do it both ways. And you should be able to interpret both tests in a question. Any questions on that? Clear? Or I don't care? Correct. The small cell cancer of the lung actually releases, they make ACTH. Yes, question, Arbel?
Yeah, so please, did you say that if you do the ACTH and it's increased, you do the high dose DST, right?
Correct.
Okay.
Yeah.
Okay, please, this whole sketch, when it started from DST, whether it's suppressed or not suppressed, how did it come about? Is it from the cortisol or something?
Correct. Whenever they have increased cortisol or a patient presents with Cushing's, then this is how you figure out what is the cause of that Cushing's.
Okay.
Joshua?
Yes, so just simply, when you say suppressed or not suppressed in your chart, you're talking about cortisol suppression, not ACTH suppression, right?
Correct. Cortisol, yes.
Okay, thank you.
Paulo?
Yes, sir. Thank you. Would you be able to explain one more time why, when you measure ACTH levels and they are low, it would point towards an adrenal issue?
Sure. If you have the adrenal gland, remember we talked about the endocrine feedback. So the adrenal gland is making cortisol, right? And pituitary makes ACTH. So if your adrenal gland is making a lot of cortisol, it's going to feed back to the pituitary and inhibit it, because it's going to tell the pituitary, I have a lot of cortisol. I don't need you to kind of tell me to make more.
Roger, thank you.
Okay. All right. So now the next is ADH, right? SIADH. So in SIADH, you have too much ADH, right? But what does ADH do? Reabsorbs water, anti-diuretic hormone. So it makes you keep the water. Where does ADH work? In the distal part of the nephron, collecting duct, right? What does it do? We have ADH, it inserts, opens up aquaporins and reabsorbs water. If you have too much water, now what are you actually causing? A hypervolemic state, right? But when you look at SIADH, it is called euvolemic hyponatremia. Yeah? It causes hyponatremia, but it's euvolemic. So why is it euvolemic and why is it decreased sodium? So when you absorb a lot of water, right, your volume increases, so your serum gets diluted, sodium can fall because it's more dilutional. But if you have all this water being retained, what happens to venous return? Increases. What happens to the right side of the heart? Right atrium, right ventricle, they dilate. What does they make now? ANP, atrial natriuretic peptide. What's the function of ANP? Yeah, it actually dilates renal afferent and also makes you pee out more water, but also wastes some sodium. So although you're keeping water and then you're letting go of water under the effect of ANP, volume remains relatively normal. That's a euvolemia. But however, because ANP also wastes sodium, now you become hyponatremic. Okay, so this is also a situation where if you have SIADH, these patients can present with seizures. Why? Because of the hyponatremia. So that's why that hyponatremia needs to be corrected pretty fast so that it doesn't affect CNS. Because what happens if you lose a lot of salt from your body? What's going to happen in the brain? There's osmolarity difference, right? So if in the blood, all that sodium falls out, now which way is water going to move? It's going to move into the cells. It can cause central pontine demyelinosis. So that's why we have to correct. So that's something that can be seen in SIADH if it's uncorrected because of that hyponatremia, right? All they present with seizures or CNS symptoms. So anytime they present with CNS symptoms, you got to give them hypertonic saline, right? Or 3% saline. So in SIADH, what would serum osmolarity be then? It'll be low because you're reabsorbing water, plus you're losing sodium, right? Osmolarity is particles, so sodium, you're losing sodium, low. What about urine osmolarity though? It's high. Because you're reabsorbing all that water initially, right? So what a net change in urine osmolarity will be high, it'll be more concentrated. So urine is more concentrated, serum is more dilute in SI-ADH. So that's one way to kind of bring it back to, oh, somebody has lung symptoms or pulmonary symptoms, might be ADH, if this is what you're going to see in osmolarity, okay? The third paraneoplastic syndrome in small cell is Eden-Lambert, right? Eden-Lambert is because of antibodies directed against presynaptic calcium channels. Because only if calcium comes into the presynapse, you can move those acetylcholine vesicles down to the synapse and get it released into the cleft. If the calcium doesn't come into the presynapse, then acetylcholine is not released. Okay, so that's why they can present with Eden-Lambert syndrome, where they have antibodies against presynaptic calcium channels. Okay. How is this different from myasthenia? Yeah, acetylcholine, but that is postsynaptic, antibodies against postsynaptic acetylcholine receptors. So that's the pathology. And symptomatically, to remember, in myasthenia, they get tired throughout the day. And at the end of the day, they are more tired. Whereas in Eden-Lambert, they get better towards the end of the day. Okay. So those are your lung cancers and your paraneoplastic syndromes. Yes. No, not PTH, but the small cell carcinomas. Yeah, not the hormones, just the cancer itself.
Excuse sir.
Yes.
So please, you said ADH antidiuretic hormone. That means it doesn't. It takes water away, right?
It keeps water in your body. It's too much antidiuretic, antidiuresis, so inhibits diuresis, which means you don't pee, you keep the water in your body.
Okay, please, what did you say about envelopmic hyponatremia?
So SIADH, because even though you're reabsorbing all that volume, because the body compensates by A and P, it helps you pee out that excess volume. So you're actually, even though you're gaining volume, you're also losing volume, and that's why it's euvolemic. Because if you drink more water, if you have more water, what are you going to end up doing? You're also going to go to the bathroom more often, right? You're not going to keep it. You're going to keep trying to pee it out. Yes.
Okay. Please, what is the first and second paraneoplastic syndrome, please?
First and second, one is with Cushing's with ACTH. The other is with ADH, and the third is Eden-Lambert.
Okay.
Okay.
Thank you.
So even though there is compensation, so one general principle overall in medicine is your body compensates to some extent. There is never 100% compensation, no matter what, in any situation. So that's why we check the urine and serum osmolarity, because although there's euvolemic, when you check osmolarity, that's what's going to tell you, oh, is it ADH? Is it DI? Is it somebody who's drinking a lot of water? You know, all these different conditions. So you look at the osmolarity between serum and urine. Okay.
What's the connection? Small cell carcinoma and the antibody.
So this cancer, right? It's what you call, when you say paraneoplastic, the small cell cancer induces antibody production. So your body makes antibodies. But these antibodies are specifically directed against this presynaptic calcium channels. Okay. All right, so those were central cancers. Peripheral cancers, bronchogenic adenocarcinoma and bronchoalveolar adenocarcinoma. And here, bronchoalveolar is the only one that's not related to smoking. All the other ones, number one risk factor is smoking. Okay. Just like we said, risk factor, primary smoker increases with amount and duration. So how much and for how long? Radon, that also increases the risk for lung cancer. Even secondhand smoke increases the risk for lung cancer. And finally, pneumoconiosis. All of them increase the risk except anthracosis. So the side stream and mainstream is just, I mean, it's not really clinically relevant, but all it's trying to say is, if you had an option to inhale secondhand smoke, let's hope you don't. But if you do, would it be side stream smoke or mainstream smoke that you would choose to inhale? The mainstream. So all it means is the one that has gone through the filter, right? So someone who smoked it and then you blow it back out, that's relatively less toxic than the smoke that comes off the cigarette directly, right? So that's the mainstream and side stream smoke. But don't inhale either, right? That's a better way. Stay far away. All right, so now let's talk about pneumoconiosis, right? Different pneumoconiosis, all of them increase lung cancer risk except anthracosis. So what is anthracosis? Not anthrax. What is anthracosis? Inhalation of coal dust, right? So all of these are considered interstitial lung diseases, right? Because what does it affect? Does it affect the airway or does it affect the parenchyma of the lung? It affects the parenchyma or interstitium. So these are all interstitial lung diseases. If it's interstitial, would it be classified as an obstructive lung disease or a restrictive lung disease? It'll be a restrictive lung disease, all right? So all of these are interstitial and they are restrictive lung disease. So when you say restrictive lung disease, is the trouble, they have trouble breathing in or trouble breathing out? In. So they cannot breathe in. So breathing in is a problem. So if it's breathing in, the problem is going to be, what will PO2 be? Low, right? Restrictive lung disease, trouble breathing in, PO2 is low. If your oxygen levels fall, what's your medulla going to tell you to do? I mean, that's not the medulla, that's somewhere else. What's the medulla tell you? What's in the medulla? Your respiratory center, right? So whenever you're short of oxygen, what are you going to try and do? Breathe more, right? Try to get in more oxygen. So increases respiratory rate. And that center is in the medulla, right? And then if you increase respiratory rate, what happened to CO2? It lows. So what happened to pH? Increases. It's respiratory alkalosis, right? So this applies to all restrictive lung diseases. So which means in all pneumoconiosis, this is what you will see in your ABGs, okay? So anthracosis is coal dust. And it leads to lung fibrosis, okay? How about asbestos? Occupational, right? What kind of occupation? Construction, yeah, roofers, plumbers. Also an interstitial lung disease. But what do you see here though? Ferruginous bodies, right? So what are these ferruginous bodies and what do they look like? They're dumbbell shaped ferruginous bodies. And what is it made of? Yeah, macrophages that have ingested iron and asbestos particles, Trojan's bodies. Now, if you do have asbestosis or exposed to asbestos, you are at a higher risk for developing bronchogenic. It's still bronchogenic. Yeah, there is. So if you have mesothelioma, what's it caused by? Asbestos. But if you have asbestosis, it still increases risk of bronchogenic first. Mesothelioma is number 2. So you still have an increased risk for bronchogenic adenocarcinoma. And then secondly, increases for mesothelioma. Okay. Remember that. It's always still a higher risk is for bronchogenic. Silicosis, what does that due to? Sandblasters, so those who work in like glass mines. And here, when you do a lymph node exam, eggshell calcifications. Okay. Eggshell classification. So you see those cracked egg-like appearance. And if you do get silicosis, it also puts you at an increased risk of tuberculosis. Because what does it do? It actually silicosis, there is macrophage apoptosis. So which means now you don't have any macro, because TB, what cells help you defend against TB? Macrophage, T cells and macrophages, right? Now in silicosis, macrophages get eaten away. What's going to happen? Now you're left with low macrophages. That puts you at an increased risk for tuberculosis. Pessinosis. You don't hear about that very often, but cotton. So those who work in textile industry or in plantations and stuff. And finally, berylliosis. Electronics and aerospace. In berylliosis, something else that's unique is they cause, or you see non-caseating granulomas. So which now means that you have to also differentiate this from sarcoidosis, exactly, right? So berylliosis, non-caseating granulomas, similar to sarcoidosis, but obviously there will be some occupational risk factor or exposure in the question, right? Or some of the other things associated with sarcoid will be also be seen. All right, so those are your pneumoconiosis. Like we said, all of these will increase your risk for lung cancer, right? Except lunchtime, except anthracosis. Yes, Syed, question?
Yes, quick question on how in silicosis, how exactly are the macrophages eaten away? Like by what exactly?
So eaten away in the sense they are destroyed, silica itself, right? Because these are all inhaled, right? So silicon particles, they destroy macrophages.
Okay, thank you.
So now we talk about treatment, right? Most of these have poor prognosis. Only if the lesion is less than 2, and if there is a mismatch, then we do surgery, right? A VQ mismatch. So what is a VQ mismatch? Ventilation to perfusion. So in a lung, when we divide into 3 zones, right? In general, right? When we look at the lung, which part of the lung is well ventilated always? The top or the bottom? Air, where does air go? Top or bottom? It goes up, right? So the alveoli, they're always well ventilated, but your blood flows like this. Let's say there's blood flow there, right? On the other hand, which part of the lung is well perfused? Is blood flow, right? At the bottom. So bottom is going to look like this. The vessels are bigger. And plus that's where they're going to pick up the oxygen too. So more blood is going to come there to pick up that oxygen. Now, only thing is when you're breathing in, so these alveoli at the bottom, they also open up. So at that time, when you're breathing in, you have a lot of oxygen in the bottom also, because that's where you're going to diffuse now, right? So when you look at this VQ ratio, we're talking about this particular pattern, because ventilation is oxygen here, and then perfusion is the flow, right? So which means at the apex, what would the VQ ratio be? High, low? It'll be high, right? Because ventilation is high at the apex. I mean, yeah, the apex. So the ratio is high. Whereas at the base, what will the VQ ratio be? Low. In the middle, they're kind of matched. Okay. So when you average it all out, the normal VQ ratio is about 80% or 0.8. So we don't need a number, but just to make a point, it's 0.8. So any variation from this 0.8 is called a mismatch, a VQ mismatch. So which means if you have a ventilation defect, can you have a mismatch? Yes, right? If you have a perfusion defect, can you have a mismatch? So what will be an example for a ventilation defect that leads to a mismatch? What kind of lung disease? Or where would the problem be? If it's ventilation that's affected? The airway, alveoli, so collapse, right? If the alveoli collapses, what happens to ventilation? It goes away from that side, right? What would be an example where perfusion is affected leads to a mismatch? Perfusion. Not areas. Primary embolism, right? Embolism means there's a clot that's going to block this pulmonary vessel, right? So it affects perfusion. So whether it's perfusion defect or a ventilation defect, it can cause a VQ mismatch. So basically, if there is a mismatch in the lung, in the context of lung cancer, and a mass that's less than 2, then we do surgery, right? So this will all be talked about more in pulm. Yes, question?
Can you explain the sketch, sir?
Sure.
Yeah,
So
thank
here,
you.
we are talking about the lung and the different zones in the lung, right? The apex and the base. At the apex of the lung, there is more ventilation and there's low perfusion, means less blood. Blood, goes to the bottom of the lung, air rises, so goes to the top of the lung. So more air on top, less blood on top. At the base of the lung, there's less air and more blood, right? And when we look at the ratio between this ventilation and perfusion, we get a 0.8. Now, if there is a lung disease, which causes a change in this number, that's when we say there is a VQ mismatch. And that's why in pulmonary embolism, what's that test to diagnose pulmonary embolism? A VQ scan, right? We do a VQ scan in the diagnosis of pulmonary embolism. Why? Because we know that there's going to be a mismatch, right? So similarly, if the airway, there are some airway diseases where, the alveoli is collapsed, that will also affect this ratio. So anytime there is a difference from this 0.8, we say there is a VQ mismatch. So that's what we're trying to explain with this graph. Okay. And if it's a small cell cancer, we generally use chemo radiation. A long time ago, we talked about chemo radiation being effective for anaplastic cancers, right? So the small cell it's an anaplastic cancer. It's pretty bad. So that's why we use chemo radiation for treatment. Okay, let's just do pleural cavity and then we take lunch. So most common tumor in the pleural cavity is a mesothelioma. So no, what are the clues for mesothelioma? Ferruginous bodies, psammoma bodies, and pleural thickening. Even if you don't see ferruginous and psammoma bodies, but if you have a lung mass and you see pleural thickening or pleural plaques, okay, either thickening or plaques, that'll be a clue for mesothelioma. Okay, from a bronchogenic, yes. Yes, so ferruginous bodies are macrophages that have ingested some asbestos particles and iron. Okay, and they look like dumbbells. All right. So the nose too, then we'll get to the GI right after this. So in the nose, most or nasopharynx, most common mass is a polyp, right? So if there is a polyp, then you have to be careful when you give them NSAIDs, right? Because they might be sensitive and they can develop asthma symptoms, right? So avoid NSAIDs because what do NSAIDs do? They block the what pathway? The COX pathway, right? So then everything shunted to the LOX pathway, leukotrienes. And remember, leukotrienes are very potent bronchoconstrictors. So when you use NSAIDs, if you're shutting down prostaglandin synthesis by turning on the COX pathway, then means you are shunting most of the, what you call substrate to the LOX pathway, and they make leukotrienes. And leukotrienes, your BE, although they are all bronchoconstrictors. So that way you can induce an asthma attack. Same thing if you see a lot of polyps or if you see nasal polyp, what's the other condition that you also have to screen for? Cystic fibrosis, right? So those are the two associations with polyp. Most common tumor is a fibroma, and most common cancer is nasopharyngeal carcinoma. Here too, there's an EBV association, right? EBV, we talked about EBV with non-Hodgkin's or Burkitt's lymphoma. And the second association with EBV is nasopharyngeal cancer. And it's also commonly seen in the Asian population. This is because of their diet, because of the smoked and curated meats and all that, so nitrates, right? They can also increase the risk. And there's also, I think in the Asian population, there is also increased incidence of EBV. So those are reasons why it's seen in that particular group. Okay, all right, question?
Please, why do we have to rule out cystic fibrosis in polyp?
So it's also an association. So cystic fibrosis, along with all the other symptoms, pancreatitis and all the other respiratory infections, they can also have polyps. So if you see a polyp, you want to make sure that they don't have an associated cystic fibrosis. That's all. It's just because it's seen in CF. All right, ready for lunch? I am. But, all right,
So you're ready.
lunch is back at 1:15 or 1:20. So good?
Okay, 1:20.
Enough time
Yeah.
for a nap? Right, so. Good, good lunch. All right. So now let's move into the GI system, okay, all the cancers of the GI system, starting with the oral cavity. Most common tumor here is a fibroma. Okay, and most common cancer, squamous cell carcinoma. Now this can be anywhere in the mouth, right? Floor of the mouth, lower lip, tip of the tongue, and the number one risk factor here is still tobacco, like smoking, chewing tobacco. So these are your risk factors. So it could be anywhere in the mouth. All right, so esophagus. So the rest of the GI tract, it's made up of smooth muscle. So all the tumors all the way down, most common, they're going to be leiomyoma, because we're talking about smooth muscle, right? So leiomyoma all the way down from the esophagus, small intestine, large intestine, it doesn't matter. It's all going to be leiomyoma. Now the esophagus, most common cancer is squamous, right? And in the esophagus, cancer we can actually look at it as the upper 2/3 and the lower 1/3. In the upper 2/3 of the esophagus, most common cancer is squamous cell. In the lower 1/3, and that's what we talk about Barrett's, it's going to be adenocarcinoma, right? So if there is an ulcer that doesn't go away, if there's a mass in the proximal part of the esophagus, it's most likely squamous. And it's a distal part of the esophagus, it is adenocarcinoma. Okay. Now, risk factor. Outside of smoking, you also have Barrett's esophagus. So how do these patients present if you do have a mass? They're going to have dysphagia, right? Dysphagia basically means difficulty swallowing. They might also have a dinophagia, which is painful swallowing. Okay. So a mass, dysphagia can be from different causes. You can have a mass or even motility disorders that can cause dysphagia, right? So what's one way to separate, like for example, achalasia, for example, from dysphagia due to a mass? So you look at how that dysphagia has progressed. So whenever we talk about dysphagia, which started out with solids, and then it progressed towards solids and liquids, that points towards a mass, right? Because initially the mass is small, so liquids can go around it, but solids have a difficult time going through. But if they have a problem with both solids and liquids at the same time, then it's more of a motility disorder. Because if it's achalasia or scleroderma or something like that, then what's the problem? Both liquids and solids will be difficult to swallow, right? So that's one way to symptomatically, complaint-wise, you can separate it. Yes.
You're saying starting with Barrett's, they first start off, they can't swallow with difficult to swallow, and then can't swallow?
The other way. Can't swallow solids.
Can't swallow solids.
And then it progresses to both liquids and solids, if it's a mass, if it's cancer.
Okay, but then if it's like neuromuscular or
Exactly.
it's swallowed at the same time.
It's both, because it's generally swallowing, right? Motility, it doesn't matter whether it's liquid or solid, they just have trouble swallowing. So we also talked about Barrett's earlier, it's a metaplasia, right? Metaplasia, we have to now start monitoring them. So once they have Barrett's, we're going to have to do a screening endoscopy every 3 to 5 years. So it's not become dysplastic yet, but we're going to screen them if they have Barrett's every 3 to 5 years with an endoscopy. Okay. Now, when we do this endoscopy, if we find low-grade dysplasia, now that becomes more frequent. Remember, we said low-grade means we're still not going to do anything other than control the risk factors and all that. We're not going to intervene And we're going to just keep an eye to make sure it doesn't progress. So here now you're going to do more frequently, 6 to 12 months. Okay, so the screening is important. If it's Barrett's, how often would you screen the patient? Every 3 to 5 years. If it's low-grade dysplasia, how often would you screen? Every 6 to 12 months. And then if it's high-grade dysplasia, then you have to treat it. That's when you treat. Okay. And generally, these cancers of the esophagus, they have a poor prognosis overall. Again, proximal, squamous, distal, adeno. Okay. Endoscopy. Even when somebody comes with GERD symptoms, right? Initially, you're not just going to scan them, right? Or scope them. We always start off, what's the first line? When somebody comes to you with dyspepsia or GERD symptoms, what do first? Yeah, give them a trial of PPIs first. And then unless they have what we call alarm symptoms, right? Someone comes to you with GERD, but at the same time, they're talking about, every now and then they see blood in their, vomit or sputum, or they have loss of weight, things like that, then you might have to go straight and screen with an endoscopy. But if none of these are there, just GERD, then start with PPI. And then even after that, it doesn't go away, then you want to also check for Helicobacter. And then we go into your endoscopy and all that. So in the stomach, what's the most common tumor? All through GI, most common is going to be leiomyoma, a smooth muscle, leiomyoma. Cancer, adenocarcinoma. Now, stomach cancer, based on metastasis, you have the left supraclavicular node that's going to be felt, and that's called the Virchow's node. Okay, the left supraclavicular node. And if you have a left supraclavicular nodal enlargement, most likely it's going to be a GI cancer, and that to a stomach cancer. Okay. Now, what does the stomach look like? Leather water bottle appearance. Lionitis plastica. Basically, it's losing the rugae and it becomes kind of like flat. So it loses all that lining and the rugae. And you also see signet ring cells. Signet ring cells basically are these cells with nucleus kind of pushed to the periphery here. Because the entire cell is made up of mucin, right? So the cell gets full of mucin, pushes the nuclei to the periphery, giving the appearance of a signet ring cell. Okay. Now, these cancers can also metastasize, right? And one place they can go to is the ovaries. When it goes to the ovary, so let's say that someone has an adnexial mass, a female with an adnexial mass, an ovarian mass, right? When if you have an ovarian mass, what's your next step? Like a solid ovarian mass. You always take it out, right? You never biopsy an ovarian mass, right? There are some masses you don't biopsy, right? Testicular mass, ovarian mass, you don't biopsy. If you have a hard mass there, you take it out, okay? So ovarian mass, let's say someone has an ovarian mass, and then you do surgery, you take it out. And then when you do a study in the, what you call in the lab, PAT, you see signet ring cells. So that tells you what kind of mass it was, right? So what kind of tumor it was then, if it you signet ring cells in the ovary? It's from the stomach, exactly. So it came from the stomach. So it's not a primary ovarian tumor there. It actually came from the stomach. And this particular tumor is called a Krukenberg tumor. So that's a Krukenberg tumor is an ovarian mass that has come from the stomach. But there are like 10 different kinds of ovarian cancers, right? But those are primary ovarian cancers, which are from the cells in the ovary itself. But this, it's not from the ovary itself, it's actually coming from the stomach. And one way to know that is you see signet ring cells. Now, if you have a mass in the stomach, obviously it's going to lead to early satiety, right? You're going to eat as much. And that's why you have a lot of weight loss, because you're going to have early satiety, you're not going to eat as much. Risk factors in general for upper GI cancer: smoking, number one, alcohol, nitrates, and again, Japanese, that kind of goes along with nitrates too, the diet. Okay, and there's also a higher prevalence of EBV in that population, right? So along with this, one more mass in the stomach, one more benign tumor in the stomach. A maltoma. This is a lymphoma, just like the lymphomas we talked about. What kind of lymphoma would this be? B cell or T cell? B cell. Any lymphoma, primarily B cell. This malt lymphoma, so mucosal associated lymphatic tissue. So that's what MALT stands for, malt lymphoma. And OMA is your benign, your naming we talked about earlier. So it's still benign. But the number one cause of this is Helicobacter, right? That's the actual cause. So that's why if you have a maltoma, the treatment for a maltoma is to treat the bacteria. Okay? Helicobacter treatment is how you treat maltoma. Okay. So how do we treat Helicobacter? Triple therapy. And what are the first line for the triple therapy? Clarithromycin, amoxicillin, and a PPI. Okay, so 3-drug regimen triple therapy: clarithromycin, amoxicillin, and a PPI. If they are resistant to amoxicillin or penicillin allergy, then we can use metronidazole. Okay, so we do this for about 4 to 6 weeks of treatment, and then, or even before you start treatment, how do we check for Helicobacter pylori? Urea. So you do that, you treat it. Now, after treating for 4 to 6 weeks, now you want to check whether you've eradicated this bacteria. How do we check for that? You can still do urea blood test, or more often it checks stool for antigen. So stool antigen for Helicobacter is how you check to see if treatment has worked. And let's say you check the stool antigen and it's still there, then what can we do? We can add a 4th drug to this, which is bismuth. Triple therapy plus bismuth. And we only worry about chemotherapy if all of this have failed and the maltoma still persists, then we think about chemo at that point. But usually this is all what we need to do for treatment. Okay, so that's another lymphoma in the stomach or a stomach mass. Now moving down into the small intestine. Most common, again, leiomyoma, cancer adenocarcinoma. Most common cancer of the ileum is a lymphoma again. Most of your lymphatics in your GI is concentrated in the ileum. So that's why a lymphoma is common in the ileum, because that's where you see all this lymphatic tissue. Yes, question?
You said that in penicillin allergy that we use which drug?
Metronidazole.
Okay, metronidazole. Okay, thank you.
Rice?
Yeah, so after the first therapy has failed, how long do we use bismuth in addition to the therapy?
Until you eradicate, until you find it gone.
Okay.
Yeah. So the initial period is to see if you need the 4th drug. That's why we do periodic every few weeks. We're going to check for stool antigen. Anytime, and once you figure out that it's gone, it's come down, then you can stop it. So if you have a mass in the intestine, anywhere, whether small intestine, whether large intestine, it doesn't matter. What kind of symptoms will they cause? It's a mass. Obstruction. We'll have distension, constipation, maybe not passing gas, all these kind of obstructive symptoms because it's a mass, right? And along with that, the lesion itself would be like a napkin ring. So basically all that means is that the mass here will kind of pull the center towards itself in a way, and then it looks like a napkin ring. You know, you have a ring that goes around the napkin in restaurants, as you see. So you have a constriction in the middle, and both edges are like opened up.
On what is that?
That's when there is a mass.
But on what, like X-ray or?
X-ray imaging. Napkin ring lesion, or the other way to talk about it is this. Sometimes they talk about it, refer to this as a apple core.
Same thing.
Same thing. Right, but narrowing in the middle with both proximal and distal ends dilated. Apple core lesion or a napkin ring lesion. Okay. Now this could be kind of anywhere in the small intestine, or even once it goes in the large intestine too, it's the same finding on Gross exam or on imaging. Next part is the appendix. Still smooth muscle. The most common is leiomyoma. Most common cancer is a carcinoid, right? Carcinoid. So if you have a carcinoid in the appendix, right, what would they present with? No. So there is two things. There's carcinoid tumor and there's carcinoid syndrome. The tumor in the appendix, it will not cause the syndrome. So tumor in the appendix will lead to appendicitis. So they'll present with appendicitis symptoms because it occludes the lumen of the appendix, right? Whereas if it's carcinoid syndrome, what's the most common location of that tumor then? Pancreas or ileum, right? So, or in other words, the carcinoid tumor in the pancreas or the ileum can metastasize and can lead to carcinoid syndrome. So they put out excess of serotonin. Whereas the tumor in the appendix stays local. It doesn't metastasize. So there, the symptom will be inflammation and appendicitis and then appendectomy, right? The most common cause of appendicitis is what? Fecal, right? So this will be another cause of appendicitis, and that's what you do. Now, these patients are making a lot of serotonin, right? So if they have if it's carcinoid syndrome, what would they present with at that point? Serotonin. What is serotonin? How does serotonin act in your GI? It's parasympathetic, exactly. So diarrhea, increased motility. So they're going to present with flushing, diarrhea and things like that, right? So that's carcinoid syndrome. Now, because they're putting out a lot of serotonin, what do they make serotonin from? What amino acid? Tryptophan, right? What else do you make from tryptophan? Niacin. So if all of it is getting shunted towards serotonin, what happens to niacin? They can develop niacin deficiency and they can present with pellagra. So that's another manifestation of a serotonin syndrome because of that shunting. Most of it is used up for serotonin, less available for niacin, can develop vitamin or niacin deficiency. Okay, so something else to keep in mind. Now, how do we check for this? Just like we did for few, serotonin also has breakdown products. If you have excess serotonin, all those breakdown products of serotonin will end up in the urine. So we check the urine for 5-hydroxy-indole acetic acid, 5-HIAA. That's a breakdown product of serotonin. So we look to check in the urine for that, and that's how you confirm it. Yes, question?
Please, sir, you said I think is in the stomach or small intestine. You said that most lymphatics are what? I didn't get what you said.
Lymphatics are in the ileum.
Okay, thank you.
Just a location. Shri?
So you were saying that carcinoid syndrome causes a decrease in the niacin, which could cause niacin deficiency. Is that why the symptoms and the presentations are very similar? Like with the diarrhea and the...
So in niacin deficiency, what are the symptoms? Pellagra, what do you see?
Diarrhea, dementia, and dermatitis.
Dermatitis, right? So that's again for niacin deficiency. in carcinoid syndrome, you can have, let's say, the carcinoid syndrome part of it. It can also overlap with pellagra, right? They can be there simultaneously, concurrently. They can occur together also, right? Depending upon how much has been used up and what the level of deficiency is.
Thank you.
Joshua?
So just for clarification, does carcinoid cancer in the appendix have elevated serotonin?
No.
Okay, no, just from the ileum and pancreas with carcinoid
Correct.
syndrome. Okay,
Yes.
thank you.
Yep. Mhm.
Sorry, the link between carcinoid tumor and carcinoid syndrome, what was it?
Carcinoid tumor is in the appendix, right? But this carcinoid tumor in the appendix will not cause carcinoid syndrome. But a carcinoid tumor in the pancreas and in the ileum will cause carcinoid syndrome.
Okay.
In the appendix, only cause obstructive symptoms. Everywhere else, it causes your GI symptoms. It can also metastasize.
But if you take a biopsy of a carcinoid tumor, either in the appendix or the pancreas, the biopsy will be the same. So is it like
Yeah,
the
same tumor, yes. It's a neuroendocrine tumor, right? Remember we said earlier, enterochromaffin cells. So the cell type, what it's made of will be the same. But it's just that it's localized rather than causing a syndrome. Syndrome means you have to have more, it has to cause some effects, right? That's not there. Leslie?
Yes, but it's still gonna present with niacin deficiency or only with the carcinoid syndrome in the pancreas and ileum?
Yes, only when it's carcinoid syndrome and then putting out a lot of serotonin, it can eventually lead to niacin deficiency. Not always, but if it's not treated, eventually it can lead to niacin deficiency.
Thanks.
So if you want to treat it, how do you treat it? How do you turn it off? Yes. So even if it produces, it doesn't get into the blood and doesn't go everywhere else. It stays within the appendix. That's it. So if you want to turn it off, what do you give them? Octreotide, somatostatin analog, right? Because it turns off pretty much everything in the GI. So octreotide to turn off those secretions. But if it's in the appendix, then you have to do an appendectomy. If it's serotonin syndrome, you start out with octreotide. All right, now in the colon. Most common tumor? Leiomyoma, right? Cancer, adenocarcinoma, the same exact appearance. Napkin ring lesion, the apple core. Now, only other thing here is because it's going into the colon now, it will also affect the consistency of stool also. So pencil thin stools. Because of the mass, the stools not form bulky. So you'll have pencil thin stools and melena. Now, as you go into the colon, you have bleeding, right? Remember we said, anytime there's blood, you always rule out cancer also in your difference, especially with an older person. So there is bright blood and there is dark blood, right? So there is maroon blood and there is bright red blood. So maroon blood is more dark blood. That's melena. So if it's melena, where is it coming from?
Oh.
Where?
Oh no, from the
Upper,
yeah.
upper GI, right? Melena means upper GI. Bright red blood is okay. So that's why here, more proximal it is, the darker it's going to be. More distal it is, the brighter it's going to be. Okay. So colon cancer is the third most common cancer. What's the most common cancer in males? Prostate. What's most common in females? Breast. What's the most common cause of mortality in males? In females? Lung, right? Mortality wise, lung across both, but incidence wise, prostate is most common in males, breast is most common in females. Risk factors for colon cancer: low fiber diet and a high fat diet. And then polyps and ulcerative colitis, so inflammatory bowel disease, Crohn's and ulcerative, but ulcerative has a higher risk for turning cancerous. Okay, inflammation, mutation, and then eventually can become cancers. So let's talk about polyps, different polyposis syndromes. Benign polyps, the one that rarely becomes cancerous. Those are Peutz-Jeghers syndrome. So you have hyperplastic polyps here. It's a benign hyperplastic polyps, usually seen in children, when it is in association with hyperpigmentation of the mucosa. That's called the Peutz-Jeghers syndrome. Okay, but these are mainly benign. And then you have two that are malignant, the bad ones. Familial adenomatous polyposis. So this is a hereditary condition. They have literally hundreds to thousands of polyps in your GI. And it's a real bad situation because 100% of the time, it turns malignant. Right? 100%. There is no chance it's not going to be malignant. It's kind of probably the only time where you're going to say 100% in medicine in general, right? It turns malignant. So that's why if you have this, they start sigmoidoscopy at a very young age, starting at 12 years of age, and you do yearly sigmoidoscopy. And majority of the time, by age 20, you do a prophylactic colectomy, right? Because it is going to turn malignant. It's just a matter of time, right? So most of the time you do that too, prophylactic colectomy. And what's the mutation here? When you go from polyp to cancer, what's the first thing that goes wrong? APC, right? APC, remember we said earlier, is a tumor suppressor gene. So first thing that goes wrong in the development of the polyp and the polyp becoming a cancer is APC. So now tumor suppressor gene is inactivated. They continue to divide. What's the next thing that happens? Now you have an oncogene takeover. Your KRAS comes and takes over. This is an oncogene now, continues to mutate. And then the last is P53, another tumor suppressor, which is inactivated. So in the progression of a polyp to a cancer, this is the mutation, the course of the mutation that happens. APC inactivated, KRAS activated, P53 inactivated. Yes.
Is this for all colon?
Polyps that become cancer, the cancerous ones.
Any polyp that becomes cancer
Correct.
in the colon?
Right. So even polyps, there are villous polyps and there are tubular polyps and there's tubular villous, right? Which one has a higher chance of becoming malignant? Villous one. So this has happened mostly in that particular one when it turns cancerous. Now these polyps are also seen in two other syndromes, Gardner's and Burkitt's, with other tumors. In Gardner's, it's mostly bone tumors, right? Osteomas and sebaceous adenomas, if it's Gardner's, bone tumors. In Burkitt's, it's brain tumors and polyps. Okay, so brain tumors and polyps, Burkitt's, bone tumors and polyps, Gardner's. Okay. Then another one is Lynch syndrome. This is non-polyposis, so hereditary non-polyposis colon cancer. That's HNPCC or Lynch syndrome. So here the mutations are MLH1, MSH. These are the genes. 2, MSH6. These are a few of them. Few of the mutations in Lynch syndrome. Okay, they may or may not have polyps or very few polyps. What is the problem here, though? It's a DNA repair defect. So they have inability to repair DNA defects. And even with Lynch syndrome, there are a few cancers that are most prominent. So if you have a patient who comes to you with, let's say, a colon cancer, and when you take a family history, they talk about an aunt having another GI cancer, a mom having what you call endometrial cancer, maybe a sister having ovarian cancer. When you see these cancers in the family, that leads to, that kind of tells you it is Lynch syndrome. So the most common cancers you see in Lynch syndrome, along with colon cancer, is other GI cancers, endometrial, which is most common, and ovarian. Okay, so these are the cancers that occur together, not in one person, but within that family, everyone will have a different cancer. Or these are the cancers that you're going to see, and that will kind of point towards Lynch syndrome. Okay. 1 and 2, it's not very significant between Lynch 1 and 2. Just know what Lynch syndrome is in general, HMP, CC. Okay. And that's why when you do colonoscopy, if you see polyps, then you have to take a biopsy to see what kind of polyp it is. And then depending upon that, you have to continuously screen them to make sure that it doesn't become cancerous. Liver. Now, most common mass in the liver is a cyst, a hepatic cyst. Tumor is an adenoma, or can also have an angioma, hemangiomas, right? Hemangiomas are basically what? Vascular malformation, right? Enlargement of a vessel. So that can also happen in the liver. But like any other organ, most common cancer is what? Even in the liver. It's all metastasis. Okay. Most common primary cancer. Now we're talking about a cancer that's originating from the liver itself. The hepatocellular adenocarcinoma. Okay. Yes. Yes.
Yes, sir.
It's originating from the liver itself, liver tissue itself. Is there a question?
Yes. Lisa, what do you say about brain and you something? Is it something about brain and bone tumor?
Yeah, so that's on this slide. If you have bone tumors with FAP, the polyps, that's Gardner syndrome. If you have brain tumors with polyps, that's Turcotte's syndrome.
Okay.
Hepatic adenomas, most common cause, OCPs, right? Or even injected steroid use. Oral contraceptive pills. So what's the danger of having, whether it's a cyst, whether it's a hemangioma, or even adenoma in the liver? It can rupture when intra-abdominal pressure increases. So for example, someone who gets pregnant and you have the cyst in there during pregnancy, because of intra-abdominal pressure is increasing, these can rupture. So these rupture, then they can lead to shock, like hemorrhagic shock, and then increase mortality. That's an adenoma. Now we also have AVMs. AVMs are arteriovenous malformations, right? So you have an artery that's bringing oxygenated blood, and you have a vein that's carrying deoxygenated blood. It's a vein, this is an artery. So in the arterial system, what's partial pressure of oxygen? What's normal partial pressure of oxygen? Normal PO2. Minimum is 60, but it's usually very high, so 80 to 100. Right, because it's completely oxygenated. It hasn't been delivered to the tissue yet. Once it delivers the oxygen to the tissue, and then it goes back to the lung as deoxygenated blood, what's PO2 there? It's less than 60 millimeters of mercury, right? So 80 to 100 high in the arterial system, less than 60 in the venous system, because the tissue has extracted the oxygen it needs. Okay. Now, when you have an AVM, what's going to happen? This blood from the arterial system is going to get shunted towards the venous system, right? So what happens to that oxygen in the venous system? It goes high, right? So PO2 here now, when you have a shunt, it goes up, right? PVO2, right? That's in the venous system, PaO2 in the arterial system. Okay. So which means now when you look at AVO2 difference, what's going to happen to the AVO2 difference when there is an AVM? Right? It decreases. Yes. Arterial oxygen minus venous oxygen. Normally, let's put numbers in there. Let's say that PO2 normally in a normal person is, let's say 95, right? And we said it's less than 60, so let's say 60 in a normal person. So what's the AVO2 difference here? It's complicated math. 35, right? I mean, that's very high. That's not normal. So normal AVO2 difference is about 15. But anyway, 35. Okay. So now let's say that you have a shunt. What's going to happen to the 60? It becomes, let's say it becomes 80. What's happening to the difference now? It's 15. So what happens to the AVO2 difference? It went down. So that will be an example in a shunt. So when the AVO2 difference decreases, that means that oxygenated blood is getting to the venous side. Okay. Or in other words, your venous oxygen level goes up. Now, along with this oxygen that goes across, what else gets sequestered? Platelets, right? Platelets, there are more platelets in your arterial system than the venous system. There are more clotting factors in the venous system than the arterial system, right? So that's why when if you look at clot prevention, right? If you have an MI or if you have an arterial clot, what do you generally give? To prevent an arterial clot, what do you give them? To block platelets. Aspirin, right? Whereas we have DVT, do you give them aspirin? What do we give them? Heparin, right? Because now we are blocking the clotting cascade. We're blocking clotting factors. In the arterial system, we use platelet blockers. In the venous system, generally we use anticoagulants, right? So here we're also sequestering platelets. Now, if all the arterial plates goes in the venous system, now what are you at a higher risk for? For platelets are getting sequestered to the venous system. So now arteries can bleed. You're getting rid of platelets. So you're at a higher risk of bleeding, right? So AVMs, higher risk of bleeding. Okay. Plus, those AVMs themselves can also burst because this is not a normal vessel, right? It's a weaker connection. The second thing, if I'm shunting all that volume to the venous side, what are we doing to venous return? Venous return increases, right? Venous return increases, what will happen to cardiac output? Will increase. So if you leave it alone and don't do anything about this AVM, and the heart's kind of trying to push out more blood, that excess volume, the heart's working harder to push it out, right? Eventually, what's going to happen? What's going to happen? Heart failure. So this is an example for high output heart failure. So generally, when you talk about heart failure, what's cardiac output? Any type of cardiogenic shock or heart failure, it's not pumping blood forward, low cardiac output, right? Now there are some exceptions are high output heart failure, but that's not that there is high output when the heart's failing, it's because of high output that's leading to heart failure, right? MI can lead to heart failure, but that's just the heart stops pumping. So this is one example, an AVM is an example for a high output heart failure. What's another common example for a high output heart failure?
Oh, very good.
Leslie?
Vitamin thiamine B1 deficiency.
Very correct. You get your point too. Another one. Hyperthyroidism. Leslie.
Hypervolemia.
Hypervolemia usually doesn't happen because as long as you're peeing out by itself, it can, but not that often. But something else. Not renal failure, but pregnancy, sure. Not renal failure. Renal failure is because low cardiac output goes to renal failure. We're missing an important one or a common one here. Somebody said shock. Somebody outside? Said shock. What kind of shock? Septic shock. Leslie?
Anemia?
Anemia. There we go. Chronic anemia. And there's one more. Yes. Hydropsis from no, that's what's that? RH, right? Our incompatibility. Thalassemia, alpha thalassemia. Not cirrhosis. Not hypoxia. I mean, there's one more. I'll just say it. It's Paget's disease. Bone. Paget's disease of the bone. So these are all examples of high output. So why in Paget's disease there is high output? Let's see. Concept. I know after lunch is not the time to work too hard in your brain because no blood there, but still, let's try. Let's try. What's happening in Paget's disease? What's the pathology there? Yes. Increased bone turnover. So what do they need? So how does that energy get there? More blood. So where does the blood come from? Tiny blood. That's it. So Paget's disease is because there is osteoclastic and osteoclastic activity. That's why you see that marble bone. So both of them are working very hard. So it's rapid bone turnover. It needs a lot of energy, needs a lot of blood. So what does the heart do? It will start compensating to send them more blood. That's how it eventually gets into heart failure. Paget's disease of the bone. Okay. So all those are the exact exceptions when you talk about heart failure, all the causes of high output heart failure. Okay. Now these AVMs can be present. So what's the most common cause of an AVM? How does the connection develop between an artery and a vein that's running side by side? Most common. Yeah. Fistula, how does that fistula form? Non-infectious disease. Non-inflammation. I mean, how do you connect this? If you want to connect like two things side by side, what do I need to do?
Dialysis?
Dialysis, you make a fistula, correct. That's made for the purpose of dialysis, but that's trauma, right? Even needle sticks. So somebody's trying to, inject a vein and they actually go all the way through and inject into the artery also. The needle goes through the vein into the artery. Now you form a fistula right there, right? So trauma is the most common cause of fistula. Even like a road traffic accident, something goes into, something goes into your artery and then also traverses the vein. Now you connect to the fistula. So most common cause of that is trauma. But there are also some syndromes where you see a lot of fistula or AVM formations. And those are your Osler Weber-Landau and von Hippel-Landau. But however, this name has been changed. Hereditary hemorrhagic telangiectasia. So that's how it's referred to as now. These are both AVM syndromes. So these are present from birth. Hereditary hemorrhagic telangiectasia. So in HHT, you have lots of AVMs in the brain, GI, and pulmonary circulation, right? So what's the problem if you have all these AVMs in the brain? What are they at your risk for? Any AVM anywhere. Bleeding, right? They can burst. So if you have a young person, somebody, let's say, who's 35, no risk factors, presents with a hemorrhagic stroke, what are you looking for? What are you looking for? One of these conditions, because there's no reason why a 35-year-old with no risk factors should get a stroke. So when you have a young person with a stroke, then always think about one of these, what you call AVM syndromes, okay? And then there's also von Hippel-Landau. Here, there are lots of AVMs in your abdomen and cerebellum. Again, it's still in the brain. but likely in the cerebellum. Okay, those are two. Now, VHL also has other tumors, cancers associated with it. They have renal cell cancer, along with all these areas. Okay, so that's one way to differentiate VHL and HHT. HHT, they also have telangiectasia. So along with these AVMs, you have those dilated vessels in the skin. And you will see like the, spider angiomatosis. Sometimes we talk about that, right? So you have dilated vessels in the skin, telangiectasias. Whereas in VHL, it's a renal cell carcinoma, okay? So here again, a question would be, what else would you do? So let's say somebody has VHL, right? But they didn't say anything about renal cell carcinoma, right? But they just say, you know that it's VHL. What's the next thing you should do? If you have a patient who comes to you, you did a workup, and you identified it as VHL because it's family history, whatever reason it is, what's one extra thing that you have to do now? You have to do an ultrasound, right? This is that kind of a question where what's the next thing you do? So you have to do an ultrasound to figure out if they have any renal issues. Okay. Yes, question?
Yes, sir, please. What do you say? How do we treat the VHL, please? I didn't hear you.
So we can't really treat it, right? Because it's an AVM in the brain. You can just monitor it.
Okay, thank you.
What are the risk factors for liver cancer? Smoking, still number one for most cancers. Alcohol, hepatitis B, C has a higher risk. Then parasite, schistosoma, Manzoni, aniline dyes, aflatoxin. So these are all other toxins, vinyl chloride, and benzene. So all of these exposures are related to a higher incidence of liver cancer. Okay, vinyl chloride specifically, it leads to an increased incidence of angiosarcoma. Okay, but remember the parasite thing. No parasite. It is parasite. Schistosoma Manzoni. Okay. Now let's talk about the rest of the hepatobiliary system. So the gallbladder, liver, common bile duct, cystic duct, pancreatic duct, the pancreas, and then duodenum, right? So bile in the liver, bilirubin is conjugated, right? And then this bilirubin goes through the intrahepatic ducts, goes into the hepatic extrahepatic duct, goes into the common bile duct, some stored in the gallbladder as bile, and the rest excreted into the duodenum, right? From there, all the other things happen now. So here, let's say that someone presents with loss of weight, jaundice, and the gallbladder is inflamed. What else? Most of the bilirubin, when you do check lab values for bilirubin, it's conjugated. What are you thinking the problem? Where do you think the problem is? If it's conjugated. So conjugation has already happened. It'll be outside the liver, right? Because if it's conjugated, that's elevated. That means liver has already conjugated it, right? But then it's not going anywhere else, because what's happening to this conjugated bilirubin? It goes into the GI. There it gets converted into urobilin, stercobilin, and then you get it excreted through the urine and stool, right? So that process is not happening. So which means there is an obstruction to flow of conjugated bilirubin, and that obstruction has to be outside the liver, right? It can be in the liver too, but in the intrahepatic ducts, because the liver has conjugated it, but the ducts are occluded, and I can't transport it. Here we talk about two autoimmune conditions, okay? Primary biliary cholangitis. So it used to be called PBC, or primary biliary cirrhosis. Now it is primary biliary cholangitis. So PBC stays at least, but it's cholangitis. So this is an autoimmune condition usually seen in females, right? And what's the antibody? Anti-mitochondrial antibody, right? Autoimmune condition, anti-mitochondrial antibody, usually seen in females. This affects the intrahepatic ducts. So that's a clue. Intrahepatic ducts in PBC. Okay, these ducts are occluded. Now, if the other autoimmune condition that's seen in males is primary sclerosing cholangitis, what's the antibody here? The ANCA, right? Primary sclerosing cholangitis. For primary sclerosing cholangitis, the obstruction can be intra or extra. So both. So if you see both intra and extra occluded in a male in the context of elevated bilirubin, what's the condition? PSC. If you only see intra occluded autoimmune condition, it's PBC. Okay. So now, along with that, obviously we said your bilirubin is going to be elevated, right? Normally, what's normal serum bilirubin? What should it be? Pretty low, about 1 to 2 milligrams per deciliter, right? And it's equally split between conjugated and unconjugated, right? Half and half. So depending upon where the pathology is, you can either have both elevated or one elevated. Now, in both situations, over a period of time, both of them will be elevated. However, the clue to figuring out what the actual problem is, between the two, which one is elevated to a higher extent. So let's say that serum bilirubin is 10, okay, measured as 10. Unconjugated is 7. Conjugated is 3. Conjugated normally should be about less than 1. Unconjugated normally should also be less than 1. But both of them are elevated here. But which one is elevated to a greater extent? Unconjugated. So it means the primary problem will be before the liver, right? Liver or before the liver means they are not conjugated. Now, if I switch these numbers with the same 10 and say this is 3 and this is 7, now what's the problem? It's conjugation. That means it's extrahepatic, right? So even though both are elevated, the one that's elevated to a greater extent will tell you what the primary problem is. Yes, question?
Yeah, can you explain more on this the conjugated and unconjugated, the this figure you gave, the 3, 7 and the 10, please?
Sure. Normally bilirubin is the breakdown product of, where do you get bilirubin from? Hemoglobin, right? Heme plus globin, and then globin gets recycled and heme is broken down into biliverdin, which becomes bilirubin, right? So this bilirubin is unconjugated, but to get it excreted, we don't want unconjugated bilirubin to accumulate, right? Because if it accumulates, it's a fat soluble compound. So that's how you get jaundice, because it gets into the skin, gets into the eyes, because it's fat soluble process membranes. We don't want it to accumulate. How do we get rid of it? It goes to the liver, it gets it conjugated, and then gets it excreted. So if that conjugation is not happening in the liver, then you're going to build up unconjugated. And if you have an obstruction later on, extrahepatic obstruction, even though you're conjugating it, you're not getting rid of it. It can stay in the body and cause symptoms related to that. Okay, so that's the numbers we're talking about. Normally, it should only be 1. Total should be 1 to 2, and unconjugated and conjugated should be equally split, 50% of each. But let's say that your total is 10 and unconjugated is 3, but conjugated is 7. Although both of them are elevated, since conjugated is elevated to a greater extent, the problem is obstruction. Right? When you have conjugated elevated, think about an obstructive pathology. When you have unconjugated elevated, think about a conjugation defect. So maybe the enzyme is missing, maybe it's not getting there, maybe there's hemolysis, too much breakdown where conjugation is not happening adequately, all of those causes, or prehepatic. Okay, so now we are talking about this in the context of cancers, right? So let's say I gave you a scenario earlier, right? If you have a lot of conjugated bilirubin elevated, they might also get jaundice because if you have a lot of conjugated, eventually unconjugated will also go up because you're backing it up, right? Plus, gallbladder is enlarged. Okay. Where do you think the pathology is? Approximately in this picture. It's obstructive. So what could be obstructing that? Stone, but in stone, that's correct. But in the context of cancer, what kind of cancer? Pancreatic cancer. Yes, pancreatic cancer. Because if you have a mass in the pancreas, let's say, there's a mass here, it's going to obstruct, compress the common bile duct, where you're draining the conjugated bilirubin in the duodenum. So head of the pancreas. That's why in pancreas, you think of a pancreatic cancer when a patient presents with painless jaundice, right? They have jaundice, but they don't have any pain. And because that common bile duct is obstructed, now can the gallbladder secrete bile there? Doesn't do that, right? So all the bile is backing up into the gallbladder. What will happen to the gallbladder? It'll also be enlarged. It'll be a palpable, non-tender gallbladder. Why is it non-tender? Because it's not a gallbladder pathology. There's no actual inflammation in the gallbladder. It's just that it's like a balloon. I'm filling it with more and more bile, and it becomes palpable. That's actually called Courvoisier's sign, right? A palpable, non-tender gallbladder with elevated conjugated bilirubin and jaundice. Look for a pancreatic cancer. Okay. Now you can also have cancer of the gallbladder. So all these cancers we're going to talk about. Gallbladder cancer. So what are the risk factors for gallbladder cancer? I think that's the next slide. Gallbladder. Most common, it's still a muscle, right? So leiomyoma. And if it's cancer, adenocarcinoma. So what are the risk factors for gallbladder cancer? Starts out with cholelithiasis. That's just gallstones, right? If you have gallstones that have not been addressed or treated, eventually what will happen to the gallbladder? Cholecystitis, right? Now it becomes infected, it becomes inflamed. You still when you have cholecystitis, you have to remove the gallbladder at some point. But let's say you didn't do it. I don't want to take my gallbladder out. Yeah. So cholecystitis, it was treated with antibiotics, pain, all went away. Then again, it happens. It went away. What's going to happen eventually? If you have all this inflammation continuously happening over a period of time, what's going to happen to that gallbladder? It gets fibrosis. And that is called a porcelain gallbladder. And that's a thickened and calcified gallbladder, porcelain gallbladder. And these are all risk factors for gallbladder cancer. Along with all of this, there's also an infection, a bacteria that puts you at a higher risk for gallbladder cancer. Which bacteria? Who likes to live in the gallbladder? Salmonella. Okay. So those are all the risk factors for gallbladder cancer. Cholelithiasis leading to cholecystitis, which leads to a porcelain gallbladder, which then can lead to cancer, or even chronic infection with salmonella can also lead to gallbladder cancer, right? So that's a gallbladder there. Then the biliary tract, common bile duct. That's cholangiocarcinoma, right? Cholangioma, if it's benign, cholangiosarcoma or carcinoma, based on where it's coming off, and that's affecting the gall, common bile duct. Most common mass in the common bile duct is a choledochal cyst. So going back to the picture, so choledochal cyst is a cyst right here. At the terminal part of the common bile duct, where the bile duct enters the duodenum, there's a cyst, right? This is sometimes seen as a newborn too, choledochal cyst, a new cause of newborn jaundice. If it's choledochal cyst, would they have elevated conjugated or unconjugated bilirubin? Conjugated or unconjugated? Conjugated. Whereas because it's outside the liver, it's at the terminal part of the common bile duct. It's not affecting conjugation. So if you have a cyst there, that's choledochal cyst, that has to be surgically corrected. Okay, it can be seen, like I said, in newborns also. Any pathology with the common bile duct, whether it's primary biliary cholangitis, primary biliary cirrhosis, or even primary sclerosing cholangitis, any pathology with the bile duct, along with bilirubin, what else will be elevated? What's the other lab enzyme? Alkaline phosphatase and GGT. Right? Question? Maribel?
Yeah, please. You said oh, I forgot what I want to actually. I'm sorry, I've forgotten.
No problem, no problem. Okay, so alkaline phosphatase. Where else do we get alkaline phosphatase from? The bone. When there is increased bone turnover, also you get alkaline phosphatase. So that's why if we have alkaline phosphatase elevated and we don't know where it's coming from, what do we do next? We do GGT. And if GGT is also elevated, then we know that alkaline phosphatase is due to a common bile duct pathology. If GGT is normal, we know that alkaline phosphatase is due to a bone pathology. Right? So make sense? So those two we talked about already, cholangitis and cirrhosis. Yes, Eric?
Just a quick question, I might have missed it. For choledochal cyst, that does not necessitate a stone in the duct, correct?
Not as a cyst, but if it's a cyst, you're actually having stasis, right? So eventually it can lead to a stone formation.
Okay, gotcha. Thank you.
Yeah, that's why we usually, when we have a cyst, we usually remove it. Yes, go ahead.
Yeah, excuse me. Yeah, I forgot. You said it affects conjugated bilirubin. Please, can you tell me the reason again, please?
So bilirubin is two types, right? Conjugated and unconjugated. And we have to conjugate the bilirubin to get it excreted. So if you have a problem with excreting bilirubin, it's most likely going to be conjugated, that's elevated. Okay? Conjugated in obstructive causes, unconjugated in pre-hepatic causes. Even in the biliary duct, there's a parasite that puts you at a risk for cholangiocarcinoma, right? And that one is Clonorchus. It's a fluke. I think it's what's called liver fluke. Clonorchus sinuses. So Clonorchus for common bile duct, Salmonella for gallbladder, Schistosoma Mansoni for liver, EBV for nasopharyngeal and Burkitt's. Right, so these are infectious associations with cancer. Okay? And also, you're asking about, we're talking about non-Hodgkin's and owl-like, right? Hodgkin's and owl-like. So actually, CMV is not in relation to Hodgkin's by itself. So cytomegalovirus infection by itself, you can see owl-like in the cells. But that's separate from Hodgkin, sir. It's not anything to do with Hodgkin. Then pancreas, most common cyst, most common mass is a cyst, tumor, adenoma, adenocarcinoma is a cancer. Now we talked about all that. What happens in pancreatic cancer? They have cholestatic jaundice. They block the biliary tract, high direct bilirubin. Risk factor, smoking. Number one risk factor is still smoking. This is a very mucinous cancer. So because of that, one of the presenting symptoms of pancreatic cancer is a hypercoagulable state. And they have clots that form all over their body. And it's called migratory thrombophlebitis or Trousseau's syndrome. Right? Trousseau's syndrome is seen in pancreatic cancer. And that's because, one day they'll have a clot in the veins of your leg. Then it'll be on the other leg. Another day it'll be in your upper arm. Somewhere else another day, right? So it cannot move around. That's because they're hypercoagulable. Why are they hypercoagulable? This mucin interacts with platelets and makes them stick to each other. So that's how they get these clots. Yes, question? So that's hypercoagulable. That's why they're in a hypercoagulable state, and you see all these clots. Okay. Now, these clots that are formed, if they get displaced, they're the veins, right? Eventually, where can they end up? In the heart, right? You can go to the heart and then sit on your valve and can lead to endocarditis. In pancreatic cancer, that's another problem. These clots, platelet and fibrin clots, those masses can go through your venous system, go into the heart, and go into your venous return, and then can go into your valves and cause non-infectious endocarditis. Because generally, when we talk about endocarditis, it's bacterial, right? So, for example, if IV drug user, what's the bacteria there? Staph aureus, right? If it is IV lines or the central lines, what's the bacteria there? What's that? Epidermidis, right? If it is from a tooth extraction or extraction, like a root canal, somebody root canal ended up with endocarditis, what's the bacteria there? Viridans, right? If somebody had a colonoscopy and ended up with endocarditis, what's the bacteria there? Bovis, right? So these are all, usually when we talk about endocarditis, it's infectious endocarditis. This is one cause of non-infectious endocarditis, where what's sitting on the valve is not vegetation. It's actually a mass made up of, what's a mass made of? Platelets and fibrin, okay? Non-infectious endocarditis. There's also another condition where you see non-infectious endocarditis. What's a condition? SLE. What's on the valve in SLE? Immune complexes, exactly, right? So that's also an example for non-infectious endocarditis where you have immune complexes, so antigen, antibody, complement, immune complexes deposit, and that's called verrucous endocarditis. And this is merantic endocarditis. And there's a name for that too, like in lupus, Liebman-Sachs endocarditis, right? So that's immune complex deposition on the valves. Two causes of non-infectious. This one here is merantic endocarditis in pancreatic cancer. In lupus, merantic. In lupus, it is Liebman-Sachs. Liebman-Sachs endocarditis, verrucous.
And then which type of pancreatic cancer is diffuses? All of them?
Pancreatic adenocarcinoma. Yep. Yep. Yes, question?
Yeah, please, can you spell the Liebman-Sachs? Can you give me the spelling, please?
Sure, Liebman-Sachs, SLE, right? What type of hypersensitivity is SLE? 1, 2, 3, 4. The immune complex, it's got to be 3, right? Type 3 is immune complexes. So, autoimmune, you make these immune complexes, they are in your blood, right? And they travel around. And eventually, where can they settle down? On your heart valves. So when these immune complexes settle down on your heart valves, that's limb and sac endocarditis in lupus. Okay. Now, pancreas has different cell types. They have alpha cells, they have beta cells, they have delta cells. What do alpha cells make? Glucagon. So if you have a tumor of the alpha cells, it'd be glucagonoma. What would they have? Glucagon. What's the function of glucagon? Their role is to increase glucose, right? The opposite to insulin, right? Insulin will decrease, glucagon will increase glucose. How does glucagon increase glucose? Glycogenolysis, gluconeogenesis. They also induce ketogenesis, right? So you can also see ketones. Ketogenesis. So elevated glucose, lipids, and ketones in glucagonoma. Another unique finding in a glucagonoma, or a clue for glucagonoma, is a skin rash. And that's called migratory. Again, it moves around. Necrolytic erythema. Generally seen in skin folds, so axilla, groin, neck, right? But it can be seen anywhere. This is a rash which becomes macules, becomes pustules, and then they crust. And so if you see these rash in the presence of elevated blood glucose, think glucagonoma, which is a tumor of your alpha cells. Okay. Beta cells in the pancreas too. Beta cells make insulin. So if you have a tumor of the beta cells, they have a lot of insulin. So what will they be presenting with? Hypoglycemia. So they come and complain of, they faint all the time and blood sugar falls, right? So when you look at differentials, it could be an insulinoma or pancreatic tumor, or it could be that they are abusing insulin too, right? Because if you inject yourself with too much insulin, or if you inject insulin and forget to eat, then you can also have these fainting episodes. Yeah, pancreatic cancers, right? So it could be pancreatic tumor, correct. So insulinoma, increased insulin, hypoglycemic spells. So generally, when you want to, before you confirm it's an insulinoma, you also want to check for, you want to measure insulin levels, or you want to measure actually what levels? C-peptide levels, right? You want to make sure that it's not someone who's injecting themselves with insulin, in which case C-peptide levels would be low. If you're injecting insulin, C-peptides will be low, but if it's an insulinoma, C-peptide is high, okay? Somatostatinoma, these are from your delta cells. So glucagonoma, alpha cells, insulin, beta cells, somatostatin, delta cells. Okay. Somatostatin, what's the role of somatostatin in your GI? It turns off everything, right? All your secretions. So therefore, if you have too much of somatostatin, what you're going to end up having? Everything dries up, constipation, right? Achlorhydria, so no acid secretion in the stomach. You won't have any acid. And then constipation. So these are symptoms of somatostatinoma. Then you have a vipoma, VIP. What's the function of VIP? It increases secretions, right? So which means if you have increased VIP, they're going to end up with diarrhea. What kind of diarrhea? Secretory diarrhea, right? So diarrhea can be secretory or osmotic, right? Osmotic diarrhea, secretory diarrhea. What's the fastest way to figure out which one is which? What do you tell the patient to do? Not just water, everything. NPO. Because osmotic means something is pulling, right? So if you don't put food into your GI, it will stop. So when you go on NPO, and if the diarrhea stops, it's osmotic diarrhea. If you are on NPO, diarrhea continues, that means it wasn't osmotic. It's more secretory. So that's the fastest way to kind of figure out whether it's osmotic or secretory. Okay. Now, this is one cause of secretory diarrhea, right? Viapioma. Then we also have gastrinoma. Normally, where does gastrin come from? Stomach. G cells in the stomach, secretes gastrin. But now in the pancreas, you can have these cells, right? That's Zollinger-Ellison syndrome or a gastrinoma, a gastrin secreting tumor in your pancreas. So they'll have increased gastrin. So what will they be now complaining of if you have increased gastrin? What's normal function of gastrin? Increases acid. So if you have too much gastrin, even though it's coming from the pancreas, what's going to end up causing? Ulcers. So a patient who presents, and when would you think a gastrinoma? Not a person who presents with a gastric ulcer or duodenal ulcer. Anytime you see multiple duodenal ulcers. Because most of the time when you talk about gastric ulcer or peptic ulcer disease, yeah, you might have one ulcer, right? It's unlikely that you're going to have multiple ulcers in your duodenum. So multiple duodenal ulcers or a jejunal ulcer. Okay, multiple duodenal ulcers or a jejunal ulcer, think gastrinoma as the cause, right? Because excess of gastrin secretion. Okay, so how do we test for gastrinoma? First step is always to measure gastrin levels. You want to know if the gastrin levels are normal or high. And in these patients who have a gastrinoma, the gastrin levels are obviously going to be high, right? Okay, fine. Now, how do we know whether this gastrin is coming from the stomach or this gastrin is coming from the pancreas? So what's the next test? We do a secretin challenge, right? Normally, what does secretin do? Secretin is from the duodenum, right? What's its normal function? It turns off gastrin. When food's in the stomach, you have a lot of gastrin. When that food comes to the duodenum, the stomach is empty. Do we need to make more gastrin? You get ulcers if you do make it, right? So who tells that gastrin to turn off? It's secretin from the duodenum is inhibitory to gastrin in the stomach. That's normal. So if you have a gastrinoma or Zollinger-Ellison syndrome, when you do a secretin challenge, it actually does the opposite. It increases gastrin. That's how we know it's a gastrinoma, right? When you give secretin to a person who has a gastrinoma, it increases gastrin levels. And that's gastrinoma. Okay. Even with this, any of this, first step in medical management is always going to be, we're trying to turn off all secretions, right? Octreotide. So all of this, first thing will always be, first medication or medical management will be octreotide. Okay.
I have a
Right.
question.
Yes, question?
Yeah, sir, please, you said that somatostatin, what does it do, sir, please?
It inhibits all GI secretions. So it dries up your GI tract, causes constipation, it inhibits pancreatic enzyme, so it also causes malabsorption. It decreases acid secretion in the stomach, so it leads to achlorhydria. All of that from somatostatin.
Okay, so what do you say about you mentioned something about osmotic and secretory diarrhea? Then what do you say about secretory diarrhea, please, sir?
So that's VIPoma. This watery diarrhea here is a secretory diarrhea because it's more watery. Okay.
Okay.
Now, there is also an osmotic diarrhea, but osmotic diarrhea means it's an osmotic pull. So if you have food or something is actually pulling the water and then causing the diarrhea. So that's an osmotic diarrhea. Secretory diarrhea means your volume is actually being secreted directly into your GI tract. And that VIP does that. It increases secretions. Okay. All right, now, ovaries. Most common mass is a cyst. So what's the problem if you have an ovarian cyst? What's it at a risk for? Yeah, a couple of things. Any cyst anywhere, it can become an abscess, right? Second thing is it can rupture. And third thing here, more importantly, it can cause torsion, right? Which is an emergency at that point. So ovarian cyst, most of the time, if it's small, you don't do anything. And even if a small cyst ruptures, you still don't do anything, right? We don't really consider it peritonitis unless there's a large cyst and you have large volume and then you go into shock, then yes. But generally, if you're a simple cyst rupture in the ovary, we don't really do anything. That fluid is going to get absorbed. Okay. Now, but if it goes into torsion, now that's a problem, right? Most common tumor, serous cyst adenoma, cancer, cyst adenocarcinoma, right? And this one is very malignant. And we also said, when we take this out and look under a microscope, what do we see? Some Moma bodies. Some Moma bodies. And this is very mucinous.
But this won't cause a hyperthyroid. It's not going to blood.
No, it's actually leaking into the peritoneum. So it causes something else in the peritoneum, something called pseudomyxoma peritonei, because it's leaking out into the peritoneal space from the cyst. All right, so let's talk about what are all the ovarian tumors and how do we identify? Because we're going to present as a mass and we're not going to do a biopsy, right? Only after removal of this mass, we can do path and then identify what the tumor is. So before that, we have no idea. Maybe one or two, there might be some additional features, right? So let's look at the different cell types in the ovary, right? So they have epithelial cell, they have sex cords, and they have germ cells in the ovary, right? So these are different cell types, which means cancer or a tumor can arise from any of these cell types. First, sex cords or stromal tumors. Okay, let's look at what they are. A fibroma. This is actually a stromal tumor, so it can be grouped under that. Now, fibroma, they also have some kind of exudate. You can ovarian fibroma. And what happens is, because of that exudate into the abdomen, they can lead to ascites, right? So a fibroma and ascites. Now, if you have a lot of fluid building up in the abdomen, where else can it go? Through the holes in the diaphragm, it can go up into your thorax. That's why they develop pleural effusion, right? So a fibroma with ascites and pleural effusion, that's Meeks syndrome. Okay, all three together. And the ovarian tumor there is a fibroma. Okay. Then we have sex cord tumors. Granulosa cell and Sertoli Leydig cell. Granulosa cell, what's a normal function of the granulosa cell? What do they make? Estrogen, right? Estrogen. Granulosa cells make estrogen. So if you have a granulosa cell tumor in a young female, what do you see? Precociousness, right? Because they have too much estrogen. Granulosa cell tumor. Here they do have a specific finding on pathology, and those are called Karl-Exner bodies. What do they look like? No, nobody's going to tell you Karl-Exner bodies in a test anymore. I'm going to tell you what it looks like. So what does it look like? You have a pink center, and these granulosa cells are arranged around it. Kind of look like a flower, right? A pink center with granulosa cells arranged around it. So those are Karl-Exner bodies in a granulosa cell tumor. And the Sertoli Leydig cell tumor. What does Sertoli cells make? And what does Leydig cells make? Leydig cells make testosterone, and Sertoli cells make inhibin. Okay. So if you have a tumor that's either a Sertoli cell or a Leydig cell, what's going to be high? Testosterone. So which means in an ovarian tumor with increased testosterone, you're going to see masculinization in that female. Okay. Here too, there is a microscopic finding. Called ring case crystals. These are, again, nobody's going to ask you what ring case, they're going to give you the name. But what are they? These are intracytoplasmic rod-like inclusions. So if you see that described in the context of an ovarian mass, intracytoplasmic rod-like inclusions, then think a Sertoli Leydig cell tumor. Okay. If it looks like a flower, or granular cells arranged around a pink center, think granulosa cell tumor. Okay. So those are your sex cord tumors. The next category is germ cell tumor, right? Germ cell could be an endodermal sinus tumor. So germ cell or endodermal sinus or yolk sac. The other term for this is yolk sac tumors. If it's a yolk sac tumor, what's the tumor marker there? Alpha fetoprotein, high AFP. Okay. Then there's choriocarcinoma. What's the risk factor for choriocarcinoma? Molar pregnancy, hydroidiform mole, right? Molar pregnancy, choriocarcinoma. They have very high levels of para-HCG. So that's how I know it's choriocarcinoma. And then there is teratoma. Teratoma could be mature or immature. And like we said earlier, the immature one is malignant. The mature teratoma, the other name for it is dermoid cyst. So how do you know it's a teratoma? Might see some bone fragments in there, might see some teeth, might see some hair, right? So that's how we know it is a teratoma. And one other thing, I'm going back to yolk sac, they also have a microscopic finding, which is Schiller-Duval bodies. What does it look like? So they're not going to tell you Schiller-Duval in a question. They're going to describe it. This looks like a renal glomerulus. I don't know what it looks like in a picture, but that's a yolk sac, yes. So it looks like cells that resemble a glomerulus of the kidney. That'll be yolk sac tumor. Okay. So that'll be a clue for that. Now, teratoma, right? We also said, remember, there was a tumor, there's a mass that can occur in the ovary, but it came from the stomach, right? What is that? Krukenberg tumor. So that's in a way kind of not a teratoma, but that's a secondary, but it's thyroid tissue. Now, one thing about that is when do you suspect that? It could be a person with an ovarian mass and hyperthyroid symptoms, with their thyroid gland being normal, right? They have a normal thyroid gland, an ovarian mass, but they're hyperthyroid. So obviously it's not coming from the thyroid gland. Where else could it be coming from? The ovaries, because the thyroid tissue in the ovaries, they're actually functional tissue. So they can actually release thyroxine. So that's why they are hyperthyroid, even though their thyroid gland itself is normal, but they have an ovarian mass. Okay, so that's a differential for ovarian masses. Now, actually that particular tumor, which is made up of thyroid tissue, is called struma ovarii. Okay, right here. This is thyroid tissue. Struma ovarii is thyroid tissue in the teratoma in the ovarian mass. So look at microscopic findings, what they describe. See if they tell you any markers like AFP, HCG, and third, look for like it's a cell type. Okay. The third cell type is epithelial cells. Epithelial cell cancers are the most common ovarian tumors, and they have mucinous cystadenocarcinoma, serous cystadenocarcinoma, right? Now you asked earlier, this one is also very mucinous cystadenocarcinoma. But why doesn't it put you at a hypercoagulable? Yes, it can, but in general, remember, all cancers make you hypercoagulable in general, right? Pancreatic cancer, it goes up a little bit. In mucinous adenocarcinoma, this mucin from the ovaries leaks out into the peritoneum and kind of coats the peritoneum. So it gives you a shiny, a smooth coat of mucin in the peritoneum. And that condition is called pseudomyxoma peritonei. Okay, when all this mucin is leaking out into the peritoneum from the ovarian tumor. Okay, so these are all your ovarian masses. Yes, Shri?
So is the struma ovarii similar to like a Krukenberg tumor, except the Krukenberg would have the stomach cells?
Correct, exactly. Yeah, they're all present with ovarian mass. And then depending upon if it's a signet ring cells, then at stomach. If it is thyroid tissue, it's from ovarii.
Thank you.
Bryce?
Yes, so we'd like to have more clarification on how the mucus can produce, like the mucinous tumor can lead to a hypercoagulable state.
Sure. Mucin, when it is in the blood, it makes the platelets more sticky. So then the platelets will tend to stick to each other, and that's basically a clot.
Thank you.
Yes. No, fibroma causes ascites. So it's not mucin, it's just an exudate in fibroma. Whereas here, it's actually mucin that's leaking out. Now moving into the uterus. Most common mass in a uterus is a polyp. Tumor, because it's made up of smooth muscle, what's it? Leiomyoma. Cancer, adeno or endometrial carcinoma. Okay, so let's look at polyps. How do these patients present? So anytime someone presents with a young patient with passing clots, think about a polyp. And if you do an exam, if you see a polyp, so you remove it, polypectomy. Okay, pretty straightforward if it's a polyp. Now, if they present with excessive bleeding, menorrhagia, with irregular uterine enlargement, then we think about fibroids. Okay, so these are leiomyomas or fibroids. Fibroids can be subserosal, right here, submucosal, here, pedunculated, all of these will cause uterine enlargement. Okay, now if it's a fibroid, submucosal or subserosal fibroid, when you palpate the uterus, it'll be bumpy because it's not uniformly enlarged, because these are masses. So you're going to see those little enlargements where the masses are. So if it's irregularly enlarged, then it is submucosal or subserosal fibroids. What if it's uniformly enlarged? It is adenomyosis. So here, when you palpate the uterus, it's enlarged, but it is smooth, right? It's uniformly enlarged. You don't feel those bumps. If you feel those bumps, then it is subserosal or submucosal fibroids. If it is uniformly enlarged, it's adenomyosis. Adenomyosis is endometrial glands within the myometrium. So those are these little red dots that I put here. These are actually endometrial glands, right? It's a type of endometriosis in general because it's present now within the myometrium. Because it's within the myometrium, it causes a uniform diffuse enlargement. So that's adenomyosis. Okay. And then there's a subserosal, and this is a submucosal fibroid. And this is a pedunculated fibroid. Now, fibroid, what do we do? There's fibroids are benign masses, right? So what we talk about early in the morning, benign tumors, they follow some physiology, right? So these actually enlarge. So that's why they have excessive flow also. Okay. Pelvic pain, pressure, they are dependent on estrogen. So they're present with excessive menstrual flow. So what do we do if they have fibroids? Depending upon what they intend to do. Like if it's a younger person, if you have one fibroid, a small one, you kind of leave it alone, right? You can also do myomectomy. This is done in the childbearing age group. If they haven't completed their family, you don't want to do a hysterectomy. So if it's only 1 or 2 fibroids, you try to do a myomectomy to preserve fertility. Second thing that you can do to preserve fertility is uterine artery embolization. So kind of cutting off blood supply to these fibroids. So first is going to be myomectomy. You can do uterine artery embolization. That's another option. And then if it's someone with multiple fibroids or past childbearing, then you can do a hysterectomy. Okay, that's how you approach treatment for fibroids. So initially, because they present with menorrhagia, you start with OCPs for symptomatic treatment or leuprolide, okay, for symptomatic treatment to kind of regulate their axis to control the blood flow. And then eventually you will have to remove that fibroid. Okay. Then we have endometrial adenocarcinoma. Number 1 risk factor, estrogen. Any hyperestrogenic state. Could also be PCOS, polycystic ovarian syndrome. Because in polycystic ovarian syndrome, what's the problem? They have decreased progesterone. So which means now estrogen is left unopposed. So we have more estrogen that's unopposed. It's a risk factor for endometrial adenocarcinoma. So anytime there's bleeding between periods, which is metorrhagia, bleeding in between periods, especially in someone who's over 35, you always have to do endometrial biopsy because you want to rule out cancer, right? So metorrhagia in someone who's about 35 requires biopsy. Okay. Now, what's protective for endometrial cancer? Having a lot of children. No, in general, also smoking. So don't start smoking, but it's protective for endometrial cancer, right? It causes ovarian. I mean, you shouldn't smoke anyway because, you know, you're preventing cancer, but it's shrinking your ovaries. Yes. Because less estrogen, right? So you have 9 months of amenorrhea each time. So that's endometrial adenocarcinoma. So now moving down into the cervix. Mohammed, question?
Yeah, I wanted to know, we were just discussing the fibroids, the leiomyoma. What
Yes.
cancer does that lead to?
It's not precancerous.
Oh, okay.
Yeah, they're just benign masses. It doesn't lead to cancer.
Okay, thank you.
Most common masses in the cervix. Warts. And what's the cause of warts? HPV. Most common tumor, fibromas. Most common cancer, it's squamous cell carcinoma. Even that is from HPV, right? So that's why we do pap smear, right? When do you start pap smear? At 21. Irrespective of history, everybody gets pap at 21. 21 to 29, you do it every 3 years. Okay. 30 to 65, you can do it every 3 years. That's one option. Or if you do an HPV co-testing and it's negative, you can do it every 5 years. There are two options. Okay, you can continue to do it every 3 years, or let's say when you do a pap smear, you also test for HPV, and if it's negative, then you can increase the time in between to 5 years. Okay. Warts are caused by HPV. As far as lesions go, there could also be another lesion in the cervix that it's not wart, but it's still a growth. Okay, and that is actually from syphilis, and that's condyloma lata. Secondary syphilis, you have a fleshy growth in the cervix. If it's HPV, that's condyloma acuminatum. And the strains for HPV are 6, 8, and 11. And what do they look like? How do you know it's a wart? They are verrucas or mushroom-like growths, right? Due to HPV. And if you want to get rid of them, what do we do? You can burn it with acetic acid, trichloroacetic acid. We can use podophyllin, which inhibits growth, or there's another one that can be used, imiquimod. Another drug that can be used. Imiquimod basically is activating your own immune system to attack that growth. So it activates your cytokines. So it activates your TNF, your interferon, your interleukins, to kind of increases your immune system and makes it attack that growth. That's imiquimod. And if none of these work, freeze it, right? Cryosurgery. So trichloroacetic acid, podophyllin, imiquimod, and cryosurgery. So these are treatment for warts. Again, warts are also benign. However, if you have HPV, you got to also make sure your pap is done regularly. Cancer, cervical cancer is squamous cell. Here the strains are 16, 18, and 30, and other STIs also increase that risk. Then once you have cancer, then you either have to remove the entire uterus, hysterectomy, you can do chemotherapy and radiation. So now I just want to mention one thing about chemotherapy here, because we're going to connect it to something else. Chemotherapy is usually with cisplatin. Here, okay. Now, if it's cisplatin, what's the side effect of cisplatin? Ototoxicity, nephrotoxicity, and neurotoxic. Okay, oro, nephro, and neuro. The nephrotoxicity of cisplatin can be prevented by using a rescue drug, right? And that rescue drug is amifostine. So remember, we talked about another rescue a long time ago, right? Which one was that for? Dilated cardiomyopathy for doxorubicin, dexrazoxane. So that was the first rescue drug we talked about. This is the second one we talk about for cisplatin. So cisplatin is ototoxic, nephrotoxic, and neurotoxic. But this amifostine is specifically to prevent the nephrotoxicity of cisplatin. We can use amifostine. Okay? Only nephro, correct. So another rescue drug, leucovorin. This has nothing to do with cervical cancer, okay? But just a rescue drug. Leucovorin, where do we use that? What is that a rescue drug for? Methotrexate. Okay. So those are three. There's one more which is going to come up in the next few slides. So doxorubicin, cardiotoxicity, dexrazoxane, cisplatin, nephrotoxicity, amifostine, and methotrexate, leucovorin. So those are three rescue drugs so far. Okay. Yes, question?
Please, what's the number one rescue drug you mentioned?
Dexrazoxane.
Dexa? Okay.
This was from the morning for doxorubicin. Cardiotoxicity of doxorubicin. Okay. Then you have this, and then leucovorin. Okay. So there's also a vaccine available, right? So preventive medicine is also very important for any step. When do we, when is that vaccine recommended? What age? Yeah, I think it's like 9 to 26, right? Starting at 9 to 26. And then I don't think you need to know details, but between 9 and 14, if it's between 9 and 14, you only give 2 doses. 15 to 26, you give 3 doses. Okay, so that's a protocol. The vaccine starting at 9 to 26, 9 to 14, 2 doses, 15 to 26, 3 doses. Okay. So that's cervical cancer. So most common mass in the vagina is still warts. Okay. Another cyst that can occur there is Bartholin cyst. This is because of occlusion of the duct of something called the Bartholin's gland. Same problem. If you have a cyst there, what can it become eventually? Abscess. So if it's a Bartholin cyst, so anytime a cyst becomes an abscess, what's the most common bacteria? Staph. Anything to do with skin, it's staph. Now here, because of its location, it could also be what other bacteria could also do this. E. coli, right? So that's why if you have an abscess here, let's say, I think it's coming up later. We'll talk about when it comes up. So most common cancer here is squamous cell carcinoma because it's an extension from the cervix itself. The lower half of the vagina is skeletal muscle. So with skeletal muscle, naming, what's that tumor called? Rhabdo, right? So skeletal muscle, the lower half is rhabdomyoma, right? This rhabdomyoma generally is seen in, or rhabdomyosarcoma or sarcoma pituitariis are the name usually seen in children, very young children, and it looks like a cluster of vesicles, like, or a cluster of grapes that actually is protruding from the vagina, okay, in a child. That's rhabdomyosarcoma, generally seen in children. So what's same thing, exact same as in the cervix. So Bartholin cyst, it could be congenital. It's a fluctuant mass behind the labia. It can become infectious and can lead to abscess formation. E. coli or staph. So that's why if you want to use antibiotics, what antibiotic would you use to cover these organisms? Penicillin, so amoxiclavinate or TMP, Bactrim, trimethoprim, sulfamethoxazole. Okay. So those will be the antibiotic choices if you need to treat after it has become an abscess. So what do? Antibiotics if it's the first infection. Second infection, you have to remove it, or you actually have to open it up. Marsupialization is the procedure that we do to treat a cyst. All it does is it just opens up the cyst and then it sutures the endings the other way. So it kind of leaves it open. That's marsupialization. If this occurs in the older age group, after age 50, you have to check for cancer. Any lesion on the vulva above 50 years of age, always do biopsy. Next step will always be biopsy because you want to rule out cancer. Okay. We talked about this, rhabdomyoma, rhabdomyosarcoma. Rhabdomyomas, it occurs in tuberous sclerosis if it's in the heart, and sarcoma pituitaris is the one that is seen in kids. All right, now to the kidney. Most common mass, cyst. Tumor is an adenoma. Most common cancer in children is a Wilms tumor. Now, Wilms tumor, and in adults, it's just renal cell adenocarcinoma. Okay, so Wilms tumor in children, renal cell adenocarcinoma. And remember, we said abdominal. What was the most common abdominal mass in children? From the morning. Most common abdominal mass in children. Louder, louder. Neuroblastoma. Neuroblastoma. Remember the one that crosses the midline? That's the most common abdominal mass. Wilms tumor is the other abdominal mass, but it stays on the flanks. Okay. So what is the association? There's something called the Wager syndrome, WAGR. Should be this way. So what do we see? Wilms tumor, aniridia, absent iris, intellectual issues, and gonadoblastoma or other reproductive tract tumors. Gonadoblastoma. Okay, so that kind of happens together. So aniridia with one of the other issues here with an abdominal mass, think Wilms tumor. Okay, in children. It doesn't develop. It's the syndrome, so it's something where developmentally it's not there. But in an adult, renal cell carcinoma occurs on the superior pole of the kidney, so on top. What do they present with? Painless hematuria and a flank mass. But this blood also has casts, because if there is blood in the urine without casts, where is it coming from? No casts are formed, because where are the casts actually formed? In the tubules, right? So that's why if you have casts, you think kidney. But if you don't have casts and there's blood in the urine, exactly, further down, ureter or bladder. So hematuria without casts, think bladder cancer. With casts, think renal cell cancer. Obviously, if you see casts, it could also be nephritic syndromes. But if it's not vasculitis, and if you're thinking cancer with a mass, because nephritic syndrome, there won't be a mass. But if there's a mass with hematuria and casts, think renal cell carcinoma. Yes, it could be squamous also, but it's a bladder, depending upon the etiology. It could be transitional cell, which is the most common, or squamous cell if there is parasite. Now, these cancers metastasizes via the retroperitoneum because kidneys are located retroperitoneally. So it also metastasizes through the retroperitoneum. Yes, Marbel?
Did you say that the hematuria without cast is seen in the bladder
Yes,
cancer?
correct. Without cast bladder, with casts, kidneys.
Okay, thank
Where
you.
does it go? Renal cell cancers goes to the lung, and we see little coin lesions or cannonball metastasis in the lung. That's renal cell cancer. Now, if you remove the kidney, you also have to do pediatric ultrasounds or CT scans, because there's a small percentage, a 20% chance that it can recur in the other kidney eventually. So you got to do that screening. So you can't just take out that kidney and then they say you're all good, but you have to do periodic imaging to make sure that it's not coming back in the opposite kidney. Joshua?
Yes, I'm not sure if you'll cover this, but I've seen a lot of questions where they ask you to differentiate unilateral or bilateral tumors in the kidneys. And I was just wondering if there's like a quick kind of like chart on which ones appear on both kidneys versus ones that appear on like one kidney.
What kind of tumor? So renal cell carcinoma, you have two types. Where is that? A clear cell or fat cell. So between the two, It may not occur at the same time, but there's always a risk of it coming back in the opposite side. So specifically, is there a risk for one over the other? I am not familiar with that.
Are like, are Wilms tumors, do you know, I forgot, are they bilateral always? Like, or can you have a
No.
Wilms tumor on one side?
It's unilateral. So that's why if you look here in Wilms tumor, we talk about hemihypertrophy, right? So that's only
Okay.
on one side, blood flow to one side being affected.
Okay.
It's usually unilateral.
Thank you.
Yeah, usually unilateral, but does it mean that it can't be bilateral? It can, but most of the time it's going to be unilateral. Risk factor for renal cell. Smoking is still number one. Now we talked about a couple of syndromes earlier on where we're going to see renal cell, right? Von Hippel-Lindau, VHL, the AVM syndromes where they have a lot of AVMs in your GI and in your cerebellum, right? That's VHL. And then tuberous sclerosis. We talked about kidneys being affected, having renal cell cancer. So those are other risk factors. So anytime you're suspecting a renal pathology, what's always the first thing to do? Very first thing. Simplest thing to do. Simplest thing to do. Urinalysis, right? You never skip that. Right? No, never go to ultrasound without doing an UA for any kidney issue, right? Urinalysis, then we do an ultrasound. If we do, we can, if you want to go further, we can do other things, but usually an urinalysis and ultrasound is fine. You should be able to locate it. Okay. Now, this is a third place where we will not biopsy, right? Ovarian masses, no biopsy. Testicular masses, no biopsy. Renal masses, no biopsy, right? Because we have to prevent it from spreading. So when you do biopsy, there are a higher chance of it seeding. And that's why for these three organs specifically, we do not do a biopsy, but we do surgery and remove it. And then we do pathology to find out what kind of cells it has. Okay. So like I said earlier, annual CT scans to make sure that it's not recurring on the other side. Okay. For renal cell cancer. Now, adrenal gland, cyst, adenoma, and adenocarcinoma, just like anything else. So I'm not going to spend much time on that. But what are the different segments in the adrenal gland? All the way inside, it's the medulla. And we talked about adrenal medullary tumor, right? What's that called? Pheochromocytoma. And then that's the adrenal medulla. But adrenal cortex is divided into three segments. What's the outermost? Zona glomerulosa. What's next? Fasciculata. And innermost is reticularis, so GFR. Salt, sugar, sex. Glomerulosa, aldosterone. Aldosterone. So that's Cont's syndrome. And if you have too much aldosterone in Cont's syndrome, what's the function of aldosterone? It increases. Well, water is kind of a secondary thing. What's the primary thing that it reabsorb more? Sodium, right? In exchange for potassium and hydrogen, right? So they, well, what will their pH be in the blood? Alkalosis. So they'll have metabolic alkalosis, hypernatremia, hypokalemia, right? Hypertension along with that. So that's if it's a tumor of the glomerulosa. Similarly, we talked about this too. If it's a tumor of the fasciculata, that is Cushing syndrome. So when we talked about the dexamethasone test, we addressed this. Increased cortisol and adrenal adenoma from the fasciculata. And if it's reticularis, a tumor, what will they make? A lot of testosterone. So it depends on if it's a female, you have masculinization. If it's a male, it might be precociousness. But if it's an older male, you may not really see anything. And if it's medulla, pheochromocytoma, right? So those are the different tumors of the adrenal gland, depending upon what segment of the gland is affected. So if you have a Cont syndrome, right, and increased aldosterone, what's something else that you can check the levels of to kind of confirm it? Or what controls aldosterone? What's a signal for aldosterone? Renin, right? So this Cont syndrome, is it primary or secondary hyperaldosteronism? Is it primary or secondary? It's primary because it's from the gland itself, right? So anytime it's the gland itself, it's always primary. But so which means, how does it feed back to renin? Is it positive or negative? It's going to be negative feedback, right? Because the gland is making aldosterone. Do I need further signaling? We don't. So here, renin will be decreased. So decrease renin and increase aldosterone. It's primary hyperaldosteronism. But what if you have a tumor in the JG cell? That can also lead to hyperaldosteronism, right? Because JG cell is what makes renin. And if you have a tumor there that makes a lot of renin, it's going to also make a lot of aldosterone and also give you hyperaldosteronism. But would that be primary or secondary? So that'll be secondary, where you have both renin and aldosterone goes up. So if you have somebody with a lot of aldosterone, one initial step or test that you can do is to measure renin to see if it's a primary cause or a secondary cause. Okay. Now in the bladder, most common mass is a diverticulum, an outpouching. Most common tumor, bladder made up of smooth muscle, so leiomyoma. Cancer is transitional cell adenocarcinoma, right? So this is the one where you're going to see hematuria without cast. So if it's a diverticulum, it's an outpouching, right? What's the problem if there's a pouch in the bladder? What's going to collect in there? Urine, stasis. If it stays around for a long time, what's going to happen? It can get infected, or urine stays put for a long time. It can also develop stones. It can precipitate stones. So if you're diverticulum, you can get infected, UTIs, or you can develop stones. So what do? Remove it. If it's cancer, transitional cell, this particular cancer can have multiple primaries, which means you can have different sites within the bladder where the mass is originating. Presents with painless hematuria with no casts. Treatment is surgery or radiation. But when you look at risk factors, number one is still smoking. Then we have aniline dyes, other toxins, benzene, aflatoxin, and also a chemotherapy drug, cyclophosphamide. Because what is the side effect of cyclophosphamide? Hemorrhagic cystitis. So hemorrhagic cystitis is a risk factor for bladder cancer. And that's why here comes our fourth rescue drug. If you want to prevent hemorrhagic cystitis by cyclophosphamide, what is that drug we use? Mesna. There we go. So now we have our four rescue drugs. Okay, Mesna to prevent hemorrhagic cystitis from cyclophosphamide. Now, if the cancer is squamous cells, squamous is usually due to irritation, and that's a parasite there, Schistosoma hematobia, right? What was the other schistosoma that we talked about? Manzoni, which caused hepatocellular cancer, liver. Okay. And I'm going a little faster because we have only half an hour left. Prostate, enlargement, BPH, benign prostatic hyperplasia hypertrophy. Also remember, prostate undergoes both, right? Hyperplasia and hypertrophy. If it's cancer, adenocarcinoma. If you have BPH, what would the patient present with? Trouble urine, incontinence, right? What kind of incontinence? Urinary incontinence? Yes. It's not stool, it's urinary incontinence. Okay. Yeah, they have trouble initiating, they have a weaker stream, dribbling, frequency, nocturia, overflow incontinence, because it's actually obstructing. So if you look at the bladder and the urethra, prostate is here, right? So it kind of compresses the sphincter. The bladder sphincter, urethral sphincter, when it enlarges. So that's why they have trouble initiating, because the sphincter is tightly held shut by the enlarged prostate. So that's why they have an overflow incontinence, because then, they don't go, they have increased urine left over even after they go, increased post void residual urine and all that those kind of problems. Okay, so what do? What are we trying? Symptomatic relief. We want to help them relax that sphincter so they can maturate properly. What receptor is on the sphincter? Urethral sphincter, alpha 1. Okay, so we do alpha 1 blockers. Terazosin, doxycycline, and tamsulosin. These are all alpha 1 blockers. But what should you be careful about when you give somebody an alpha 1 blocker? Hypotension, right? Because alpha 1 also causes vasodilation. So always make sure that they're not on other antihypertensive drugs. You may have to do some adjustment. Don't just blindly add it to a hypertensive regimen, because now it's going to go unsafe drop in blood pressure. Second thing, you always have to tell them to kind of like be slow to go from sitting to standing because of that orthostasis. Okay, so alpha 1 blockers. That's to relieve symptoms. Now, you can also cause the prostate to shrink. So what is responsible for prostatic growth? What hormone? It's DHT. The active form of testosterone is what actually stimulates the prostate to grow. And DHT is made from testosterone. And what's the enzyme there? 5-alpha reductase. So we can also use 5-alpha reductase inhibitors, finasteride and dutasteride. So they inhibit 5-alpha reductase, inhibit DHT, so they kind of stop that prostatic stimulation or maybe even shrink the prostate. And even after medical management, they are symptomatic, and then we have to remove the prostate. How do we remove the prostate? TURP, transurethral resection of the prostate. Right? It sounds painful, but yeah, you gotta do that through the urethra. Cancer, most common cancer in men, second to lung cancer for cancer deaths. We already mentioned that. Now here, surgery, hormonal therapy, or radiation, right? If you want to use hormonal therapy, medication for prostate cancer, what kind of medication do we want to use? Leuprolide, right? Leuprolide is a gonadotropin releasing agonist, GnRH agonist. However, when you give somebody leuprolide, it's an agonist, right? What will happen to sex hormones? It's an agonist. It increases. Testosterone will increase initially, right? Until the axis resets, and then eventually it'll be inhibited. But in that initial period, when you start treating with leuprolide to prevent the prostatic cancer from worsening because of increased androgens, what else can you do? You also use another drug to inhibit that effect of testosterone on prostate. How do we do that? We block androgen receptors. So if you block a receptor, even when testosterone goes up, does it do anything? No. What's an androgen receptor blocker? Flutamide. So this is a question where I can ask you, what do we pre-treat them with? Why do we pre-treat them with this? And what's a drug that we pre-treat them with? Okay. So the purpose of giving flutamide is to prevent that initial surge in testosterone to make the prostatic cancer worse, because it's activating prostate, right, with androgens. So that's why we give flutamide and with leuprolide, and then follow that with chemo or radiation. Okay. Yes. Yes. It blocks the androgen receptors. Yes, question?
Yeah, please, what do you say about radiation?
Radiation, after you treat them with medication, then you can treat them with radiation or surgery. Okay. Radiation generally for prostate cancer, it's actually called brachytherapy. They actually implant little seeds in the prostate. Just like any other cancer, you can use radiation too, if it's not enough. All right, now, is there a recommended prostate screening protocol? No, right? There is no preventive USPSTF protocol for prostate screening, but your doctor will recommend that after age of 40, get the prostate examined, once in a while to make sure that it's not enlarging, right? Now, prostate enlargement, there are three types of prostate enlargement, just quickly. If it's uniformly enlarged, what is that? What we just talked about, it is PPH. If it's nodular, what is it? Cancer. If it's boggy, what is it? Boggy in the sense of like squishy or
Prostatitis.
Prostatitis, right? So 3 different types of enlargement when you do a rectal exam, when you feel the prostate. If it's uniformly enlarged, PPH. If it's boggy, soft and boggy, but it's still enlarged, it's prostatitis, that's an infection. If it is enlarged and nodular or irregular, it's cancer. Okay.
Would the body one also be painful for the patient?
It'll be painful, yes. It's infection. Question?
Excuse me.
Yes.
Please, what did you say about, you said that the radiation is what, Brady what? Radiation?
Yeah, brachytherapy is a term for treatment of prostate cancer with radiation. That's all. I mean, you don't need to know that, but that's fine. It's just more specific.
Okay, thank you.
Colon cancer screening, however, there is a protocol, right? When do we start screening for colon cancer? 50 has been changed, right? 45. First colonoscopy at the age 45 and then done every 10 years. Starting at age 45. There is also another option. You can do an FOBT. You check your stool for occult blood and sigmoidoscopy every 5 years or more frequently, right? I don't know why anybody will choose that. You want to go every 5 years. It's like go every 5 years and have a small tube go up every 5 years, or go every 10 years and have a long tube go up. So what's the choice there? I want to see somebody who picks sigmoidoscopy every 5 years. Okay, so that's for colonoscopy. Unless, now if you have ulcerative colitis, then you have to start screening earlier, right? So when do we start screening if someone has ulcerative colitis? First screen would be 8 years after diagnosis, and then yearly. Okay, so 8 years you wait. So someone who was diagnosed at 28, but you see, what's the first, when would the first screening colonoscopy be? At 36, right? 8 years after. And after that, it has to be done every year. So that's an exception to the normal screening protocol. And you also said if you're talking about familial adenomatous polyposis, it starts at 12 years of age. Sigmoidoscopy starts at 12 years. Yes.
So colonoscopy every 10 years, starting at 45, that's just for network.
Everybody. Yes. Testes. Most common mass in newborns, hydrocele. Hydrocele is fluid collection around the testes. It's due to a patent processus vaginalis, right? The fluid's not draining, so it's collecting around the testes. How do we know it's fluid as compared to blood or something else? You shine a light, transillumination. Okay. There are 2 that transilluminate. One is hydrocele. The other one is a spermatocele. But the difference here, how do you know it's a hydrocele versus spermatocele? Location. Hydrocele is around the testes, right? Spermatocele is a fluctuant, transluminating mass on the upper pole of the testis. Okay, so both of these transilluminate. So think about hydrocele, think about spermatocele, and look at what the physical exam tells you. Is it all around or is it only on the superior pole? In children, the most common mass is hematoma. So that's from trauma, blood. In adolescents and older, varicocele. Varicocele is felt like a bag of worms, or sometimes they talk about rope-like consistency, right? Because it's a occlusion of your venous, pampiniform plexus. Now, if an adult has a varicocele that is irreducible, and if it comes and goes, what else do we have to look for? Because testicular drainage, right? The left testicular vein, where does it drain into? Left renal vein. Right testicular vein drains into IVC directly. So which means if a varicocele on the left side persists, there is something that's preventing it from draining into the left renal vein. Rule out a left renal mass. So renal cell cancer on the left side can present with left-sided varicocele, right? Because it prevents that drainage into the renal vein. Okay. Yes, Marbel?
Please.
Yes. I didn't hear you. Okay, we'll come back to that. So most common tumor is an adenoma. In the first year of life, what's the most common cancer? Yolk sac. In teens to adults, seminoma. So this testicular cancer also very similar to ovarian cancers. Okay, so briefly, most common testicular mass is a seminoma, right? And what's a marker for seminoma? It's placental alkaline phosphatase. Okay. No AFP, plus or minus HCG. So they might have HCG, but not always. But placental alkaline phosphatase will be a marker for seminoma. Okay. Just like in the female, males more commonly can also have your what you call the sex cord stromal tumors. Probably the same markers. If you have a Leydig cell tumor, what will be elevated? Testosterone. If it's a Sertoli cell tumor, what will be elevated? Inhibin. So that's the same as you see in females. Actually, all the microscopic findings for these tumors are identical for both. Okay, depending on, so in Leydig Sertoli cell tumor, what's the microscopic finding that we talked about? What do you see on path? You see some crystals there. Ring case crystals, right? So that's seen in the ovaries if it's a Leydig Sertoli cell tumor. It's the same thing that's seen in the male too if it's a Leydig Sertoli cell tumor, right? So even in the males, they can have what you call an embryonal cell tumor or a yolk sac tumor. If it's a yolk sac tumor, what's a marker? AFP, right? Males can also have a choriocarcinoma. What's a marker? If it's choreo. HCG, right? Very high HCG, similar to one in females. And then in males, there's also one other type, which is mixed germ cell tumor. And this is also kind of easy to identify based on markers, because if it's mixed, this is the only one that has both AFP and HCG. So if it's a testicular mass, you remove the mass, you send it for path, or you look at markers, and both alpha fetoprotein and HCG is elevated, there is only one answer, which is a mixed germ cell tumor. All right. So seminoma, yolk sac, choreo, sex cord stromal tumors, and a mixed germ cell tumors, just like in the ovaries. Is what? No, dysgerminoma is the seminoma, is the equivalent to seminoma in a female. So this seminoma is an ovarian tumor, which is the counterpart for seminoma in a male. Okay. So those are testicular tumors. So testicular exams begin in adolescence because you're randomly making sure that there are no masses. Any firm testicular mass, what do? Say goodbye, right? Orchiectomy. Any firm testicular mass, orchiectomy, no biopsy. So after you do orchiectomy, hopefully it's just one, but in case you have to do both testes, what do you do after that? Phone a friend, right? Because it can be transplanted, right? So phone your best friend and ask him, hey, can you lend me one of your testes, right? I mean, it's okay, only one. But, however, what else would you have to deal with? If you ever impregnate your spouse, he will look like your friend. That's the only problem, right? I mean, that's actually happened too. Actually, they have done some experiments and it's actually happened. So if you're okay with that, that's the test of your friendship, right? You call them and say, you know what? I need a testes. Anyway, all right. Skin, most common mass, skin tag. A fancy name for it is acrocordon. Yes, question?
Yes, sir, please, when you said about hydrocele or varicose, you said that adults is reducible, you see it in left renal vein.
No, if it's not reducible and if it occurs consistently, then it might be a renal cancer on the left side, which is blocking the flow of blood into the renal vein. Okay.
Okay, what about if it's reducible, sir?
What was that?
What about if it is reducible?
Reducible, I mean, it's just that there is varicocele, but it's not that severe because venous blood should drain against gravity. When you lie down, it should disappear. When you stand, it appears. So it's just a varicocele. It has nothing to do with the kidneys. That's all.
Okay, thank you.
Right? So skin tags. If you don't like it, what do? Take it off, shave it off. It could also be a hemangioma on the skin, a blood vessel, enlarged blood vessel. If you have a tumor, it's a fibroma. Most common cancer, basal cell carcinoma. Most common malignancy, squamous cell, right? So you have squamous cell cancer, you have basal cell cancer, and then you have melanoma, which we'll also talk about. So let's look at skin tags. You don't like it, like you said, take it off. Hemangioma, there are two types. If it's a child, what do children like? Strawberries. So it's strawberry type in children. What do adults like? I don't know, we might like strawberry, but cherries. So cherry type in the adult. So cherry hemangioma in an adult, strawberry hemangioma in pediatric. And that's based on how it looks, the appearance. Okay. Just a shape, yes. Exact, can be found anywhere. It's just an enlarged blood vessel. What do? Usually nothing. It enlarges initially. So if it's present at birth, it can enlarge in the first year, but then eventually it will regress. If it doesn't, and if it's in a place where it's disfiguring, you can either inject steroids or do laser to get rid of it. Okay, that's a hemangioma. Fibroma, we talked about this with neurofibromas, right? All those different cutaneous tumors. One or two you can remove. If it's neurofibromatosis, you're going to see lots of them. So I think next few slides are just a recap of all that we talked about. And then now cancer, it's a basal cell and squamous cell. So how do you know which one's which? Basal cell usually is benign, right? It does not behave malignantly. And it presents as a pearly papule or sometimes ulcerates. Okay. Risk factor, sun exposure. So Thymus, that causes xeroderma, which is a risk factor for squamous cell. Okay. Usually found on the face from sun exposure. What do? resection. And generally, there's a surgery that we do. It's called Mohs surgery. So Mohs surgery, let's say that you have a lesion. Mohs surgery basically is going layer by layer, like very thin layers, microsurgery, so that minimal tissue is removed. Rather than taking a big chunk, it's on your face, taking a big chunk out, they go layer by layer, and they try to, leave as much tissue as possible. So that's Mohs surgery. Okay, treatment of choice for basal cell. Early papule that sometimes ulcerates. Whereas if it's squamous, it's always going to be malignant. Almost always ulcerates. Sun exposure is still number one. Now you have other risk factors too. So actinic keratosis, it's pre-malignant. Pound's disease, so that's like a rash in the groin or in other skin creases. Other diseases with increased incidence of squamous cell albinism. So any disease with a cutaneous manifestation can lead to that. So albinism, vitiligo, porphyria cutanea tarda. So that's a defect in heme synthesis pathway with uroporphinogen decarboxylase deficiency, porphyria cutanea tarda. And those are the vampires. They don't go out in the morning. They can only come out at night, because if you come out in the morning, it burns the skin. PKU, phenylalanine hydroxylase deficiency. They also have cutaneous symptoms. Wiskott-Aldrich, that's a problem with B cell and T cell immunodeficiency, where there is impairment of phagocytosis, so B cell and T cells. They have eczema, right? Another risk factor. Job syndrome, which is hyper IgE. So these are all of these conditions have some kind of skin issues, and therefore can lead to squamous cell as an end result. Same treatment. You can do Mohs surgery or chemo and radiation. So here, when you do a biopsy, what do we see? Keratin poles. So keratin poles in squamous cell, early papule, or ulcer in basal cell. Okay. Squamous, always malignant. Basal, they do not metastasize. Squamous will metastasize. The melanoma. Remember we said melanoma, what cells do they come off? Melanocytes, they come from neural crest cells, right? This is the most malignant skin cancer. And the risk is based on, when you look at the different characters, so if it's asymmetrical, if it's irregular borders, if it has multiple colors, if it's very deep, if there is any itching, if there's any bleeding, these all point towards an increased malignant risk. The most important is depth of invasion. So that's the worst prognostic factor. The deeper it is, the worse it is. Now, melanoma, interestingly, when it metastasizes, it's got a favorite place to go. And this is the only cancer that goes here. It goes to the gallbladder. Okay, so melanoma met. So in case, we talk about gallbladder cancers, right? In case we see mets in the gallbladder, where's the primary? There's only one answer, melanoma. Okay, so whatever reason, it goes there. Don't know why, but that's where it goes.
But the most common is the brain.
No, in general, brain will be mets. But if you have mets in the gallbladder, there's only one place it could have come from. That's malignant melanoma. So because they're coming from neural crest cells, what are they all positive for? S100. So that'll be a marker. But that's again common to all neural crest derived structures or cells. And treatment would just be wide excision, right? You have to remove the whole thing. All right, that's skin. Now, I think we're almost there. Bone tumors. Benign tumors of the bone, what are they called? from 8:15 in the morning. Yes, it's called osteomas, right? Benign tumors of the bone, osteomas. Anyway, so bone has epiphysis, metaphysis, and diaphysis. These masses can originate from any part of the bone. Epiphysis is the growth plate, and it's made of cartilage. So if it's a tumor of the cartilage or epiphysis, it's called a chondroma if it's benign, and if it's cancer, it is chondrosarcoma. So in chondrosarcoma, what are the bone on X-ray? It's got a moth-eaten appearance. So it just looks like bugs have taken a bite out of it. Moth-eaten appearance of the bone in chondrosarcoma on X-ray. Yes, I mean, you'll have little, like a lot of different spots in there. Okay, and it's also what you call osteolytic. And the other thing you're also going to see is popcorn calcification. So these are clues. So if you see any of these, epiphyseal growth, bone mass, moth-eaten appearance, osteolytic lesions or punched out lesions, and popcorn calcifications, chondrosarcoma. Okay. Metaphysis, made up of osteocytes. Osteocytes basically are calcified osteoblasts. So mature osteoblasts, they become osteocytes. Benign osteoma, most common cancer overall, like any other organ, it's going to be metastasis. Primary cancer is osteosarcoma, right? Overall, mets, primary osteosarcoma, benign osteoma. So if it's osteosarcoma, so if you have a bone, let's say it's a femur, osteosarcoma, two things. You see an elevation like this, a triangle on imaging. That's a Codman's triangle, and that's due to subperiosteal new bone formation. Okay. It causes a triangle-like elevation on the metaphysis, and that's the Codman's triangle. Along with that, the bone is destroyed. So you're going to see like starburst appearance of the cortex, again on X-ray. Okay. It's like a starburst. So those two, starburst appearance in the cortex and Codman's triangle on an X-ray. Bone mass, it's an osteosarcoma. Okay. The diaphysis, same, osteoma, mets, but in children, the primary cancer is Ewing's osteosarcoma. Yes, question?
So what's the last thing you said after periosteal new bone formation? What's the last thing you said, please?
So that's a Codman's triangle, and you have a starburst appearance on the cortex. So it's like, that's because of bone destruction. So in children, Ewing's osteosarcoma, and in the adults, multiple myeloma, right? Ewing's has a translocation, right? 11-22. Here, this is the most common primary bone cancer in children. What do we see? Onion skinning. Onion skinning basically is due to calcification. So those are layers of calcification. So it looks like, onion skin, so multiple layers of calcification. And when you see that, it's Ewing's osteosarcoma, right? 11-22. Most common primary in children. In adults, multiple myeloma. So this is a plasma cell disorder. What do plasma cells make? When you activate plasma cells, what is it making? Immunoglobulins. Immunoglobulins are your IgGs, IgMs, all that made by plasma cells, right? What's the predominant immunoglobulin in us? It's IgG. So that's why if you have multiple myeloma, you have lots of plasma cells. A plasma cell, they make a lot of antibodies. And what's the largest amount made? It's IgG. But when you do serum electrophoresis, which is what you do for diagnosis, you're going to see what we call the M spike, right? But this M spike is due to IgG. All immunoglobulins are elevated, but IgG to the greatest extent. Okay. And these are heavy chains. Because these are heavy chains, they don't cross the filtration barrier. They don't end up in the urine, right? They stay in the blood. However, there are also light chains that are overproduced. And those are your kappa chains. Kappa chains, right? But these light chains will show up in the urine. So heavy chains in the blood, light chains in the urine. So what else do you see in multiple myeloma? What's a mnemonic? Crab, right? You have hypercalcemia because there is bone destruction. So calcium goes into the blood. There's renal failure. And there's anemia. And bone osteolytic lesions. And in the urine, you can also see Bence-Jones proteins. Correct. The kappa light chains, paraproteins in the urine, okay? And if you do peripheral smear, all these RBCs, they kind of stack on top of each other. What's that called? The rouleau formation, right? So those are the things with multiple myeloma clues. Rouleau formation on peripheral smear, increased IgG or M spike on serum electrophoresis, hypercalcemia, renal failure, osteolytic lesions, and then light chains in the urine. Yes, Marbell?
Okay, so okay, the A stands for what? Is it anemia?
Anemia, correct.
Okay, thank you.
So what are the, if it's immunoglobulin issue, what are they at a higher risk for? Why do we need immunoglobulins? Infection. So they have a higher risk for infection. Okay. All right, now I think this is the last part. So breast masses. Most common mass is a cyst. Most common tumor, less than 25, fibroadenoma. Greater than 25, fibrocystic disease. And most common cancer, the intraductal adenocarcinoma. Okay, we talked about fibroadenoma. They are estrogen dependent, so they enlarge during the first 2 weeks. And we talked about it earlier in the morning. If it's during the second half, progesterone dependent, it'll be fibrocystic disease. Okay, the fibrocystic disease, because these are cysts, when you aspirate the cyst, the fluid has a greenish appearance. Okay, greenish fluid. But so these are benign conditions. The most common cancer is an intraductal adenocarcinoma. So they present with a bloody discharge. Okay, so there are only two conditions if there's a bloody discharge from the nipple, right? One is intraductal papilloma, or it could be intraductal adenocarcinoma. That's it. If it's bloody, it has to be one of these two. Okay. Now, if it's intraductal adenocarcinoma, usually seen in the upper outer quadrant, and it presents with a dimple. So there'll be dimpling. Now, what's a dimple due to? Something is pulling that area, and that's due to involvement of your suspensory ligaments or the Cooper's ligament. That's what causing the dimple. So if you see that bloody discharge, intraductal adenocarcinoma. Now, breast cancer metastasis can be osteolytic or osteoblastic. Although it's osteoblastic most of the time, it can also be osteolytic. Okay. Now there's intraductal adenocarcinoma. It's within the duct, right? So it can grow. It can grow into the surface and reach the nipple and involve the nipple also. That's Paget's disease of the breast. So Paget's disease of the breast is what you see on the outside with an intraductal adenocarcinoma within the duct. Okay. Yes, question?
Yeah, please, what is about Paget disease? Say you see on the outside?
It's an extension of the intraductal adenocarcinoma into the nipple. Other breast cancers, if there's bleeding, intraductal papilloma is the other option, either papilloma or adenocarcinoma. Then there's lobular adenocarcinoma. When we do a biopsy, how do we know it's lobular? All the cells appear lined up in a single file. Okay, so that's a clue for lobular. Comedocarcinoma, comedones, so there's moles, right? So they have multiple areas of necrosis. Comedocarcinoma. Inflammatory adenocarcinoma is the worst. That's the most malignant. And this is where you see the skin of the breast like an orange peel, right? Woody orange appearance. So it's like an orange peel with lots of like puckering on the skin. And this is due to involvement of lymphatics. The dimple is due to ligament involvement. The orange peel appearance is due to lymphatic involvement. Okay? And this is the worst form of cancer. And then we have a sarcoma, cystosarcoma, which is fast growing, but then once it comes from the inside and outside, it kind of stops, right? It looks like a leaf in a way. And then what do? Resection. So any breast masses, right? Once you do, you're doing your mammograms to kind of screen for them. When do you start mammogram? At 50, and you do it every 2 years. Okay. We don't really worry about breast exams anymore. That's not recommended. You can do it, but not recommended. But mammogram every 2 years. Okay. So if you have a cystic mass, take the fluid out, send it for pathology. And if the cyst disappears, you're done. If it's a firm mass, you got to do a mammogram, right? And then you do a lumpectomy. So removing that lump, then you send it to path for identification. The type biopsy will tell you what kind of cancer it is. Okay? If it comes out as malignant, or if it's benign, don't do anything. Like fibroadenoma, right? You remove the lump, it's benign, you don't do anything. If it's malignant, then perform a modified radical mastectomy. Modified basically means you're leaving the pectoralis muscle intact. And then you also have to do axillary node dissection. Okay. Now, something else you're going to check is if they are positive for estrogen or progesterone receptor, ER or PR positive. If they are estrogen receptor positive, what do we treat them with? Tamoxifen or raloxifene. Which one's better? Safer? Raloxifene, right? Because tamoxifen is antagonist at the breast, agonist at the bone, both of which are good, but it's also agonist at the endometrium. That's bad, right? So we use raloxifene. Raloxifene is antagonist at the breast, agonist at the bone, and doesn't have an effect on the endometrium. So you don't increase the risk of endometrial cancer. So raloxifene is actually preferred if they are estrogen receptor positive. Yes, question?
Please, what do you say about tamoxifen, please?
Tamoxifen is antagonist at the breast, agonist at the bone, and it's also agonist on the endometrium. Okay, that's why we don't want to use it. Increases risk of endometrial cancer. Now, there's also another receptor that we have to check for, which is HER2/neu. If this is positive, then what do we use for treatment? Trastuzumab. Okay, if it's HER2/neu positive, use trastuzumab. What's the side effect of trastuzumab? It's the same as doxorubicin, dilated cardiomyopathy. But this is reversible cardiomyopathy. So if somebody has dilated cardiomyopathy from using trastuzumab and they're concerned about the dilated heart, what do you tell them? It's fine. You stop the drug, it'll go back to normal. However, let's say you don't even want to deal with it and you want to prevent the dilated cardiomyopathy. What can you do? Just like in the other, we can actually use the same drug here too. Dextrosol can also be used to prevent dilated cardiomyopathy in trastuzumab. Okay. I think we are done. Questions? Tomorrow. All right, so just some general cancer stuff. Obviously, they're all going to be in low energy state. More common in males, generally under age 30 and after age 50. So young and old, but in between 30 to 50, more common in females. And most common cause of death is generally not heart failure, right? Infections. Now, antigens. So we have antigens do have a role, but does it have a role in diagnosis? No. We never do antigens for diagnosis. But what do we do antigens for? We want to know a baseline so that after treatment, we can follow those numbers to see if it's coming back up, in which case that means it's recurring, right? So let's look at quickly about all the antigens that at least some of the antigens, not a complete list, but there are some antigens that we need to know. PSA, prostate, CEA, colon cancer, S100, melanoma, AFP, yolk sac, HCG, choreo, CMYC, Burkitt's, LMYC, small cell lung cancer, NMYC, actually NMYC and thrombocin, both of these are neuroblastoma. Desmin, rhabdo, vimentin, connective tissue, so sarcoma. CA125, ovarian. 19-9, pancreatic. BCL2, follicular. BRCA is best. Follicular, RET. MEN2, RB, retinoblastoma, and osteosarcoma. So these are all tumor antigens. So what we do before you start treatment, you have to get a level, right? And then after treatment, you check the level. So you establish a baseline and you know what happened to the number after treatment. Then as you follow up, you keep checking those numbers to see if it's come back up or if it's staying low, excellent. If it's coming back up, it's trending back up, it means there's a chance that the cancer is recurring, okay? How about translocations? 922. CML, I didn't mention this earlier. This is the Philadelphia chromosome, 922. 814. Burkitt's. 1418. Follicular. Lymphoma. 1122. Ewing's. 1517. 1122 is Ewing's, the bone tumor, Ewing's. 1517. PML, that's part of AML, right? These three, breast, all three, and P53, all else. Now, obviously, there's not a complete list. There are, 1722. What's 1722? What is 1722? We did this.
Isn't it neurofibromatosis?
Yes, neurofibromatosis.
These are genetic markers.
Translocation.
Translocation.
Yeah.
Like for the RV, HER2, record.
So those are actually tumor suppressor genes, right? So when we talked about tumor suppressor earlier, so these are all tumor suppressors. And then one more. Yes, question? Go ahead, questions?
What was 840?
814 is Burkitt's lymphoma. Another question?
Lisa, what is a TSG?
Tumor suppressor genes.
Okay,
So these three, HER2, BRCA, those are tumor suppressor genes. And when they are inactivated, breast cancer, for breast cancer. Okay. And the last slide, these are the bugs. Okay. So Clonarchus. Clonarchus, which one? Bile duct, right? Cholangio. Cholangio. Strep bovis. Yeah, and Clostridium septicum, both of these are colon. Schistosoma mansoni, liver. Hematobium, bladder. Helicobacter. Gastric, adeno, and multiple lymphoma. Okay. HIV. So HIV basically, it's a more association. HIV, they develop non-Hodgkin's lymphoma. And in HIV patients, they're also at a risk for HHV8, herpes virus 8, that leads to Kaposi's. Okay. HTLV, T cell, leukemia, or lymphoma. Hep B and C, liver. HPV, and then finally EBV. It's got Burkitt's, got nasal, pharyngeal, and a primary CNS lymphoma, so brain. Okay, and there's one missing. What's missing? Which one's missing that we talked about? Bonus points. Which in this list? Ah, there we go. And Allah for love, and that's it. No, we don't. Not too bad. 15 minutes. I have to go too fast. I just start 7 hours. Do this. No, he's probably going to discontinue going with the problem. No. So he just goes in order, Usually he kind of goes slow, so it kind of falls in. Wait, that's a plan. Yeah, John said he knows yesterday. Oh, is it? And he's still. If there's no, after we can just get. Yeah, it's like running. One of these things. Still have 45 minutes. Yeah, you can reschedule if it goes past 15. All right.
Excuse me.
Yes.
Yes, please. Primary CNS and primary CNS lymphoma. Is it under which one?
EBV.
Okay,
Epstein-Barr virus.
okay. Oh, okay.
Yes.
There's your pancreas cancer. When we were talking about pancreas cancer, you said that there was one type of cancer that had mucin. That's another type of cancer besides adenocarcinoma cancer, right?
No, it's adenocarcinoma, but it's mucinous.
Mucinous.
Yeah, it's still the same. There's only one cancer in the pancreas. It's just pancreatic
But
adenocarcinoma.
there's like a lot of subtypes of adenocarcinoma besides mucinous.
No.
Just mucinous.
Yeah, I mean, there might be, but I just know that adenocarcinoma is a mucinous cancer. It makes, because it's pancreas, right? So it has enzymes, so it makes a lot of mucin.
Okay, and that one causes the bleeding, right?
Clotting.
Alright. But it was because the mucin
Makes the platelets stick to each other.
and how does that affect the clotting factor?
Not clotting factors, platelet plug. Oops, sorry, platelet plug is a clot.
Oh, all right. Thanks.
Fanta, you have a question?
Yes, I do. I had a quick question regarding the breast cancer and metastasis to the bone. I think you mentioned that most of the lesions are osteoblastic, and I just want to make sure, does that mean that there's bone formation when it
Yeah, there is bone
metastasizes to the
formation.
bone?
Yes, it is bone formation. So osteoblastic means there's more bone being formed. Osteoclastic means you're destroying bones. When you say osteoblastic lesions on the X-ray, they look darker, like you have patches of, like excess bone deposits.
Okay, so that's what we'll see in most cases of breast cancer met to the bone.
Correct.
Okay, thank you.
Sure.
Bye-bye, please. Let's go.
Okay. Have a good evening.
I just have a question. So is it possible we could get these slides? Because they're different than the ones that are online, and there's certain slides on here that have slightly more information. Like I guess I'm referring mainly to the tables, which I like because they help me organize.
Okay.
So there's a lot of stuff we had to like fill in.
I don't think they use those slides anymore. I have the slides, so I can give it to you, send it to you.
Is that okay?
Yeah, that's fine. I mean, it's the same thing, but maybe organized a little differently.
Yeah, literally, I wanted to.
But I'm just used to teaching with these. Not the, I haven't seen the newer slides yet, so that's why I just use this to keep it nice and quick and organized in my head too.
Some of them don't have like the treatment on it. Because I was looking at the older slides, or I guess not the older slides, because I guess the ones we have are the newer ones.
You don't have, they don't have treatment?
Some of them don't. Not, it's not.
But
like
it's on
that.
here?
Yes.
Oh, okay. Yeah, no, I can send it to you. Just give me your email address.
Okay, yeah.
Actually, my email is tura11@passprogram.net. Okay. So just send me an email. So it's easy to remember. 11.
Read it.
Yeah, I mean, good. Oh, if I would go.
No, I was thinking about